faculty, Dr. Ajay, Dr. John Mukhopadhyay, Dr. Samir Agarwal, Dr. Das, Dr. Susut Babulkar, you made it yesterday. It was very, very exciting for everybody. And with this 9th AAOS Trauma Conclave, our objective is to bring a global Indian experts together, and that's what we are trying to achieve over the last 1 decade. We are very passionate when we come with this feast of the medical phase, and we continue to do so in the future with your support. Thank you so much, and we look forward for the next 2 days. And Dr. Mandeep, I'll request you that please cooperate. Look at that, but everybody is excited to see you all. Thank you. Okay.
As many things have been said by Mr. Sunil about Dr. Mandeep Dhillon, he is our program director since the inception of this program. So now he has been instrumental in getting the agenda, the speakers, the learning objectives behind the trauma conclave over years. So thank you, Dr. Mandeep Dhillon, for being program director. Now I request Dr. Mandeep to come on stage and share his few words related to the event.
Thank you, guys. I don't see all of you here, and that's why Sunil was saying that I pull up a few socks, so I will be doing it today. Good morning to those of you who are with us, and maybe a late good night to those who are not. I have this idea of doing this trauma conclave was conceptualized by Sunil and the Insignia team, and with a lot of inputs from the American Academy. And this was started way back, I think Ram remembers, when he was the president of the IOA and I was there, and much before that time. And we thought we'd do something which would be of academic interest to both the American Academy as well as to the Indian orthopedic surgeons. And the first one was a little in the sense that the people who used to come from the US never really knew the level of knowledge which was there in the Indian surgeons. So they brought in a bit of a basic kind of talks, and they were quite surprised to find that even the Indians knew a bit about orthopedics. But from the next one on, with the graciousness of the American surgeons and the goodwill of the Indian faculty, who we handpicked, because we know everybody here is the best in their field, to give the talks, we've had a great mixture of what can be done in the best of hands and with the best facilities, and sometimes what can be done even when the best of facilities are not available. So today, over the next so-called maybe 1.5 days, you will see a mix. You will see this is the ideal method of doing it. And then you will see, oh, this is a bad case, somebody did it wrong, and what could we do it? So when you go away from here, your knowledge of managing trauma would be comprehensive. We can't teach you everything, but we would like you to look at the cases which are discussed, and we've left ample time. We make sure there's ample time for question hour, 15 minutes after every session. And the chairman have been instructed to maybe make a point while the two speakers are changing. We will save that minute also by having a little bit of discussion. So this is the theme. We are here to educate ourselves till 5:30. After that, I don't care what you do, which pool you go to, which beach you go to, which nightclub you go to. But at 5:30, the aim is we teach each other. And I thank you for being here.
Thanks, Dr. Mandeep Dhillon. Now I would request Dr. Brandon Earp to come on the dais and share a few words related to AAOS.
Thank you very much for having us here. We're thrilled to be here. All right, so thank you very much for our program sponsor, Outcome, and also Insignia Learning for organizing yet another great trauma conclave. On behalf of the Academy, we are thrilled to be here. This is our building in Chicago, and if you ever get a chance to visit, it's really nice. About the Academy in the United States, it was founded in 1933 with just 500 members and now has over 39,000. You can see the specialty mix. Trauma, unfortunately, is only 7%, but a very important aspect of that. And we kind of span across a lot of international members. We have surgeons that are in private practice and academic practice as well. There are many different offerings from the Academy in terms of education, and hopefully you'll be interested in taking advantage of some of those. Our annual meeting is coming up in March. If any of you are coming, we would love to connect while you're there. It's going to be in Las Vegas. And then our upcoming 2 meetings are in San Francisco in 2024 and San Diego in 2025. We have a really strong collaboration with India that spans back many, many years. This is the 9th conclave, as you all know, and India was the invited guest nation at our 2017 meeting in San Diego. These are the 4 faculty: myself, Dr. Rich Yoon from New Jersey, Dr. Robert Dunbar from Washington, and Dr. Langford from Orlando, Florida. Our learning objectives are here. And we thank you very much for having us on behalf of the Academy.
Thanks, Dr. Brandon. Now with this, we will begin the program. Our first session is on pelvis and femur. For that, I would like to invite Dr. Gurinder Bedi, who is going to chair this session, on stage. So Dr. Gurinder Bedi is the director and head of department at Fortis Hospital, has interest in deformity corrections, especially fixator-assisted deformity correction, and his area of super specialization are joint replacement, arthroscopy, sports medicine, surgery, and trauma. He has been involved in PG training for a long time, beside being the editor and reviewer for the Journal of Clinical Orthopedics and Trauma and Indian Journal of Orthopedics. With this, I would now hand over the session to Dr. Gurinder Bedi to take it forward.
I'm expected to say a few things. Okay. On behalf of ALCOM, can I welcome all of you? We hope that the next 1.5 days turns out to be a very fruitful and enjoyable thing. Remember, it's a meeting in a resort, so there's a lot of entertainment which is going to be thrown into it. Let's keep the atmosphere very light, but while you're in the hall, let's keep it purely academic as we can make it to be. I do really hope that we have tons of questions thrown at them. Can I just tell the international faculty, trauma to an Indian orthopedic surgeon is like showing a red tag to a bull. So frankly, be ready. You're really going to get a barrage of questions, and I really hope you're good enough to handle them. But let's keep it very, very interactive. There is enough time for the talks, enough time for the questions. If you think we are overshooting on the time, do let us know. We can actually do more questions rather than the talk. So please make sure there is some amount of time left. Again, on behalf of all of us, welcome, and special thanks to Brandon. We really are encouraging more and more women in the Indian orthopedic scenes. In fact, we have sessions this time where we sort of trying to encourage women to participate more. But it does take a woman to manage a hall of 700 odd people. I bet no man can manage 700 women at the same time, but I'm sure you're more than up to it, and I'm sure you'll do very, very well. Lots of hopes in you. Rob, I think you've been here before as well, so you know the local crowd, so I'm sure you'll have a look. And Florida, just like Goa, I take it, no change of scenario for you. New Jersey people, same brown faces, no changes for you as well. I think all of you are really at home out here. Well, nonetheless, okay, let me start off the talks now. So we have this first session on pelvis and femur, and we have 4 speakers. Chitta, you're in the hot seat because you got 2 lectures coming up. The first one is from Richard. Richard, if you can make your way up. You're going to talk about fractures of pelvis and acetabulum in the elderly. Huge problem in our scenario, mainly because of the massive osteoporosis which we see. I think if you look at the figures, we're about 10 years ahead of you guys when it comes to osteoporosis. But let's start with the talk, and if you don't mind, I'm going to interrupt you if the time exceeds. It's just that Professor Dillon is going to have my ass if I don't finish on time.
Of course.
honored to be here today. Let's keep it interactive. And this morning, to start off, we're going to talk about fractures of the pelvis and acetabulum in the elderly. And I'm looking forward to learning how you guys treat these fracture patterns here. And in the U.S., we're kind of figuring out how aggressive we really need to be in order to get our patients up and moving. Here are my disclosures, none relevant to this talk. And really starting off, anything that's starting off with a case is probably going to keep everyone awake. This is an 88-year-old female, status post fall at home, goes to the emergency room. First thing the ER does is get a CT head, which is negative, gets admitted to the medicine service for a urinary tract infection, which they thought it was the cause of the inability to ambulate. I don't know about you guys, this x-ray, that was a spot done in the ER before they called us. I don't see anything other than that pure wick of the Foley that's in there, and really is nothing much there. But she has this pain that's describing kind of going from the lower back to the groin. As we all know, here and around the world, osteoporosis is a severe problem and always will be. 200 million people worldwide. In the U.S., 44 million with osteoporosis or osteopenia. And really, when it comes to osteoporotic fractures, there's a significant amount of fractures that are consistent, especially when it comes to the hip fractures. Why are hip fractures so important? The WHO led this as an education, prevention, and treatment protocol. Our own AAOS has its own Own the Roan program to kind of get orthopedic surgeons to refer patients out to specialists to help prevent osteoporosis with medications, just like Forteo and Dinospan, which we learned about from our sponsors yesterday. And hip fractures are important because when someone comes in with a hip fracture, as we all know, this is something that is associated with a high morbidity and mortality rate. That's why, other than our interventions, obviously calcium, vitamin D, bisphosphonates, rank ligand inhibitors, teriparatide, how are we doing in preventing them with these medications? Our colleagues at the University of Pennsylvania kind of did this longitudinal epidemiologic study. As over the years, our treatment of hip fractures has gotten improved, so the incidence has decreased. However, what we've seen concomitantly is an increase in geriatric pelvic fractures, increase in geriatric acetabular fractures, as well as an increase in subtrochanteric fractures, which is likely associated with atypical long-term use of bisphosphonates. Over in Europe, I think they've done a better job of looking at geriatric pelvic fractures. These are all the kind of literature that's come out that shows that this increase in pelvic fractures in the elderly, possibly due to the fact that patients are healthier, living longer, an aging population, also concomitant with the improving imaging that's been available, including CT and MRI. So really, what's the difference between a high energy and a low energy fragility fracture? When it comes down to it, the elderly have a low reserve. The fragility fractures, as we all know, fall from seating or standing position. Oftentimes, patients can't really recall the events. And with the high level of medical comorbidities, this is something that continues to be a problem as patients are living longer and become more frail, but also as they consistently want to be more independent. In contrast to high energy injuries, these initial fragility fractures are hemodynamically stable. However, subtle continuous bleeding, especially from the posterior venous plexus, you can lose up to 1.5 units over 4 days in the retroperitoneum. Oftentimes, as I'm sure it occurs here with the advent of Xarelto and Eliquis and other anticoagulants, this just increases that bleeding risk even from a low standing fall. So why are these fractures so different? This is a study from across the pond. Dr. Romans has really done a significant amount of work looking at the biomechanics and how fragility fractures of the sacrum are different from low energy people. And what one of the studies she's shown is that over time, the lateral mass in the area that's colored here, this is where elderly patients lose their bone mass in osteoporosis. So when it comes down to it, the severe loss of the lateral mass lateral to the foramen, this affects the overall loading biomechanics in the posterior aspect of the pelvis and really changes the biomechanics of what happens in the bone. So in a follow-up study here, this is a stationary model, a walking model, and then what happens in an insufficiency fracture in the posterior aspect of the sacrum that occurs through the ala and not the foramen. These are kind of an FEA finite element analysis that looks at when you have a stationary fragility fracture, whether it's from a fall or just overall insufficiency due to a really bad osteoporotic T-score, patients in general, when they're not moving, will have this low back pain. When they try and get up and walk and they load, they're going to have this pain that characteristically goes from the SI joints around to the groin. And if you keep walking on this pattern even without a fall, it completes kind of an insufficiency H pattern, which leads to the inclination that we might need a different classification system. The sacral fractures you see on the left is what you typically see in younger folks, fractures that occur in the lateral aspect or through the foramen. But on the right side, you see here that it's really different when it comes to insufficiency fractures of the elderly patients. So really when you come down to it is, do you need a separate classification? This is a study from 2019 in the Journal of Orthopedic Trauma, specific to pelvic fragility fractures in the elderly. Over 245 patients over 65 years old admitted for pelvic fracture fragility. What they looked at, and this is only based on X-ray and CT, because at this time the MRI wasn't acutely available to help classify these. They came up with 4 types of fractures in the elderly. Type 1 is slight, really with anterior pelvic ring involvement. Type 2 is a moderate with non-displaced posterior aspect of the ring. And type 3 and 4 are really the ones that are displaced when they come in. This is about 17.5%. And this is one that patients kind of come in. After a fall, they get an X-ray, CT, they get up and walk. We know these type are 10 and 20%. These are the ones that are probably have to go to the OR anyway due to the level of displacement. And this is probably the greatest group, the type 2s, but really this is the question really where type 1s we're going to treat non-op 100% of the time. 3 and 4 we're going to try and operate on. And when it comes to type 2s, we really don't know what to do yet. And this is where I want to focus, where we want to be a little bit more aggressive with this specific clinical presentation. So I'm interested to learn how type 2s are treated here, but the way I was taught is when grandma falls, we get an AP pelvis, inlet outlet, usually a CT scan, right? Non-displaced posterior aspect. We have them get up and walk. We get post-ambulation films, and if it doesn't walk, if it doesn't displace, we kind of send them to a rehab center and we get them home after a few weeks. But really, there's a subset of these patients that in this old school non-op kind of thinking is based on their clinical presentation, who should we actually be indicating for percutaneous SI screws to help stabilize the back, help kind of mitigate that initial pain and get them up and out of bed. What happens when you leave these type 2 fractures alone? Another longitudinal study here, low energy pelvic fractures over 70 years old in a comparison to age-matched femoral neck fracture population. In over 200 patients here over 70, the 30-day mortality, if you treat them non-op, is still 7.3%. At 90 days, it's 11.4%. So really, the disturbing part about this is that the incidence of morbidity and mortality in these low energy fracture patients that we usually treat non-operatively is the same as hip fracture patients, which is kind of alarming. So really when it comes to surgical stabilization for the type 2s is should we be fixing these in order to get patients up and mobilized in order to decrease these morbidity and mortality? This is kind of an attempt at that at our friends over in Texas and in Missouri by Corey Collins and Brett Christ. All of us who treat these fractures in osteoporotic patients, we've seen these fractures at 6 weeks, 3 months, 6 months. We've seen these 6'5" screws kind of wiggle and kind of back out, and we're praying that they heal before the screws completely fail. In an attempt to kind of buttress and improve that kind of biomechanical stability in the back, Corey and Brett did this longitudinal study looking at rebar or adding calcium phosphate cement to the back of the sacrum to help really try and improve that biomechanical stability. Biomechanically, they showed that by supplementing with calcium phosphate, you have a 400% increase in screw pull-out strength. Pain scores improved from 7.9 down to 3.5, both post-op and at 1 year final follow-up. 41 patients, 16 were treated operatively, 25 non-op. Decrease in pain scale, 100% were able to ambulate. A weight bearing is tolerated after surgery. And really the improvements we like to see is a decreased length of stay in the hospital, increased immediate ambulation distance, and more importantly, especially in the US, as we get more and more concerned with cost of care, over 75% were discharged home compared to going to a subacute nursing home facility with no complications. I personally am a little bit wary of injecting calcium phosphate in the back. However, this study alone was only with percutaneous screw fixation, and this is kind of encouraging, which leads to the question of should we be more aggressive in treating these patients? So back to our case, patient's 88 again, gets admitted to medicine, UTI is treated. This patient still had back pain, still hadn't called ortho yet. They got bottom of it. They saw a old L1 compression fracture, but at the bottom of the CT scan, they called us when they saw a possible sacrum fracture there. Again, inlet, outlet. I don't know if you guys see anything from the audience. Certainly, this is very unimpressive, non-displaced. I mean, the only thing I do notice is that the consistency of the bone looks almost as dense as the bowel gas that's available there. CT here on the first run through. I don't know if you see anything, but on my first pass, really nothing really that impressive here as you're rolling through. But if you look a little bit closely, there are certain things that in these CAT scans that I've learned to kind of look for. You have these insufficiency fractures again through the lateral aspect of the sacrum, incomplete non-displaced fractures. And what this kind of clinically correlates to is this symptomatic presentation in the hospital bed that I think that we used to ignore before, just stating that grandma's old, she might be demented, she's not really giving a story that she's going to heal reliably. But remember, if you go back to the FEA models and biomechanical studies, when she's stationary in bed, she has back pain. Even when she tries to sit up with PT, it's difficult for her to sit up, even swing her legs around. And then, God forbid, when they start walking, they have this excruciating pain that goes to their back around to the groin. And this has been characteristic. When I first started my practice, my chairman and my senior partner, he was very aggressive in treating these because he saw this clinical pattern. I kind of thought he was crazy and being a little bit overly aggressive. And he challenged me to try it once or twice, especially when they have this clinical presentation. And it's amazing how well they do even in the PACU. Stabilizing these fragility fractures will help them kind of mobilize and get that stability. And after I saw the first one, this is something that we look out for very significantly. This is a unique case with a newer implant in the US that we're participating in a randomized trial for. But this is someone that indicated that she failed physical therapy and had that characteristic clinical presentation. Bilateral PERC S1 screws, a transsacral transiliac S2 screw here. Really, weight bearing is tolerated with a walker. Post-op day 0, she walked 40 feet with a walker, and before that, she couldn't get out of bed. Post-op day 1, 80 feet with a walker, and a post-op day 2, discharged to a nursing home. And really, the only reason why she went to a nursing home is because she lived on the 3rd floor of an apartment building. She had no family to really take care of her, and that's why she went there before she could be discharged home safely. This is a 3-week follow-up. She lived about 2.5 hours from me, South Jersey. I recently saw her back at 1.5-year follow-up. Refused to come in and get x-rays, but on a phone interview, she was doing really well. So when it comes down to geriatric pelvic fractures in our institution, type 1s are automatically non-op. If it's just an anterior ring involvement with no back pain, they're going to do just fine. 3s and 4s are going to be operative off the bat. We're going to have to do tips and tricks to treat those. But for the type 2s, which are the most common, if they have that characteristic kind of back pain, if they have difficulty sitting up, getting out of bed, when we trial non-operative surgery, we offer surgery. And more oftentimes than not, when we put these percutaneous SI screw in, which is a very simple procedure, does not take a long time, allowing them to weight bear immediately, they can get up and walk. So what about geriatric acetabular fractures? Again, let's start with the case. 71-year-old female, fall down 2 steps. Only past medical history is hypertension. She's probably healthier than me at her age. Still a community ambulator, works as a receptionist at her husband's dental office, loves to travel with her husband. No previous hip pain or issues. And as you can see here with this kind of both column variant here, what is the right way to do it? And traditionally we're taught to kind of fix or replace, and that's really the question when it comes down to being more aggressive with these patients, because if you're only going to fix it, you may not be doing them a justice, because most of us in the US are not going to allow them to weight bear as tolerated right away, but if you fix and replace, you can also do that. Again, why is this important, right? For lower extremity fractures, we're getting more and more aggressive at weight bearing, even with articular involvement. And this is important to reduce and minimize morbidity and mortality, adhering to stable, reliable construct in the lower extremity to get them up, moving, mobilizing. Not that they're going to start doing laps around the hospital ward, but getting them up and moving is going to be the most reliable thing to prevent UTI, pneumonia, DVT, PE, and all those things we worry about with our hip fracture population. Geriatric fractures of the acetabulum are no different than hip fractures. Again, that morbidity and mortality still very high, and our goal is to get a stable, reliable construct to get them up and moving right away. And really for me, in my practice, as well as a lot of my colleagues who have the same kind of thinking, is kind of trying to avoid that second operation down the line. So really, the question we have to ask is who gets fixed and replaced, and really is it better to do ORIF alone or kind of go the extra step and do an acute total hip in the same setting? When we answer those questions, we got to look at the outcomes of the ORIF alone in the elderly. This is a study, an injury in 2013, 59 patients. This is one that looked at basically non-anatomical reduction of the acetabulum. It was over 29%. And the harbingers of a poor prognosis is when you have dome impaction or the gull wing sign. And really here, if you had these two aspects on your preoperative CT, the odds ratio, the conversion to a total hip arthroplasty within 1 year was almost a 25% risk of getting that done. So that's what I mean by avoiding that second surgery when it comes in. Study out of shock trauma in 2014, they compared 46 patients that are ORIF versus non-op and PERC. The ORIF patients alone, 28% of them were converted to total hip within 2.5 years. Another study here out of Harvard by Mark Veris when he was there at that time, looking at ORIF versus total hip, 33 versus 37 patients, 30% higher operation rate in the ORIF group, worse Harris hip scores and patient-reported outcomes in the ORIF group, and really the conversion rate, again, 21% of these patients who were fixed were converted over to total hip within 1.5 years. Another study here in Journal of Arthroplasty looking at the Canadian National Database, looking at over 1,700 patients under the age of 60 and over the age of 60. The conversion rate, even if you were young, and under 60 is young, 12.9% versus 19%. So these things, if you fix them alone, conversion rate and having a second surgery within 1 to 2 years is not insignificant. Another study out of Europe in systematic review, patients over 55, over 3,000 patients, almost 14. Pooled data here showed that 15% of these patients get converted to total hip within 2 years. So really, how do we avoid the conversion? And some earlier literature, which a lot of my residents ignore because they don't really like to go back that far when they read the papers. Dr. Dana Mears, this is almost 20 years ago now. He was, when he presented this paper at the Academy, they were kind of throwing eggs and thought he was crazy, but looking at his results, looking at specific aspects of geriatric acetabular fractures, he said that basically if there's a poor prognosis, and in his paper, part of that was marginal impaction, or really your ability to get an anatomic reduction or not do it, really those are going to be the prognostic factors that led him to do an acute total hip in the same setting, allowing the weight bearers tolerated right away, and then really improving these results for the patients, and then avoiding that second surgery. So what are those specific poor prognostic factors? Jeff Anglin, this is a paper out of 2003, looked at 48 papers, characterizing this gull wing sign. If you have any sign of this supremedial dome impaction, marginal impaction, this is something that's specifically predictive of failure of the ORIF, and is going to be almost 25% risk of getting converted to a total hip very, very quickly. This is something that is consistent through the literature now as we look for it. If you have these, we can get consistent results. You can weight bear early right away, the better outcomes over fixation, better than delayed THA at this junction too, low complication rates and a low reoperation rate when compared to ORIF alone. Are there any other potential benefits? In our institution, where we're very aggressive on this, we looked at our patients so far. We have about 44 total, looking at 30 that were fixed and replaced versus ORIF alone. Lower length of stay, almost 7-day reduction in length of stay for our fixed and replaced patients, and a significantly higher rate of patients going home, which our administration loves, and no difference in complication rates. So even in our institution, as we're getting more and more aggressive, we're going into an acute total hip. These are the aspects of our care that we want to kind of improve by lowering the morbidity and mortality, getting them up and walking, and at the same time, really decreasing the cost of care and length of stay. So how did our patient do? Back to our case. This is someone that we, on the CAT scan, looking for. She had the gull wing sign, signs of marginal impaction. In my hands, maybe some of you are probably better than me at doing this and fixing, but I was confident that I could probably get most of it, but with this kind of level of comminution and superior medial dome indicated for a fix or replace. We started supine first, did a modified stoppa, restored the anterior column, added a 7-plate for the quadrilateral buttress. We flipped her prone, lateral now. I think now I would probably do this on an off table and probably do a direct anterior just to avoid that conversion, but this is about 4 or 5 years ago. Did a cochlear longovac, fixed the posterior column to back it up, and then did an acute total hip. Made her weight bearing as tolerant right away with a walker. She went home with services on post-op day 4. 6 weeks, only using a cane for balance. She was already asking me to see if she can go back to work as a receptionist. 4 months back to work because I was chicken. I didn't want her to let it go back right away. I learned later that she was already driving around week 8, which is terrified me when she told me that she actually did it. This is her at 1 year doing well, well-fixed components, no drift, no signs of loosening here. 4 years recently doing well. Just got back from, I think, she went to South Africa safari with her husband, doing very well. So take-home points here, when we're talking about geriatric pelvic fractures, the incidence of these are getting worse. Insufficiency fractures, not even without a fall, are very, very common. The characteristic back pain or back pain in the groin with the inability to sit up and get out of bed, I think is a harbinger for poor prognosis, and those are the patients that we offer percutaneous stabilization to in order to decrease length of stay and improve morbidity and mortality. Similarly with the geriatric acetabular fractures, if there's any sign of marginal impaction or things that are going to be really hard to get through, and that includes the gull-wing sign, marginal impaction, any kind of femoral head involvement, severe comminution, these are the ones that we're going to recommend acutely doing a total hip at the same time. Again, weight bearing is tolerated, getting them up and moving, and getting them home and out of the hospital faster. Thank you very much.
Thank you so much, Richard. If I can get you, pull you down to the center, Samir, if you can make your way up. Samir is going to talk about combined fractures of pelvis and acetabulum. We have maybe a little time for one or two burning questions at all. Mandeep. I'll just get you.
A question. I'm not a pelvic surgeon, but I do hip arthroplasty. So if you got a fragility fracture with the fragile acetabulum and you got a plate on it, how comfortable are you in hammering in an uncemented cup?
So the question is...
For the hip arthroplasty, primary arthroplasty.
Yeah.
How do you put a cup in an unstable bony?
If you do a primary fixation in fragility cases, you don't allow them to walk early, do you? But if we are hammering in an acetabular cup, I would, I may be wrong, but in my mind it somehow doesn't gel that much.
No, absolutely. I think that's something that has been a controversial point. However, that's why restoring your columns is going to be really important to get that. If you have appropriate fixation with the anterior and posterior columns, putting a press fit cup actually is not that much different than doing it normally. So
Richard doesn't know how to do a cemented cup.
I have not tried that, but for a cementless cup, usually what I do is I kind of under ream by 2, and if you press it and usually use a revision cup for extra screw fixation, it really isn't an issue. You can get appropriate version. Now we have dual mobility to help prevent the dislocation rates as well. It really hasn't been an issue in my hands.
Okay, wonderful. I think that's can I just remind everyone, there is time for questions at the end of it. So we'll have all the speakers at the top at the end of it. So hold on to your questions. In fact, write them down. You got these lovely notebooks with you. You can write down the questions, and wonderful talk. Richard, I would love to get that fellowship in NYU next time when I'm around.
Thank you. First of all, I would like to thank AAOS and the organizers to invite me to share my experience, the management of combined pelvic ring and external injuries.
Sorry, Samir, can I just interrupt? Sorry, I think all of you do know Samir. I mean, Samir's been around the trauma circuit for such a long time. Professor at PGI, runs a huge level 1 trauma center. We've seen him in loads of meetings, and I think all of you are familiar with some of the excellent work that he's done. He's also managed organizations like the Indian Arthroplasty Association, been involved with AO Trauma for a very, very long time, lecturing on all the trauma circuits. We've taught together on so many of these AO courses. Samir, thank you so much, and I'm sorry I kept you back.
Thank you, doctor. So, by definition, pelvic ring injuries that require surgical intervention independent of that is needed to achieve the acetabular fracture fixation should be considered combined injuries. What is these combined injuries? You see this fracture? There's a pelvic fracture. Yes, there's no doubt. But whether it's a astral fracture, you have to see. It's a pubic rami fracture high, or it's a low anterior wall, but it needs no fixation. So it's not a combined pelvic astral injuries. Another case, everybody says there's acetabular fractures. It's a gray area. You can see there is extension into SI joint, or there is astral fracture extension. So it is a gray area. But what is true when both acetabulum and pelvic need surgical interventions? Like in this case, there's a pelvic fracture, there's a acetabulum fracture, there's a fracture here also, and all needs fixation. These are called combined pelvic astral fractures. Incidents, if you see this paper, out of 1,334 patients, the incident he has reported TIPS in 2008, 14.1%. But another paper by Osgood, he says only 5% of 854 pelvic fractures and 9% of his 457 patient astral fractures has combined injuries. So why there's a wide variation? 5%, some papers say 14%. So it is maybe because there's lack of uniform definition of what constitutes a combined injuries. People are confused to call it a combined injury, or is a pelvic injury, or is a acetabulum injuries. Common publication bias to excluding these combined injuries. If I'm writing a paper on a pelvic injuries, I try to exclude these fractures sometimes. So what is the mechanism? Whenever there's a lateral compression injuries, the impact of the head of femur is the acetabulum. That leads to fracture of the acetabulum, which can be a transverse fracture or a T-type fracture. The further forces, if it is there on the lateral side, it leads to the contralateral injury to the SI joint, and there's a combined pelvic astral injuries. If your forces are vertical, it may lead to, again, T-type fractures, and continuous forces, ipsilateral pelvic astral fracture is there. This is a combined injuries. So you have to see, whenever you see a fracture acetabulum, always try to see the other side. You may find some displacement in the SI joint or injury in the iliac bone. So significant energy is involved in these fractures. These are high velocity injuries. Another mechanism, whenever there is a posterior directed forces, it may lead to fracture of the acetabulum, and the further forces lead to the opening of APC type 3. You can see there is an opening, and APC type C. So in these injuries, the commonest astral fractures in combined injuries can be either transverse or T-type, and the commonest fracture of the pelvis is APC type 2 or 3. You remember this is high energy trauma, so all patients have polytraumatized, and they are expected to have a high injury severity scores. Greater transfusion hours are required, and lower systolic blood pressure is there, so you have to manage them aggressively. The management, again, emergency management, and then we talk about the definite management. Emergency management, you have to identify the life-threatening injuries. They should be advanced, and as per the ATLS protocols, you should try to manage the patient and try to save this unstable patient to make them stable. And you should take the help of multidisciplinary team. It's a team efforts, you can save these patients. Hemodynamic unstable patient with combined injury present unique treatment dilemma. Whenever a patient of pelvic comes, it is told that you should use a binder. But in this, use of binder, sheet, or fixator may cause some problems. It may cause malreduction of the acetabulum fracture whenever there is a medial dislocated femoral head is there. If you use a fixator, chances are pin track infection is there, and you will be able to have infection when you are operating on a acetabulum. So combined with associated posterior hip dislocation, you try to reduce it, but you must remember that there's inadequate because that pelvic may be floating on at the SI joints. So your pull may not be sufficient to reduce these fractures. You have to remember these things while managing these fractures. The definite management is you have to need fixation of pelvis and restoration of the acetabular anatomy, and to have a stable patient. That is your aim of treatment. Pelvic injuries can be more likely to be life-threatening, as know you that acetabulum fractures are not life-threatening but pelvic injuries. So it may be appropriate to stabilize pelvic ring injuries first, followed by staging of the astral fractures. And the surgical timing management of combined injury should be performed according to patient physiology, whether patient is stable, unstable, general status, and what are the associated injuries. You should plan it. It should be done as early as possible because the astral fractures you can do within 2 weeks, then you have a better results. Early treatment of pelvic and astral injuries is associated with low rate of pulmonary complication, less organ failures, shorter hospital stay, fewer transfusions, no difference in blood loss, reduced mortality is there. As every case, you have to have preoperative planning is very critical in these cases because of polytrauma. You should plan your imaging accordingly. What should be the patient position? What is your surgical approach? Because you are treating 2 fractures during one surgery. And what should be the order of fixation? Whenever possible, surgical approach should be a single approach. It allows surgeons to deal with both the pelvic and astral fractures and enables fine-tuning and manipulation of anatomy to improve the over alignment with a single incision. Ilioinguinal approach is used to fix both SA joint anteriorly. You can fix the SA joint posteriorly and astral fractures in most of the cases. And remember that it can reduce the surgical duration in high-risk patient if you're using by a single approach. Order of fixation, surgical reduction of astral significantly correlate to the residual posterior pelvic displacement. So therefore, initially accurate reduction of posterior pelvic lesion must be performed. So in most of the cases, pelvic fracture should be treated first, then you'd look for the acetabulum fractures. The dictum is fixation should proceed from posterior to anterior and from lateral to medial. Fixation of posterior pelvic can be either open or percutaneous. Is advisable to provide stable construct so that fixation of acetabulum can proceed in these cases. This is a case of combined injury. You can see there, and if you see there is a transverse fracture and fracture through the sacrum. You can do it openly or you can do it percutaneously. After fixing your pelvis, SA joint, you can put a percutaneously ischio-ilial screw. Like in this case, we have put a guide wire, and the excellent reduction has been achieved. And this is a post-op X-rays. You can have, only with percutaneous fixation, you are able to treat both the cases, and there's no need for open reduction in these cases. Another case, 34 years, blunt trauma abdomen, associated both column, lateral compression type 2 injuries. If you see, it is impossible to fix the acetabulum without addressing the pelvis, so you have to fix the pelvis. Now you have to decide about your approach, what should be the patient position. You want to fix first pelvis, then you want to fix a transverse fracture of the acetabulum. Either go anteriorly or posteriorly, you have to decide. And in this case, we have done a floppy lateral position, keeping in mind we may have to go posteriorly. We used iliofemoral approach, pelvis was reduced and fixed. Then we tried to fix the acetabulum with a posterior column screw, and we were able to achieve the reduction. So there was no need to go posteriorly, and we are able to fix this. Excellent results. Another case, acetabulum fracture with SA joint disruption. Can you reduce this pelvis? Because this fragment is now locked. In this case, you have to plan otherwise. You have to reduce the acetabulum first, then you can only reduce this SA joint. So case to case basis, you have to decide. We went inside, we fix it, the acetabulum first, then we have to put a sacroiliac screw, and the reduction, absolute reduction is there. So 90% cases, you should fix the pelvis first, but in few cases, depending on the anatomy of the acetabulum, you have to change the plan on the table or when it is locked or something. Another case is a polytrauma case, 23-year female. Ipsilateral neck of femur, associated both column, L2 type 2 injury, everything has to be fixed. So what should be the sequence? You have to plan. Can you leave the neck of femur? No. First, this is was done in this case. First, we have fixed the neck of femur, and then we fix the posterior pelvic ring, and then the acetabulum by both anterior and posterior approach, and this is the results and patient. Another case, difficult to see in X-ray, We went for the CT, and you can see there's a bilateral posterior pelvic ring injuries. On one side it is crescent fracture, other side is a sacrum, which is right zone 2 and 3. There's a double segmental anterior column fracture with tilt of the fracture, and you have to treat each and everything. So we went inside. We first treated the left crescent fracture with recon plate. Then iliac wing fixation was done. And from the same approach, we are able to fix the anterior column fracture. And now we try to reduce the tilt, and we are able to fix the pubic symphysis by the same plate, and right-sided SI joint type 2 injuries were fixed with a post-tension band plate. And this is the results. So in a single stage, we are able to fix both pelvic fracture, sternum fracture, and we got the excellent result. The sternum is contoured. So these injuries are very particular about that, how to measure the outcome. There's no combined method that we can measure the outcomes of these. So independently, pelvic scoring and sternum scoring has to be done. Among the two injuries, patient outcome is more closely related to the accurate reduction of the sternal component of the injuries, because it's a intra-articular fractures. Pelvis provide stability, and mortality is more in pelvic fractures, but the results are dependent upon the sternal fractures. So one should do. Panel et al. Reported that these combined injuries has not a good results. Why? He enumerated that it may be because of the poor sternal reconstruction, because your energy is wasted first on the management of these patients, then pelvic fractures, the sternal fracture is done last, so sometimes the poor reduction is there. Because of the exposures, there may be severe hypertrophic ossifications, there may be shedding nerve palsy, or prolonged surgery may lead to the infections. So one should remember that one should understand the mechanism of injury. Appropriate preoperative planning is must in these combined cases. The aim is to have a stable pelvic ring and a anatomically reduced acetabulum. Outcomes are relatively definitely poor than pure pelvic injury or acetabulum injury. Thank you.
Thank you so much, Samir. Wonderful as always, and wow. The x-rays that you showed were absolutely awesome. Chitta, if you can make your way up. Guys, Asim is here. Can I just change the rules of the game a little bit? So what we're going to do is, after every lecture, I'm going to come across you randomly and ask you 2 take-home points. So it could be anyone out there. I'm just going to thrust the mic into your face just to see, every end of lecture, you should have 2 points which you picked up. I think, okay, any quick question for Samir while Chitta's just setting up his presentation? Chief.
You get a lot of heterotopic ossification. I don't know how many cases you got. Do you do anything prophylactically? And if you give indomethacin, after 6 weeks, if you stop, does it happen?
Now, normally in these cases where we are going, we go for indomethacin basically. We don't go for the radiotherapy radiation. 6 weeks. After that, we have to wait for some time to see the alkaline phosphates level, and we have to exercise. Because after 6 weeks, I think so indomethacin don't work, no radiation will work. So you have to see whether it is going to mature, how much it is going to affect the clinically. If it is effective clinically, we see for the alkaline phosphate level. Once they are stable, we surgically remove these hypertrophic ossifications.
Yeah, so Guru and Samir, the 2 points that I can take home is, first of all, these combined injuries of pelvic and acetabulum fractures are very complex and challenging fractures. He also told us about how to approach them, how to fix the pelvis first, then the acetabulum, in most of the cases. The outcomes are, of course, many times unpredictable, and of course, they require a long-term kind of proper follow-up. We cannot just think about doing a weight bearing immediately in many of the cases, but we should hold on to weight bearing in cases.
Thank you so much, guys. So next time I'm going to thrust a mic into one of your faces. So nobody goes off to sleep out here. Get those 2 points. I'm going to come to you next time. Samir, okay, Chitta's a good old friend. I mean, he's been around for a very long time, especially on the AO pelvic courses. I think all of you who attended the courses have seen Chitta's wonderful lectures and teachings that he's done. So we've called him here, and even he's got a video as well to show us about his surgical approaches. Yes. So he's been around in Cuttack for a very long time. You run your own center. Am I right when I say that? And you've got some lovely courses running. If you have not attended the Oscar course, which Chitta does, in which he picks up on one topic and actually goes through it. So a lot of experience coming from him and a lot of educational achievements as well. So please follow him up for his educational achievements, but also today we talked to him about pelvic fractures.
Thank you, Gurinder. Good morning. I would like to thank Professor Mandip Dhillon for asking me to share my experience on some complex fractures. My special thanks to AAOS and Insignia Learning. I have been speaking on this approach for quite some time. Many of you might have seen it, but my first talk is on an appeal and second talk is on a complex fractures. So if you know that with the classical approaches which were designed for operating on fracture acetabulum were these 3 fractures, and the first one is the posterior approach and the second one is the anterior approach, third one is the extensile approach. This approach has initially gained a lot of popularity and is just now in the horizon to disappear. And we'd find out what's the truth behind this. If you look at the current AO reference on this approach, this is very specifically mentioned that this approach may be used to achieve reductions which are otherwise impossible. There are quite a few fractures which are very difficult to reduce, and this is the approach which you should use. This is from the AO reference. I was in the Litonel course in Lucerne in 2015, and this is a cadaveric dissection by Dr. Joel Mata. He spent half a day explaining why we should do it right. That is not long ago, that is in 2015. The current status, this is being taught in the AO trauma courses in AAOS. Litonel courses, of course, they have stopped now. AO North American Advanced Pelvis Acetabular course, all AO master courses globally, and all the textbooks write a lot about this. But you'll find the journals are silent because nobody is publishing on this, and people are not practicing this approach. So because the complications mentioned in the books have scared the surgeon. If you look at this classification of Litonel, the ones ticked in the black are having simpler answer. You can fix either by the front or by the back approach. But the one in the red, these ones require complex decision. You need to take a decision on which approach you want to fix it. You can either fix it through dual approach, like going from the front and the back, either simultaneous or sequential, or go by the extensile. And the designer, I want to pay tribute to this gentleman, Professor Emily Litonel. I think we have amongst us Dr. Ram Chadha, who had presented long back in Hong Kong, if I remember correctly, before Litonel, and he was very fortunate to see this gentleman. We don't have any knowledge about this, but we read his books. He described in 1964 Cocker-Langenbeck and ilo-inguinal approach, and he found that he could not fix a lot of these fractures because he had to expose, with a single exposure, both the columns. So that's how he came and presented his work in 1974 and developed. It was originally called a lateral approach. Subsequently, it was named as extended iliofemoral approach. And they published a large series of cases, 400 cases. Litonel, Mata, Mast, Mark Raleigh, Keith Mayo, they all published, and they had excellent outcome in complex fractures. These are the specific indications in which this fracture has to be used. So if there are so many indications, why it is not being practiced? Because the primary goal of treatment of this fracture is absolute anatomical articular reduction and restoration of the hip congruity. In complex fractures, achieving this goal seems impossible at times, and the choice of approach remains paramount. EIFA is known to give higher rate of anatomical reduction and higher quality of anatomical reduction, and it can avoid or delay a THR in a complex fracture, which is very important for the young people who are not candidates for having a total hip replacement surgery. This is the observation of Dr. Joel Mata. The beauty of this approach, it allows direct reduction of complex fractures under vision. Look at this fracture. This is a late presentation, 4 weeks, ABC with posterior wall fracture. This is the exposure you get. This is the posterior column, and this is the anterior column exposure. So you can imagine the type of exposure it gives, and you can work on this and reduce the fracture anatomically, and at the end of it, you have a fracture which is well reduced despite late presentation and complexity. So this is the beauty of this approach. This is immediate post-op. If I magnify this X-ray, you will find a congruous hip joint, a well-reduced hip joint. And 6 years down the line, the patient is doing well. Another beauty of this approach is, if you see the intra-articular visualization, like certain transsectal T and transsectal transverse fractures, Dr. Keith Mayo says you put cartilage to cartilage suture. That means it has to be absolutely anatomical, because if you have a small edge in the roof of the acetabulum, the head of the femur would wear out in no time. Look at this case. This is a 45-days-old fracture. The head of the femur is locked in displaced position, transsectal transverse fracture. The CT scan, you can see the head has a small hinge-touch region. And when you expose this fracture, you can do an arthrotomy and watch the reduction under vision. This is the femoral distractor trying to reduce the fracture. And at the same time, when you fix with the screws from the posterior to the front, you also see that there is no ridge at the dome of the acetabulum. So this is a beautiful exposure given by the extensile approach. This is the immediate post-op X-ray, and this is a 10 years follow-up. And patient has done well. Another thing, if you do a malreduction during surgery and you spot in the C-arm, it's very easy. It takes only 10 minutes to undo it. I'll show you when you debride fractures, at maluniting fractures, with the callus, you sometimes take off the normal bones from the edges of the fracture plane. And when you take out those bones and you try to reduce from the periphery to the center by squeezing in the peripheral part, doing an anatomical reduction, you can squeeze the voids and open up the acetabulum. See what happened. This is a case, and when you try to debride this, you are literally removing some normal bones along with the callus. And when you try to reduce this using your powerful tools, peripherally, you see this is what happens. You get an incongruous hip joint. The hip becomes incongruous, and it will start point loading, and the head would wear out. If you see this, this is described by Littonel in 1993. Lack of parallelism in the X-rays is called incongruity. This is the most dangerous thing. You don't want this to see in your cases. So this is the fragment which went missing during your debrima, and when you squeezed in the periphery, the acetabulum opened up in the center, and you got this incongruity. It takes only 10 minutes to undo it. You just remove the implants, use the head of the femur as a template, give due discount to the gaps which you have squeezed, open up, and control in the X-ray, and fix it. Now you have got a congruous hip joint. This is the end result of that fixation. You see there are gaps in the periphery, but the head of the femur is very well reduced in a concentric manner in the congruous hip joint. This is a 10 years post-op. Recently, this gentleman came for a different problem. 15 years, his hip is doing well. So, despite all the big benefits, why this is disappearing from the practice? If you see the 20 years, I did a search in the net. 1994, Keith Mayo published 16% of his cases were doing EIFA. Subsequently, the number started declining, and in 2015, you have nobody doing this approach. This was a webinar under Dr. Joel Mata, soon after the Littonel course, and I happened to know this gentleman who were presenting, and they described all the approaches, did not describe about this particular approach. So why these surgeons are shying away? This was also worried Dr. Joel Mata, and he published in 2005 in JBJS, and he found that this complex fractures is a very versatile approach. Extended approach is effective for treatment of complex acetabular fractures, but he found that since its inception, little information is available to the value of this approach. The surgeons, there is a trend away for the extended iliofemoral approach because concerns over the increasing morbidity. And there is another paper from Central Europe where they said, should the enlarged iliofemoral approach be abandoned? They have done a 20 years follow-up, and they found that this approach gave anatomical reduction and very good long-term results without excessive morbidity. So if you have this data, what is wrong with this approach? Why people are not doing it? This book, latest book, it says the high rate of anatomical reduction and good outcome. At the same time, it says complication rates are higher. Actually, the complication risk is higher, not the rates. So this kind of misinformation has kept the surgeons away from not doing these cases. What it failed to mention whether fractures of similar complexities were treated by the EIFA and the non-extensile approach. It was not done. So it's like comparing an apple with an orange. The main complication which they highlight is HO. It is about 35% using extensile approach. Other complications are like any other surgery. But if you look at the HO, 35% if with the EIFA, if you go by the dual approach, which is the only other approach you have to use for treating complex fractures, you have 28%. That's not a big deal. If you give prophylaxis, your HO is minimized. In my experience, I have done more than 100 cases. I am not worried about extensile approach having heterotopic ossification. I'll show you. This is a case of heterotopic ossification. Complete hip is fused. This gentleman committed suicide taking some. He wanted to commit suicide. He recovered. He had severe heterotopic ossification. The hip was fused. And I operated with using extensile approach. The one on the left you see, this is soon after surgery. I have excised the whole heterotopic ossification, and 2 years down the line, there is no recurrence. So I am convinced if you do EIFA appropriately, I will tell you what is my trick in this. I give relaxing incision. We had a web seminar with Dr. Joel Mata, Keith Mayo, Michelle Oransky, who have large experience in this, and I found their incision was small. If you give a relaxing incision, when you put your levers in the greater sciatic notch, you don't macerate the big muscles, flap. And if you keep on releasing time and again, then you don't really create the macerated muscle mass. If you have any dead and necrotic tissue, you need to remove them completely and wash periodically with normal saline and hydrogen peroxide, remove the bone dust. And I think that's the reason why, you see this particular picture. This is a huge exposure. This exposure has reduced the HO incidence. And you see it's completely clean. At the end of the procedure, you don't find any dirt. So this is probably one of the tricks why you don't have HO. Or maybe the other reason, we are from a different locality. Maybe genetically we are different. We don't have HO. I'll show you some cases. I'll show you two types of cases, less than 3 weeks old, more than 3 weeks old. This is a young girl, had a fall from a big height, type 2 ABC. This is the CT scan, and this is a 3D. And this is the approach which I used, extensile approach, again going into the internal aspect, also adding the fan and steel to that. And you see this, if you look at this particular, this is a fragment. This particular fragment is fixed by 3 screws by 3 plates because you don't want to denude this soft tissue and make it avascular. And grafted the void after checking the reduction in the supraestable area. This is the post day 0, 3 months, and 4 years follow-up. And she is absolutely fine. She can squat, sit cross-legged. She has good abductors, good extensors, good range of movement in the hip joint, no Trendelenburg. Another gentleman, high-speeding taxi driver, day 3, he arrives. He has a dome which is floating, and the fracture ABC is extended, but rest of it was fine. This is the 3 years follow-up Jude view. This was the approach which was used. This is again a young person, comes to me at the end of 16 days. You can see he has a floating fragment on the head of the femur, in the acetabulum over the head of the femur. We need to stabilize that, reduce into the right place, and hold it. This is through the extensile approach. You can see the caving in over the supraacetabular area. This was reduced using the extensile approach. And this is the fragment which was worrisome. And when you jack it out using the large femoral distractor, the fragment falls back to place. And this is the immediate post-op, 10 years. And recently he broke his tibia. I happened to take out his trochanteric screws, his 16 years follow-up. Hip is doing very well. This is a 16 years follow-up, clinical x-rays, clinical view. So this was the initial presentation and at the end of 16 years. Delayed cases, 3 weeks old. This is a lady who was run over by a tractor, had a ruptured bladder, and bladder was repaired. It started leaking. She was subsequently re-explored. So ABC with a posterior wall fracture and really operated for the bladder rupture. And this is what she had. In the back, she has a sacral sore. In the front, she has got a bladder repair. So we had to isolate the area, and you can see this is the head of the femur, which you see here. It was exposed after the extensile approach, and it's the end of the reduction. And she's 3 weeks post-op. The roof, we focused on the roof because we could not do much on the anterior aspect because of the bladder repair. 14 years follow-up. And you can see the hip is doing very well. The congruous hip joint weight-bearing part, and the functional outcome is good. This is at the end of 14 years. She is doing well. This is an engineer who comes to me after 4 weeks. This is the type of ABC fracture, and you can see we did through EIFA, and this was immediate post-op, a congruous hip joint. At the end of 11 years, you see this hip is absolutely congruous, and he has no functional disability. This is his picture, okay? So complex fractures, EIFA, when I did not use patient who had head injury and blunt trauma chest, you can see this was tried to reduce using indirect methods, and this is a collinear reduction forceps which is trying to reduce the fracture posterior column through the lateral modified AIP approach. So the fracture was reduced, but a lot of things were not seen when the fracture reduction was done. So I'll show you, at the end of it, you have a head of the femur, and this is a acetabulum which has got a ridge. So this is not going to last long. However, at the end of 7 years, he's still doing well. It was congruous in the Jude view, but not in the AP view. So take home message, EIFA is already in the oblivion. It's going to be discarded if we don't start using it. Younger patients with complex fractures need this approach because you don't want them to have a THR early. Late presentations in associated types and transtectal transverse fractures remain the best choice is EIFA in my consideration. Complications highlighted need to be revalidated. So my appeal is let us try and revive this approach. Compare the risk and the benefit and do the surgery. Thank you very much.
Chitta, thank you so much. I mean, frankly, those cases are absolutely awesome. I think most of us would not be attempting these kind of things, but wonderful having you on the stage. You want to catch a sip of water because you're on next. Are you okay to do the next, or you want a break? We can actually give you a break. Okay, perfect. Any quick questions, just while he's catching his breath? Any quick questions? It's a very difficult thing. Mandeep.
Can I have his phone number to refer the patients?
I think you really need that.
Thank you.
Sorry,
when you do trochanteric flip osteotomy, in which type of?
I do a complete trochanteric osteotomy. Yeah.
Okay, guys, take-home points. 2 take-home points from the last lecture.
Yeah, my take-home points is that a pelvic injury, this approach is good and versatile, so we try for that.
Okay, that's one.
Yeah, one. And next is that if it required, a reduction of the fragment is more important, and congruency of the acetabulum is an outcome for.
Wonderful, wonderful. Okay, Ram, you're going to say something.
So this question goes to the all the faculty, Richard as well as Samir and Chitta, that do any one of you do 3D printing, before in these complex fractures to understand, or does it really make a difference?
Not so far, but that's a good idea. Not
so we are using it now. We have started it.
It will save a lot of time from templating the implants and all that, yeah.
Okay, any other quick questions?
Doctor, we have started right now. It is a good tool for pre-operative planning also and for teaching also.
Sure.
Yes, sir.
I think that's it. The delayed presentation is a very, very classical indication for getting a 3D. But I think the problem with people like Chitta is one generation ahead. His brain is already drawing out the maps in his mind, so he may not need it, but people like me desperately need every help we can. Anybody else? Very quick questions at all before we start?
We had one other application for that. We've had a few blind patients who are unable to see the images who are refusing surgery, who made the 3D things, and we're able to offer them to palpate these models, and it was worthwhile.
That's a real unique indication, isn't it? Okay, Chitta, your second talk.
Thank you. We'll move on to the next one. I think we had some discussion yesterday evening. Sushruth and I think our AAOS faculties had discussed in detail about some of these complex fractures. So let me see my earlier experience. Actually, I have been doing this for last 25 years, but I have recently found how I could improve the outcome. This is from 2003. This is the fracture, say C-type fracture distal femur. And most of these fractures have a deep graze. When they come to you during the trauma, you find either the patellized fracture or the patellar surface is deeply grazed. you can't operate. You have to wait for some time. And so this kind of fracture, when they come to you, this is what I found. I'm just showing one example. We have done plenty of these cases. I just want to show why I was not happy at the end of this treatment. So this is the fracture, and I went through double plating, which Susruth was telling yesterday. This is double plating, and this is immediate post-op. Patient was mobilized. You can see the gauges over the knee, for which he had to wait for 4 weeks. At the end of it, recently I reviewed him. He has range which is limited. Otherwise, he's okay. Actually, if you can see his x-rays, so no evidence of osteoarthritis yet. He's now, it's about 62, but he has got a range which is limited. So how the outcome can be improved, that's what is my talk. And if you see that we have done a lot of this TARPO, transarticular retrograde plate osteosynthesis, by doing indirect reductions. I am also not very happy with the long-term results. We will be talking about this kind of fracture. This is a current classification from 2018, where the distal femur C-type is fractured. The C-type is complete multifragmentary articular fracture, but the severity increases with combination of the metaphysis. So simple metaphyseal is C1 and multifragmentary metaphyseal is C3. So we'll be seeing mostly C3 fractures. What is this? This is complete articular. No part of the articular surface is in continuity to the diaphysis. There is both articular and metaphyseal combination, and it requires open reduction. There are few reported studies in English literature. The results are mostly average to poor, and I really found some credible presentations in 3 English articles. There are some Korean and Chinese articles, but I could not understand much out of it. So the aim is to get the articular reduction correct and get the alignment correct, the length of the femur, distal femur, angulation and rotation. The 3-dimensional rotation has to be done. There is a tendency, if you start fixing from the lateral side, you may get anatomically reduced looking medial side, but there may be 2 to 3 millimeter of malalignment, and that can lead to valgus reduction. So that was a point which if you know the wet-bearing line, the wet-bearing line goes in the distal femur on the medial side. So the wet-bearing line, because of the constant weight we are bearing, has got the strongest bone on that side. So when you have a distal femur fracture which is comminuted, you will find one intact piece on the posterior medial aspect. And when you need a reference to start your reconstruction, then that's the piece of bone which guides you for the rest of the reconstruction. So the ideal treatment objective is to, at the end of the treatment, to achieve union of the fractures, well-aligned knee, no varus deformity, painless gait, full range of movement, avoidance of secondary osteoarthritis, and avoidance of complications. So you have all these ideal things which you need despite the bad injuries. This is a 64-year-old biker, high velocity trauma, polytrauma, deep abrasions over the knee. He reported to me after 11 days. So I have just put some colors in different fragments for easier identification. And you see this bit of bone, the white piece, which I just showed you, this is the one which is the constant piece which I am talking about. And you see here, this piece of bone is a posterior medial bone which is very strong and it doesn't really fragment. And you need to focus on that. You see there is impaction here. So you need to expose both the condyles, disimpact the impacted fragments, get debrima done and reduce the fracture anatomically, do a rigid fixation because it's an articular fracture. Reduction sequence starts in posterior medial. This is how it changed. I used to do from the lateral side, then I started doing from the posterior medial corner. And don't devascularize the tissue, then finally go to lateral buttress plating. You will find a void because the combination in the suprapatellar area, you need to graft it tightly and repair the suprapatellar area. I found that when you do if you don't find a smooth suprapatellar area, and the knee range gets restricted. So if you don't have a cortex, take the inner table of iliac crest and put it over there, fix with a screw, that gives a smooth surface. And because the sharp edge of the distal femur ruptures the suprapatellar pouch, you need to repair that meticulously. Otherwise, patient will have pain, will not cooperate with your post-op range of movement exercises. And this is what I was just mentioning, and do a meticulous closure. So this is a case, multiplanar fracture. This is a very highly extensile approach. It's called Olerud approach. You need to do a tibial tubercle osteotomy and lift it up like you do olecranon osteotomy and get the whole exposure. This allows you access to the posterior medial part of the knee joint. I just want to show you the video. This is what normally happens. The patient usually, by the time they get to theater, they are already 2 weeks plus because you first want the skin to be healthy for you to receive. None of the instruments, you are scared of putting the instruments because they break very easily. They are already developing granulation tissue, and you try to manipulate and get them back to debride them correctly and meticulously debride, remove the callus because you want a proper reduction, okay? And this is what I say that, see, these fragments are, once you have finished the debris and you want to reduce, this is the apex of the distal femur where you want to put an anti-glide plate to start your reconstruction. And this is the screw fixation on the posterior medial aspect. You see the big void, my finger goes in there at the end of the fixation of the distal femur. This is the post-op X-ray, immediate post-op, and this is when the patient is in the hospital. You ensure the patient starts moving the joint soon after the surgery. You give him good analgesia, muscle relaxant, but you make sure he starts, and you keep on checking the X-rays for any instability. And this is at the end of 3 months. This is at the final follow-up. He came with some other problem, and this is what he had a full range of movement. Young lady, nursing student, high velocity injury. She had a C3 fracture with impacted patellar fracture, and because these are all short fragment fractures, these are short segments, the fixation has to be good in the distal part to give you stability. That's what comes, augmentation of the medial side. Otherwise, you won't be able to get it. There's a patellar fracture which is impacted, and you see how soft is this bone. You see, when you try to curate the fracture callus, it's a very soft bone. You are scared. This is the anti-glide plate and the posterior medial aspect where you start your reconstruction. And these are the pictures. This is the anteromedial plating, the augmentation of the, this is the anteromedial plating. The augmented plate is augmented in the front. First start fixing on the medial side, then before you go to the lateral side. And finally, you start, this is the lateral plate, buttress plate, and you fix the tibial tubercle, the immediate post-op X-ray, and you do this yourself. This is what I tend to do it myself, and I demonstrate to the family how to do it, and she starts moving soon after the surgery, and this is when the family takes over. Make sure when you discharge them home, she has at least 90-degree range of movement, and this is what post-op repeat X-ray did not reveal any displacement, and she came after 2 months with a lag, significant lag. At the end of 6 months, she made up, she got married, and this is 6 months post-op. And she recently visited me. You'll be surprised. She walks up and down in the stairs, and she has no lag. Though you can make out she's definitely not like the normal persons, but definitely she has, despite such bad injury, she's able to walk up and down the stairs, and see the range of movement she has got. She has no varus deformity. She's a proud mother of 2 kids. So she has been through 2 pregnancies and she's okay. This is a young boy, college student, and high velocity injury. You can see this is another similar fracture, and he also has a patellar fracture, and I prefer to do it through a swashbuckler with a posterior medial approach. This is the posterior medial fixation, first done in the posterior medial reduction and fixation, and this is after I did part of the reconstruction. And this is when you put the periarticular reduction forceps. You should not compress the fracture too much to produce a malalignment. This is again anteromedial plate to reinforce the distal fragment. One of the screw from the anteromedial fragment is going into the fragments, you see, because you don't have much, you don't want to get into the articular block. And this is the void which I was talking about. You find at the end of it this big void. You need to graft it, and of course put a iliac crest graft in a table. This is, I reinforce the fixation of the tibial tubercle with a 1/3 tubular plate, and you see, you must make sure intraoperatively mobilize and see the range. and check for any instability. If there is instability, you can do the correction when you are in the theater. And this is patient at the end of 5 years. He just comes for a review. And his dad works in the National Defense Academy. This boy wants to go back to National Defense Academy. I discouraged him from overdoing, but he's hell-bent upon doing this because he wants to join the National Defense Academy. So to the tips, what I found, that use an external approach if required, start reducing from the posterior medial corner with an anti-glide plate, augment medially adequately, graft the suprapatellar void, smoothen the suprapatellar surface of the distal femur, repair the torn suprapatellar pouch meticulously, and repair the tibial tubercle osteotomy adequately, and range of movement straight away after the surgery. This is the trick which I think improved my outcome. I thank you very much for your patient hearing.
Chitta, thank you. If you can make your way up, and Richard, if you can make your way out. Can I just say one thing to you, Chitta? I just can't imagine the kind of cases you have. I mean, you are awesome. I mean, the variety of the cases and the severity of these cases is huge. It's huge. Guys, any quick questions, please, before Richard starts off? We still have those two pointers to take home as well. Any questions before we do that? Ajit, any suggestions at all? Sorry, John.
So I have a totally different concept about this. So I would try to avoid putting a medial plate in most situations. Yes, there are situations where I would add a medial plate, but I think the whole concept of bridging these very comminuted fractures, you do need to get articular reduction, which is good. You need to get length, alignment, rotation, but the metaphyseal comminution, I would rather bridge than add multiple plates to try and get hold of that.
So it's a valid viewpoint, I think, Chitta. I mean, can't doubt the thinking.
Sir, you are doing a tibial tuberosity osteotomy. So do you ever had a problem with the implant because it's just because you are putting a plate in all these cases?
Mike, Chitta. Chitta, take it closer, maybe.
Hello. Yeah. I think you have a very valid point. I try to get the knee going first. And I have not removed any implant on anybody so far. We have done total 18 number of cases. The last boy you saw, he's very aggressive in the gym. He had problem with irritation of the skin with that plate because he's a very thin fellow. And he came back to us and we got the plate and the tension band were removed. Yeah.
Sure. Okay. Sorry, go for it. Go for it.
How early is the mobilization you start?
Sorry?
How early?
Same day, if you operate in the morning, by evening, you should give that, because by the time you take the patient to theater, it's already 2 weeks plus because of the soft tissue. We want to start it straight away. We give the patient sufficient analgesia and muscle relaxant and impress upon the family and the patient that you can be discharged only when you achieve 90-degree range of movement. So that same day, evening you start, it becomes easier. In day 2, day 3, it becomes easier.
Chitta, can I just say, be ready to be carpet bombed on the second presentation. In the days of minimally invasive surgery, I think you're going to get a lot of questions, but we'll keep it for the question and answer session.
Okay.
So, 2 points take home from this lecture.
Two important points which I found was, one is for any complex distal femoral fractures, we need an extensile approach, and the Hollywood approach is very good with tibial tuberosity osteotomy. And the second important thing is the posteromedial fragment. That is a key to accurate reduction. We can just, it's a very strong fragment which does not break easily. And another maybe important thing is early mobilization of any distal femoral fracture patients.
I think that summarizes it well. I think the posteromedial fragment, which Chitta says, is actually a constant fragment. You will get a good piece of bone there. So getting some fixation.
I'll add one more point. These patients, suppose in the future, they require, so original Hollywood approach said that you put a Mercedes cut. So the subsequently modified, removed the vertical part of the incision in the proximal tibia. But because these patients may require a TKR later on, keep your medial incision small and onto the back, because the blood supply comes from the medial side to the front of the knee joint. So that is one point you must remember. So keep it a little wide. Thank you.
Okay, Richard. Sorry, Richard, you're going to talk about the evolution of femoral nailing.
I mean, before I started, the last 3 talks were absolutely amazing. Thank you so much. I've already learned a lot, but the most important thing I learned that it's probably that Indian patients are way tougher than Americans. Americans cannot handle that kind of early range of motion. Trust me, they'll be crying in bed. So this has been fantastic. Topic today is not really too case-based, but I always tell my residents and my fellow that in order to understand where we are today, you have to kind of figure out where we got here and how we got here, because that's the only way we can continue to innovate and continue to design implants and think of strategies to take care of our patients. So this is a topic that's near and dear to my heart, because if you don't understand the history of orthopedics and where we've come from, then we're not going to be able to get to the even better as we learn from our failures. So, in 2022, the cephalomedullary nail or intramedullary nails are very, very important for care. These variety types of fractures, we can take care of almost everything with some sort of intramedullary nail. But really, how do we get here? Intramedullary nails and femur fractures really came from a need for a better option in understanding. We went from, using a splint to first-generation nails, going to X-fix and damage control, to kind of now third-generation nails. It really all began in World War I. If you got a femur fracture during the war, it's essentially a death sentence. In 1916, because the treatment only that was allowed was really splinting and mobilizing, the mortality rate, if you got a femur fracture during the war, was 80%. It got a little bit better in 18 after a little bit of treatment and mobilization, but the unacceptable mortality rate was something that was not okay, and we had to get better. So can we use something intramedullary to get better concepts? And this is not really a new concept. If you look back into kind of the history books, in the 16th century, the Aztecs in Mexico used wooden sticks for femur fractures as IM nails. In the mid-1800s, ivory pegs were used to treat non-unions of the femur. In 1917, in the US, an IM autologous bone graft was utilized to kind of stabilize femur fractures. And in the 31, Smith Peet used stainless steel nails to treat NOF. And in the 30s, rush rods and Steinman implants were kind of come into concepts as well. It didn't really become modernized until the 40s during World War II, where Kunchner and Bowler really first designed the first kind of trochanteric nail that was V-shaped and cloverleaf with percutaneous application. He continued to refine this by using flexible iron reamers in the 50s. In the 60s, they introduced interlocking screws, and then with the ability of image intensification, IM nailing continued to increase in popularity. And then at Dr. Dunbar's house and Dr. Winquist in the 1980s, kind of pioneering the piriformis start nail was really where we started to get a lot better at treating these femur fractures. This is one of the original kind of reports in the United States by Kunchner, where he reported using a straight nail with 3 fixation points. This was not a lock construct, but specifically this was something that really improved a lot of things. As we transitioned from World War I to World War II, simultaneous testing in America as well as Germany improved. Smith Peet kind of did an original version of the sign nail where you would introduce the fracture site. However, this is like very complicated, non-unions, infections. There was an improved death rate. However, there was a high complication rate using this method. Kunchner, using a percutaneous technique, was inserting an antegrade, preserved the fracture site, obviously the blood supply to that, reducing the non-union rate, avoiding the zone of injury. This improved death rate and had a lower complication rate. So Kunchner is really the father of intramedullary nailing, where his concepts and principles really led to widespread intramedullary use and improvements in design. So based on early results, when we talk about it, he recommended that you don't nail if symptoms of pulmonary symptoms were present, be wearing those with severe soft tissue injury and polytrauma to avoid infection. And he actually recommended to wait a few days, not nail immediately in order to avoid these complications. But by the early 1970s, the intramedullary nail was widely accepted. But how can we improve? And really, there's 2 concepts of intramedullary nailing for femur that has evolved over time that's improved our rates for our patient care. One is timing, which is really the concept of early total care versus damage control. And then the second concept is design, looking at ream versus unreamed, as well as locking bolts and starting point. Looking at timing first, looking at early total care versus damage controlled. Remember what Kunstler had said, don't nail immediately, wait a few days. The rationale for this was, due to the great concern for fat amyloid syndrome and ARDS, he wanted to wait for systemic optimization before going to interventional nail. However, benign neglect method and delayed nailing was not really acceptable. In this report in 1985, Siebel showed that delayed fixation led to increased rates of multi-organ failure, decubitus ulcers, pneumonia, high risk for aspiration, which led to increased ICU stay, increased frequent leukocytosis, fever, and infection, and subsequently increased mortality and morbidity. So really in the 80s, leading into the 90s, was when there was two camps of thought: early total care versus damage control, and there really were proponents of both, and a lot of arguments that happened in each. So in Journal of Trauma in 1985, early total care within 48 hours, there was a significant increase in ARDS and pulmonary incidents in the delayed care group. And if your ISS score was over 40, your mortality rate was almost double, significantly higher. This paper in 1986, again, looking at early total care within 72 hours, your mortality rate for early total care versus delayed was statistically significant, with almost a 7-time fold morbidity and mortality rate in the delayed care group. Larry Bone, this is one of the first level 1 RCTs published in JBJS in 1985, looking at the multiple injured patient, early total care versus delay, and they essentially showed that early total care resulted in significant decreases in pulmonary fat syndrome, pulmonary issues, abnormal ABGs, any kind of respiratory complications, length of stay in ICU, as well as the floor, as an overall total hospital cost. So in the 90s, which I was glad I wasn't a resident then, because what this meant was if you came in with a femur fracture, you're going upstairs as soon as humanly possible. All long bones were fixed immediately, and intramedullary nail was implant of choice. However, not every patient did well if you fixed them immediately, and really not everyone was a believer in early total care, and this is why I always tell my residents, asking why and looking at your outcomes and your failures and getting better is more important than anything, and that's how we take care of our patients better and better. The role of the immune system was starting to be studied by Hans Pape from Switzerland, 2001. His work was really paramount because he started to look at SIRS criteria, significant inflammatory response, and he was the one who really found out, first in animal models and then in human models, that a second hit phenomenon, or how injured you are and how inflammatory response is, that correlates with ISS and significantly correlates with poor outcomes even in early total care. So in the multi-system trauma patient, those who do not qualify for early total care are multi-system trauma patients with a high IL-6, because of that early inflammatory cascade increases that and almost guarantees multi-organ failures. This is something that was consistent not only in animal models as well as patients that came in ICU. So what do we do with these patients? This kind of was borne out to the DCO, or damage control orthopedics, popularized and studied at first at shock trauma, Andy Burgess, Dr. Scalia. This is a paper in Journal of 2000 and 2000, looking at multi-system patient that was borderline or worse. Within that 4 to 7 day window, having that second hip, temporizing with an XFIC, getting them optimized, and then bringing them back was something that they saw improve not only morbidity and mortality rate, but if you converted it before 2 weeks, your risk of infection was also very minimal. So really overall, ETC versus damage control is assessing more than just an x-ray. As orthopedic surgeons in America, the medical doctors really don't think we're that smart. They just think we're glorified carpenters. However, if you look at the global patient, you have to look at the lactate, you have to look at the overall medical status of the patient, avoid the second hit if you need to, temporize, stabilize, and come back for definitive care when necessary, when they're stable. However, if they're stable, you want to go as fast as possible. So really, when the inflammatory cascade is the highest is when you want to avoid. So this is kind of the overall algorithm of early total care versus DCO, which I think everyone in the audience knows. And really, it's determining if they're stable or not. If they're unstable and their lactate is too high, you want to stabilize with XFIX and then come back when their lactate is normalized. Otherwise, if the patient is stable and their lactate is normal, below 2, then you can go on with definitive intramedullary nailing, get them up and walking right away. So when it comes to device timing, the refinement period of intramedullary nailing really continued. Really, when it comes to design portion of this, the advent of flexible reamers and fluoroscopy in the 50s and 60s helped us improve, but we had to decide whether or not ream versus unream, the importance of locking screws or bolts, and the starting point was something that was going to be important. Focusing on design in general, why is intramedullary nailing so important? Why does it have a biomechanical advantage? It promotes biology. Ream versus unream, we're going to go into that discussion as well. And also it's reproducible. The best surgery is something that is reproducible, low complications. But if you can teach someone else to do it, that's how we're going to get our patients better and better. And really when it comes to the biomechanical advantage of intramedullary nailing, it's similar stiffness to the native femur, especially if you look at our modern titanium nails. It's in line with the neutral axis to the bone. It's a load sharing device, and as you move towards the distal femur, its ability to share the stress between the medial and lateral columns in a femur is of paramount importance. And really when we look at it, it's the design features that we're going to look at is it better to have stainless versus titanium, slotted versus non-slotted, the importance of locking screws, what we'll go over, and also as we go over it, the distal anterior bow to avoid complications. Locking screws are so important. The second generation nails, while they were very important in terms of getting them up and walking, remember when we first had to do this, Dr. Brumbrack out of Harborview, he realized that in order to get to immediate weight bearing with Reliance, you wanted to get to 5/0 locking screws. Design features early on when metallurgy was not that good, we were only able to get 5/0 locking screws in sometimes 13 and 12 millimeters nails. And it wasn't until we were able to get smaller diameter nails with 5/0 locking screws that we were able to weight bear immediately. So I always tell my residents, remember, and this is a testing question in America, it's not the diameter of the nail that lets you walk, it's actually the diameter in a 5/0 locking screw that allows you to weight bear immediately regardless of the comminution or segmental bone loss in the nail. And why is reaming good? Increased contact area between the intramedullary nail and the cortex. 1 millimeter reaming increases contact by 38%. We know this from Dr. Perrin's work, amongst all of his work in the late 80s. Increased reaming can also allow for a larger diameter nail if needed, especially in a non-union scenario. And otherwise, initial negative effect shown in animal models for endosteal blood supply returns by 12 weeks, but actually even putting a guide wire down your canal actually stimulates vascular perfusion of surrounding muscle and tissue, and that's going to always promote osteoinductive, conductive, and genic factors as a fracture site to help promote that early healing. So why is reaming good again? Basic science data clinically translates this. This is a Canadian orthopedic randomized trial seeing this. And the importance of this is that if you don't ream the femur, the relative risk of non-union is 4.5 times greater. So this is kind of the landmark paper that showed us that reaming was going to be important in the femur, and that's why it's a standard of care today. Why does starting point why is starting point so important? Dr. Winquist out of Seattle again, is the most important technical aspect of the operation, because when you get it wrong, remember, it's the surgeon that makes the reduction, not the nail. If you start it with a bad start point, you're going to get malalignment, comminution at the fracture site, especially if you're using a piriformis start nail, you can also destroy and burst out the fracture site, which is not a good scenario either. When we're looking at piriformis versus troch start nails, really it's dealer choice. Benefits of a piriformis start nail: straight bone, straight nail. Remember, I'm an orthopedic surgeon. I'm not really that smart. I just want to make sure that the bone length x-rays look good. Reproducible, reliable. The ideal start point here, if you go too anterior, it's going to increase the hoop stretches and proximal femur, increases your risk of entry site blowout. So you really want to be in the posterior aspect of that fossa, which is a nice anatomic landmark and readily available on fluoroscopic imaging and x-rays. What if the fracture site extends into the piriformis fossa? Really, this is what the advent of troch start nails were, and this is where you can get there. It worked for Kunstner. Why not get it really in press use for us now? Initially, you got really bad press because remember, when you had these short nails, there were things about the design that were not good. The offset of the proximal design was too steep at 10 degrees. The distal targeting problems for that nail had a lot of misses in the distal aspect of the locking screw, and also distal aspect of the nail was too big, which caused these kind of complications in the early designs. But remember, you don't want to throw the baby out with the bathwater. You want to learn from your mistakes, get better, so we can treat our patients for improved outcomes. Is there a difference between piriformis start and troch start? Really, it's no. Redesigning improvements in machining led to this resurgence. Biomechanically, out of NYU biomechanical study showed there's no difference in each nail. A comparative study done by Adam Starr in Dallas and JOT show no differences in blood loss, reduction, or union. And Bill Ritchie in 06 showed that there's no really differences in time, union, complications, and function. He showed that the troch entry nail had less floor and easier to use and easier than obese. However, I think if you're good with both, I really don't think it matters. And how about troch entry nails? There's always discussion about the abductors. Earlier nail designs had a very, very high rate of violating that tendon because of the large proximal body diameter. But as we got in smaller and smaller with proximal diameter kind of designs, that abductor lurch or that kind of has not been an issue. If you start too lateral, and this is kind of a classic cadaveric study done by Bob Ostrom when he was at Cooper in New Jersey, showed that even if you started that lateral start point, you're going to end up being in varus. Even at the recommended start point at the tip of the troch, you can be a little bit neutral, but when you're talking about subtroch, you can be medial to that to promote valgus alignment, and that'll help promote and prevent non-union. This is an example of a troch start nail done wrong for an atypical bisphosphonate fracture, which again, this is something that has a high risk of non-union anyway due to kind of biology associated, but you can see here that the start point was too lateral for a subtroch, leading to varus and flexion. The reduction was not, even if they had a reduction perfect, with this malpositioning of the nail, you're gonna get this non-union. We corrected this by removing the nail, putting a metaphyseal plate proximally, using that as almost a blocking plate to move the start point more medial, and you can see here we got reliable healing after we got an anatomic reduction. One of the other aspects of nail evolution is the radius of curvature of the femur. I always tell my residents, you want to always make sure at the distal aspect of the nail get a lateral to make sure that you're not going to perforate out the front. Initial nails are very straight, and you got this. You got anterior impingement, a non-anatomic bow, and if you were in the older generation nails, anterior perforation was something that was not uncommon and something that's not good, especially you get as more osteoporotic and that distal third concentration gets worse, you're going to need a nail that's going to be different. So really in modern designs, your differential bow and now fourth generation nails that are coming out are even more pertinent of this. Concentration distally related to the nail length. You get a 3-degree distal kick. Some of the newer nails coming out, as your nail gets longer, that nail distal kick gets even more accentuated, allows for easier proximal insertion, and also prevents the anterior cortical perforation that you want to avoid. So in 2022, what is your ideal intramedullary nail? You can use a reamed, piriformis, or troch start nail, whatever you would like. Non-slotted, especially because taking these things out, if they are slotted, is an absolute nightmare. Our newer technology allows to accommodate for 5/0 locking screws, which allows for immediate weight bearing.
Richard, can you round this up a little?
Sure. Subtle valgus bend, smaller proximal body, and a distal concentrated bow. So just kind of wrap it up. Remember, early total care versus damage control. Our newer nails are important for this and to treat almost everything we have down the line. And improving patient outcomes and learning from our mistakes is really how we're going to improve for the future. Thank you.
Thank you so much, Richard. I'm sorry I had to stop you. Just unfair for the little. I would really appreciate you. So, Shruth, if you can make your way up. So, any 2 pointers? Anybody take him 2 points? The difficult job what he had, talking about the whole history of nails and how they work. Can I request 2 points from you for the last lecture?
Yes. Pointer.
Anybody volunteering for the 2 points? There you go.
Pointer just as
okay.
Put a proper emphasis on interleukin 6 levels.
Yes.
And damage control orthopedics. So it's easy.
What's a new term that people talk about now?
You don't dream early, or don't try to operate early. Wait.
We're talking about early appropriate care rather than
surgery.
Complete.
Yeah.
Anybody else? Any other take-home points which you've got? Okay. So the next speaker, eat your heart out, Americans. Would you believe we have the god of healing in India itself, Sushruth himself on the stage for you. That's the name. And not only that, I mean, my friend out here has a whole hospital named after him. I mean, huge achievement for any person. But Sushruth has been sort of on the forefront of trauma in our trauma society meetings and everything for a very, very long time. A very elegant speaker, extensive experience, and I'm sure he's going to give us a lot of pointers now for complex femoral fractures.
Thanks, Guridhar. Thanks, Insignia, Alchem, and AAOS. I'm going to dwell upon this humongous topic in next 15 minutes or so, bread and butter for all of us here. So complex femur, I'm going to dwell upon only high energy, only young guys, whom we think only fixation is the way out. I'm not going to talk about and touch upon arthroplasty because that's a given for elderly population. But I'm going to take you through various situations that we all see, and that's what they are. And I'm going to pick up one by one the situations that confuse you and me together. So starting with a displaced fracture, which will need an open reduction, fracture neck of femur intercapsular variety, wherein reduction is of absolute paramount importance. We know this famous Powell's and Gardens classification, wherein Powell's is more of biology and Gardens is more of anatomy. But to you and me, we all think about only displaced and undisplaced, and as orthopedic surgeons, we are only bothered about ये fracture displaced है, undisplaced है, reduce हो गया नहीं हुआ. So that's what we think of. But CT scan in these kind of fractures have given us another element, which is the posterior displacement. And so the posterior tilt and displacement, very commonly seen because posterior comminution is there, can range from 0 to 15 degrees, to 15 to 30 degrees, to more than 30 degrees. And why the hell is this important? Because of this given scientific fact that more the tilt than 15 degrees, it will have greater shortening in the femoral neck, more avance, bad clinical outcome, and need for secondary surgical procedure. So that's the importance of doing CT scan for fracture neck femur, especially if the patient is young. Does it decide what implant we are going to use? So we know about Powell's and Gardens. Let's look at this Powell's and Gardens, which is very less. So 1 and 2 Gardens, or 1, 2, and 3 Powell's, wherein the posterior tilt is around 15 degrees, 15 to 30 degrees, but not more than 30 degrees. That's where we all can afford just to use cannulated cortical screws. And the use and indication of cannulated cortical screws stops there, because as we move on, these are the patients which probably might need open reduction, but we want a biomechanically stronger construct, which today in our country is DHS and a derotation screw, biomechanically stronger. As we move still further on, then we want to convert Powell's 3 to 2, 2 to 1. These are the patients which might need in 30 to 40% situations open surgical reduction, making sure that all the rugged edges are fitting into each other. These are the patients which some of us might consider doing a primary valgus osteotomy, and we might think of newer implants. So what are these newer implants which are coming on the horizon? So let's talk about them. We of course know all these varieties. 3 cannulated screws, only DHS, DHS and a derotation screw. Americans prefer removing that terminally threaded screw and putting a fully threaded cancellous screw across. The whole aim is, of course, to, in fracture neck of femur, is to have a stable construct and not allowing any further collapse. So that concept of collapse and DHS typical is gone for fracture neck of femur. So of course, many other implants also came in vogue, like Filipov's BDSF. The new kid on the block, of course, is FNS, which also gives an added advantage of this derotation within that implant, probably having a better biomechanical strength. So all these 3 implants which are on the horizon, I am particularly fond of Targon FN, but unfortunately it got out of market from India. But again, you achieve collapse on day 1, on table, and you maintain that position till the fracture unites in fracture neck of femur. Now there are lots of reduction trips that we will need to understand. So that's a fracture which is displaced. Use a Homans, pass percutaneously, reduce it well. Once you confirm that reduction is there, then you pass in that position a DHS, derotation screw early on, achieve compression and DHS. So today, this combination of DHS and derotation screw is economically preferred, reproducible by all of us, and biomechanically very, very stable construct available to everyone. But reduction is the key, and use many tricks. There are many tricks to do and skin the cat. Open reduction for me, using a uterus entry approach is very, very neat. You can use a towel clip to reduce the open anterior gap because the posterior tilt is there. So the anterior neck is open and looking at you. You have that window to close the gap anteriorly, which will correct your posterior tilt, rectify your posterior comminution, and then you can fix it. Calcar bridging plate, also a very good tool for reduction. Because we have very tiny window, you don't need a special equipment. Normal towel clip, make one of its tongue straighter because you have very tiny window there, and that straighter tongue will sit directly on your neck and allow you to reduce it. You can of course use a Farabeau's clamp, but please, please learn the uterus approach or a modification of Smith-Peterson approach, which is an independent approach, very tiny window. You will need it in 30% of the situation, especially if the patient is young. Let's look at another variety, ipsilateral neck and shaft. Again, a very common injury, 25% of the situations. We prefer to do an independent implant for this because neck femur is a more important clinical situation wherein we want good reduction and we want a neat, stable clinical outcome. Of course, this is what we published few months back, wherein type 1 and type 2 is a vertical neck fracture, minimal comminution. Type 3 and type 4 is a displaced neck. So for example, this was the fracture, vertical fracture line, type 3 variety, wherein the first screw has to be that horizontal Powell screw, like here. So a horizontal Powell screw, independent fixation of neck of femur, and then of course the retrograde nail. My choice of dealing with this situation, what to do first, neck femur to do first. If it's a displaced variety, then followed by your shaft of femur. That's 6 months down the line, 2 months down the line. Again, how do we pass this horizontal screw? Is the combination B better, wherein the screw is going from lateral to medial in the inferior portion, or type C is better? Type C is better, which has got a bicortical fixation because it will have a better axial stiffness and failure to load is resisted. So unicortical type B, which was shown here, is not the way. Type C is the way to go about fixing this Powell screw. Complications to look for in ipsilateral is of course avian and non-unions. So the message is, do we in all ipsilateral need an independent fixation? So if the neck is minimally displaced or an accidental finding, you're already in the process of doing fracture neck of femur, these are the patients you can use a single implant to have the war against ipsilateral neck and shaft, but please hold the reduction with K-wires and use a single implant. If you are dealing with a displaced fracture neck of femur or a vertical neck, then you need an independent implant. Bifocal fracture, again, very common, almost 8 to 10% of the situations. Lateral wall can be deficient and lateral wall thickness is very, very important. So I was coming to CT scan requirement in neck and trochanteric area. There is no way your X-ray will tell you lateral wall thickness in all the zones. If you take only AP and only lateral, you will miss some amount of lateral wall deficiency. It's not a broken lateral wall, but deficiency you will miss, and that's the paper we published in Injury 2 years back. So we are dwelling upon unstable trochanteric fractures, and we have talked about augmenting unstable by doing additional cerclage wiring. Now there was a very interesting paper which we did, pitching cerclage wire technique pitching, augmenting lateral wall with a plate and multiple screws. And we thought that cerclage wiring technique is biologically sound, more reproducible, and works better. For example, this is a fracture very innocuous looking. So one would think that only AP and lateral is not showing any lateral wall insufficiency or deficiency. The moment we do CT scan, it shows you that. So there is no way we could have done probably a DHS in this situation. Intramedullary nail is a better idea with cerclage wire, which will wrap around the whole trochanter, maintain that intact osteomuscular sleeve, which will take care of your abductor lurch if at all. Next area we dwell upon is a bifocal fracture. Trochanter is separate, associated neck femur, unstable trochanter. Reduction is important. Use whatever you need to do to achieve good reduction, temporary fixation. And then, since we have opened it, maybe a DHS and a lateral trochanteric buttress plate is a better idea. Once you put all the bony fragments together with good augmentation technique, this is the result which you expect. Another trick which one of my friend Rahat from Thailand has done, this was the patient which he received, very, very unstable. Femoral head was floating, it was dislocated. He went in and put in the calcar buttress space as a reduction tool. But not always helpful, because this in his situation was coming in way of reducing and putting everything together. He had to remove that, and that's what he finally ended up doing. Fixing it together, achieving good bony union. And the last situation which we very, very rarely will come across is this central fracture dislocation. That was a young patient. Now this was a fracture acetabulum, femoral head gone right into the pelvis, floating there, young lady, very obese. There was no way this subcapital fracture would probably have made its way 8 years, 10 years, no. So this was the singular patient where we reconstructed the acetabulum, used the same femoral head as graft, but did a primary hip arthroplasty, and that's 18 years down the line. So complex proximal femur fractures will elude your mind, my mind. We will be always skeptical about them. But these are the fractures. If we know the tricks, how to solve them, probably would make our journey, which we are all going to go through, probably easier. Thank you very much.
Wonderful. Thank you so much. The Prince of Nagpur lives up to his reputation. The king is obviously your father. So, okay, guys, very quickly, we're going to have a question and answer session. Chai card dete hain, boss. Okay, guys, let's go. Question and answer session. So we've had what, 5-6 talks on this. Fractures of the pelvis and acetabulum in the elderly. Do we need to be more aggressive? Any questions, any thought? Richard is here to answer that for you. Richard, sacral fractures. I mean, I can tell you most of us are not treating those osteoporotic ones as aggressively as you're treating. You think it's making a big difference in survival overall?
Yeah, again, this is something that most of the patients are going to be treated non-op anyway. But I think the important thing is for those rare patients that can't get out of bed, a simple percutaneous S1 with transsacral S2, you'd be amazed how they do. A bunch of us are putting our data together now, but it's something that I thought was insane when I started out, but you would see the difference, especially if they can't move. So it's not for everybody. I'm not advocating for putting a screw in everyone's back,
sure.
But for those people that can't get out of bed, you can see it. You can get them out of the hospital very fast.
Okay, guys, can I just say one thing? You can make your way out for coffee, but please, no conversation in the hall. So we're still having the session going on, but please keep it quiet, but you can have your coffee in the meanwhile.
Which cement you use?
Samir, can I request all of you to come here? Actually, it's much more interactive that way. Sorry, Samir, your questions before you...
The question was if I use cement or phosphate. I actually don't. I don't trust the delivery devices, and I feel like it's going to go everywhere, and the L5 nerve root's so close. That's why I switched to that other implant that's supposed to have better bite. But traditionally, I just use simple 6.573 cannulated screws.
Chitta.
You mean to say that you use the highly porous cup?
When you do a hip arthroplasty.
Yes.
He's talking about the hip replacement.
Well, for the fix and replace, yeah, I use a highly porous revision cup, so I have multiple screw options. My goal there is to get a screw that goes up into the corridor towards the PSIS. You can get, you know, long as 60, 70 up there to get good bite.
But would you say every case had a plate with a cup? Or would you say there were lots of cases who only had a cup with no fixation of the acetabulum?
There were lots of cases that we did without. However, for the patients that are kind of more infirm and that you're not going to trust them getting up with worse bone, especially those ones where you don't think you can get the reduction perfect, those are the ones we're indicating for more aggressive.
So, I mean, what are we looking? We're looking for the superior roof and the posterior wall of the acetabulum? Is that
specifically comminution of the dome,
right,
or that gull wing sign, that's going to automatically be a fix and replace.
Okay. Chaitanya, okay. The next talk was on combined pelvic and acetabular fractures. Samir gave that talk. Any questions at all on combined fractures? Very difficult things to handle, and some of those X-rays are absolutely superb. I mean, some of the aloysial screws and everything was way beyond being a perfect piece of art. So wonderful job done.
I actually had a question. When you're coming and you're taking the gluteal pillar down, do you do anything specific to protect the SGA coming out? Or it's just very delicate dissection? Are you using a specific retractor?
Retractors only.
But you're not pulling that hard, because if you get into the notch, if you take that out, then your entire glute dies. Okay.
Okay.
Hello.
Any questions for Samir? There you go. Please. Yeah, go ahead. Was that for Samir? Do you notice abductor weakness when you do this? Or was it for Chitta on the extensile approach, or sorry, Chitta, your question. How often do you see abductor weakness at all?
I think there are a couple of things. First, when you repair, you must keep the limb in abduction. And when you transfer such patients to the ward, like in a THR, you put an abduction pillow all the time. You cannot mobilize these patients. You can make them sit up in the bed with abduction, but you have to keep the abduction brace on for 3 weeks. And static abductor exercises at the end of 6 weeks, and dynamic by 8 to 10 weeks. You saw some patients, none of the patients have abductor weakness, unless you have got chances when you are doing the dressings. If you try to pull up the dressing straight away, you can take off the whole flap. So the trick is, when you close the wound, put an elastic tape from the back to the front. The whole flap gets compressed. And when you take that strip off, start from the back and take it to the front. So every time you do the dressing yourself. That is one area which, if you don't do it.
Do you have a picture of that? Do you have a picture of
Yeah, of course. If you want, I can.
Dressing from the way coming up there.
No, actually, I have a picture. If sometime in the leisure, if you want, I have got 2 pictures of that.
What about the OT positioning?
The positioning of the patient when you do anything.
It's a lateral position. I have a picture, a slide on the position of what all you should protect. Because a long procedure, you should protect the other limb, ulnar nerve. There are 2 things. First, you should have 2 wide bore cannulae in case you have excessive bleeding to transfuse the blood. You should protect the ulnar nerve, the gluteal area, the popliteal,
the normal side.
Other side. Other side.
Yeah, a couple of questions. First, to Dr. Samir Agrawal, sir. In one of your cases, which had ipsilateral fracture of neck femur, so you said fracture neck femur fixation first. Any specific reasons for that? Because in a displaced, central fracture displaced position, it is very difficult to get a good anatomic fracture reduction of the neck femur. So
in that case, we have done open reduction, and I want to use a head as a template, because there is a fracture dislocation of the head of the femur with the external fractures. I want to first fix the neck so that I can reduce my acetabulum over that.
Okay, right. And then my second, so I'm sorry. Sorry. My next question to Sushil sir. In one of your cases, you showed ipsilateral fracture neck femur and shaft femur being fixed by 2 separate plates. What is your take on the stress risers that occurs between the 2 plates?
Yeah, very good question. So today, I would have some implant overlap, absolutely. Because these were the patients when we did not have that concept of having overlap. So today I would put a retrograde nail going across and DHS going over and try to eyeball one of the screws going through DHS lateromedial to the nail.
Thank you.
Dr. Das, regarding the distal femurs, I have two questions. One, I saw you did tibial tuberculositeotomies on some of the patients. Did you allow them active extension immediately post-operative or not? Oh, did I miss that one already?
He did ask the same question. The trick is you tell the family members that the patient can bend the knee.
Yeah.
The moment it starts hurting like hell, should stop. The family should try and do SLR. You can give them static quadriceps exercises, but not dynamic.
Okay, I have one other. Could you just explain repairing the suprapatellar pouch?
Yeah, actually, invariably, I first saw a paper from the Gulf where one surgeon he has described in 2013 that his results improved after he found that the suprapatellar pouch was damaged and he repaired. So I started looking for it, and I found invariably all the cases, the distal femur has actually gone and ruptured the suprapatellar pouch. So it just required a meticulous repair, and that stopped patients complaining about the pain in this area when they're moving the knee. And that was a great point which I found improved my results.
Thank you.
Guys, sorry. I'll just check if there's somebody else, then I'll come back to you.
To Bubulkar sir. So you are putting two big implants in a neck femur. What would the vascularity afterwards?
We're talking about the
DHS and screw.
medial buttress plate, or
No. I'm putting DHS along with the screw in the neck femur. You are putting two big implants.
Yeah, I understand. So depends on what size of the patient he or she is. I would use a adult DHS which we normally use. If the patient is too tiny, I use a pediatric DHS. So, so these are the two DHS options, number one. Number two is, again, if we look at the biomechanical study, why do I need to use that? So 3 cancellous screw, 4 cancellous screw, only DHS, and DHS with derotation screw, biomechanically strongest construct required for fracture neck femur in India, easily available, is DHS and a derotation screw. So if you are skeptical about your size of neck in a particular patient, use a pediatric DHS. So that's with a narrow
the question really
screw.
is impairment of vascularity. Do you think the implant makes a
I do not.
difference?
I do not.
It is that's quite right. Sure. Okay.
Now, given that, given that 25% of the patients still would lose their femoral head and they will become sclerotic. After 10 years, they will come back to you with hip pain. Do not remove the implant. As soon as you remove the implant, it will collapse because it becomes avascular. Your implant is holding it. So either you remove the implant and at the same time convince the patient for immediate need of THR maybe.
Okay, I'm just getting Dilip to comment on.
A very important point, and I want to clarify. I have suffered from this situation myself. What is first, anti-rotation screw or DHS?
Always a derotation screw first.
And that is very important message I want to give to everyone. I have suffered from it.
Okay, so the answer for that is in the FAITH trial. If you guys read through the FAITH trial, you'll see that one thing that came out, this is a comparative trial between DHS and cancellous screws, that if you actually, the DHS can actually rotate the femoral head and increase the chance of getting avascular necrosis compared to a screw thing alone. That's one of these sort of, it's a lovely paper if you read the FAITH trial about this, you know about that. Sorry, Samir, were you going to comment on that?
No. We put fibula, basically. We remove the screw, as Dr. Hadass Singh used to cut the fibula into two, and then you put that screw in that.
So the paper from PGI talks about just a fibular stud graft, not a vascular thing. So he's just using it as a structural graft. Any other questions on the neck of femur? Any issues with neck of femur people have? Sorry, okay, your question.
The role of denosumab given simultaneously with these bad fractures, like
so, any role of I don't think any one of you okay, I'll take it from anybody in the audience. Denosumab role in femoral fractures or neck of femur fractures?
pelvic, femur, or anything
I spoke yesterday at length, and teriparatide is positively helping in fracture union. You can give it for 3 months, and if you want to give a pulsed combination, then you can give denosumab. After 3 months, there is somebody who uses 120 milligrams in 4 weeks' time for 3 months, but the ideal way will be to give 60 milligrams once in 6 months. It's a pulse method of giving teriparatide and combination of denosumab.
We're talking about does it aid in fracture union or not? The question is am I right in saying that that's a question?
It definitely helps, and especially in fractures, neck of femur, maybe transcervical or intertrochanteric fractures.
That's opening a can of worms, so I'm not going to go in there at all.
Gurinder, can I pitch in for a second?
Okay.
So for all my orthopedic trauma surgeon colleagues, do not start denosumab immediately if you are interested in fracture healing, because it's a bone resorption agent. So start with teriparatide, which will build the bone initially, and then supplement with bone resorption of denosumab.
In dialysis?
Sorry?
Chronic renal failure.
Yeah, in both the patients. But make sure that when you give teriparatide, you do your parathyroid hormone levels.
You want to increase the density of the bone, basically.
But teriparatide we can't give in chronic renal failure, no, sir.
Again onto the...
All patients don't have chronic renal failure, so we won't give it in those.
Sorry.
Sir, my question to all of you that before this conference 2 days ago, I did the neck of femur fracture, and when I put the derotation screw, after that hip screw I put and tighten it, but it rotate the whole neck of head. So how to prevent it? Even though I put derotation screw first, then hip screw, but the hip rotated. When I over tighten it, the rotation.
So it's osteoporotic then?
So can I answer this? Yeah. Actually, this is a real life situation. You can put a 2.5 mm DHS threaded pin straight into the acetabulum, transfixing this thing, and use a DHS. And at the end of it, you can add one derotation screw if you wish. That's what I do.
So guys, we'll stop here. It's as per the schedule. I would like all the faculties to be on the stage. I would request Dr. Gurinder Bedi to felicitate all our faculties for this session with a memento. Swastika, can you? I would request Dr. Yoon to... Dr. Yoon, can you be on stage? Dr. Yoon, can you felicitate our chairperson for the session, Dr. Gurinder Bedi? We will be assembling back right after 15 minutes. So, already we are 7 minutes delayed. So please, I request all of you to be there after having a cup of coffee or tea in next 15 minutes. Hello. So, with this short break, after this short break, we will be starting with our next session, which is, knee to ankle tips and strategies for managing tibial fractures. And to chair this session, I would like to invite Professor Dr. Dilip Shah. So Dr. Dilip Shah is an honorary orthopedic surgeon at Saifi Hospital. He is the winner of SICOT Fellowship to Italy in 1985, BOS Fellowship in 1989, AO Fellowship in 1995. Dr. Shah is a panel consultant at ONGC Mumbai and editor-in-chief of ASOR, Honorable Editorial Board member for Fourth Journal of Orthopedics and Sports Medicine. He is an organizer of conferences, chairman and speaker for many conferences, and national coordinator for India AAOS Saturday conference from Chicago Rosemont. Dr. Dilip Shah is an organizer, chairman and speaker for many conferences, as well as national coordinator for India for AAOS. He is an instructor for AO courses since 1985. He is recognized professor in the University of Mumbai and examiner for post-graduate MS examination. So with this brief introduction, I welcome Dr. Dilip Shah to chair this session and take this session forward.
Thank you very much, Dr. Tarun. And thank you very much for AAOS faculty which has come here to impart knowledge to all of us. And maybe at the end of it, we'll have a lot of knowledge gathered together. Right now, we have the first speaker from AAOS faculty, Dr. Joshua Langford. He's a board-certified orthopedic surgeon with the Orlando Health Jewett Orthopedic Institute. He is the executive board of Foundation of Orthopedic Trauma and editorial board of the Journal of Orthopedic Trauma. Dr. Langford is also the program director of Orlando Health Orthopedic Residency Program and assistant program director of Orthopedic Trauma Fellowship at Orlando Health. He specializes in orthopedic traumatology as well as complex orthopedic limb salvage and reconstruction. He has extensive experience in total joint arthroplasty, including utilization of the direct anterior approach for total hip arthroplasty. But right now, he's going to give us tips and tricks about the distal femoral nailing. Over to you, sir, Dr. Joshua Langford, all yours.
Thank you. I feel a little humbled. I think that my talk may not be quite as complicated as the last distal femur talk, so hopefully I can keep you at least moderately awake. Again, thank you for having me. It's an honor to be here, and we're all kind of blown away by the cases that we've seen so far. These are great things to talk about. My disclosures don't mean anything. So what to nail? Pretty much everything. So I come from a totally different mindset when I'm looking at the distal femur. And really the only things I don't nail routinely are periprosthetics. And a lot of that has to do with femoral component design. We wrote a paper on that about where the trochlea is and where your starting point is. But that's actually changing because there are some implants that are a little bit more respectful of that. Extremely poor bone stock is one that I really wouldn't nail often because for a long time we didn't really have fixed angle screws through the nails, but now, again, that one we're having more fixed angle screws that are going through nails, so then my question mark is on that one. And then ipsilateral total hip, and again, I like putting this up because these are my things I don't nail that I made up about 8 years ago, and each one of these things I don't nail has slowly started to change a little bit to me nailing, and we start talking about, well, what if we go tip to tip on a retrograde nail and a hip, and then we can get a whole discussion about, do we have to span that junction? Do we go tip to tip and not span it? Man, we could talk for 40 minutes just on that. So one of the relative contraindications that we're all taught as residents was, essentially C3 fractures. Articular fractures, especially involved the intercondylar notch, they said, they shouldn't nail those. And I think that's in question as well. I think that we've seen, we can put things together, and if we can convert a C-type to an A-type, however we do it, that we can pretty much choose our implant how we want to. So the keys to nailing, just like we talked about in the proximal femur, the correct entrance site. And I think that, this is something that the residents sometimes miss, that, the anatomical axis of the femur does not come directly through the center of the notch. It's just slightly medial. And people not respecting that tends to get you into a little trouble, especially with the extremely distal femur fractures and trying to nail them. That can lead you to a little bit of problems. Knowing your nailing system it's important about knowing what angle, especially if you're doing really distal fractures, again, which angles are going to get close to being on your joint surface and are going to impinge on other hardware you're putting in, and taking your time. So this is the thing that probably, we all have busy practices and lots of surgeries to do, but these are things that can truly snowball if you make one little mistake that turns to a bigger one and a bigger, and then all of a sudden you don't know what you're looking at. So just taking your steps and making sure you can see what you're doing. So I think that careful decision making is important. Timing to surgery is actually entertaining for me because there's almost no distal femur that I don't treat on day one, and I think that that's the thing that's completely different for me versus what I've seen here, is that like you guys don't get the luxury of treating a lot of fractures within the first even 48 hours. That changes everything. So there, the other talk was asking, why don't we do iliofemoral? I don't do iliofemoral, not because I don't know how to do it, it's because I get to treat them within 24 hours. The last iliofemoral I did was 4 years ago for someone who's 3 weeks out. So it's just different. But hopefully a lot of this will go across to things we do. Patient preparation, so we use a radiolucent table, supine. We flex the knee with a bump, and I'll show you a little bit more with one of my intraoperative pictures. We use a radiolucent ruler. This is kind of what the bump looks like. My partner, George Hadakevich, made this one up for I think this was a JBJS article, and he has a trick of getting published in JBJS. You just have to have a really good artist, and you can get a lot of stuff published. So if you got someone that can draw really well, that's your key to JBJS American, making cool pictures. And you can see right here, if you look back at that x-ray tech, how mad they are, because he used to prep in both legs. I don't do this. I just put this picture to show it. That's an x-ray tech in America when they say, I don't like you. It's hard. This is important, and not just for periprosthetics. I use this because this is the basis of everything I do for treating interarticular distal femurs, is that when you're in the top position, the whole joint surface is looking at you. So you're going to want to actually utilize a malreduced position of the shaft portion of the fracture to get you total visualization of the articular surface. And then once you're ready to connect that articular surface that's been reconstructed back to the shaft, then that bump flows more north until you get to a point where it's just getting ready, the distal fragment's just getting ready to fall off the mountain. And that's really important to doing. As far as surgical approaches, we're talking about inarticular ones here, so not these little holes, they're actually big. My preferred approach is the TARPO. I mean, back in the 90s, everyone had to have an acronym for everything. So this is originally Transarticular Retrograde Plate Osteosynthesis. And this is the article by Christian Kredick, and I got the pleasure of meeting him when I was a resident and talking to him, realizing he's a pretty smart guy. So I think this approach is great. This is my utility approach, and I kind of argue back and forth about people when they talk about their skin incision, because I hate lateral incisions over the femur, especially being a guy that does a lot of arthroplasty. My incision for doing this is straight down the middle, and then we go a lateral parapatellar arthrotomy. And the cool thing about the TARPO approach is that you haven't bought anything. Right? So I can reconstruct an articular surface and say, wow, this was much more comminuted than I thought. I think a plate's going to be a good idea here. And I can slide a plate up. I'm not committed to nailing by doing this approach. I'm doing an approach to visualize the joint, get it reduced like I need to. And then if I need to put a plate, I'll put a plate, but I'd like to nail. So that was my whole process of in practice, going to more and more distal nailing, because I opened every one of them up, having a plate on the back table saying, if I can't nail it, I'll plate it. And then all of a sudden I was figuring out that I could nail all these. So the entrance site is important as well, just anterior to the ACL, in line with the shaft. So just like we're putting in a total knee alignment rod. We try to bring it up past the lesser trochanter. There's a paper that talked about the branches, and in reality, this is not a problem when you're putting it in, it's when you're taking it out. Because you don't have stiff tissue when you're putting it in the proximal cross-locking bolts initially. And then if you do have to take it out, usually you've had some scar tissue, and that's where I've actually run into vessels. So we do try to keep the tip of the nail coming just up north of the lesser trochanter. This is an important picture to have in your mind when you're interlocking. You got to be careful of the screw length, especially on the medial side. Right? The lateral side is pretty vertical, and the medial side is like the humeral head. Right? The medial side, you have to have almost an infinite number of views to prove that your screw's not out of the bone. People hate that. If they have interlocking screws that are sticking out the medial side of their femur, they really don't like it. So I spend time to try not to have anything sticking out the medial side of the femur. This was one of the first nails that had multiple distal locking options. This one all those cross-locking bolts could be fixed, and they became fixed angle screws, and this is really where we started coming from. So I just want to show you a case example. This is a 71-year-old female in a motor vehicle collision. We would say by our standards, she was fluffy. By Indian standards, she might be morbidly obese. So our definition of fat is different. So if you've ever visited, you'll understand. So this is what it looks like. And this is not nearly what some of the other cases that we saw in the last distal femur lecture, like it still looks like a distal femur, which is good, but we do have interarticular component to it. And we see there's a little bit, if we rotate the 3D around it, there's a little bit of incompetence towards the notch, but nothing too extreme, right? So this is what the setup looks like. And again, I do a midline skin incision. I raise mainly a lateral flap. I think that what you saw in the one where they were doing the tubercle osteotomy, you can see there's a pretty good respect in that talk to not raising huge flaps on both sides if you don't need them. And I think that's important. So I raise a lateral flap, and then I have a lateral parapatellar arthrotomy marked out. And this is where I'm talking about letting the shaft component just completely be malreduced while you're trying to fix the articular surface. Because now this shaft that's normally in line is totally looking so you can look down and see everything you need to see. Unless I have, it's kind of more rare for us to see a displaced medial hoffa. In that case, I'll do a medial parapatellar arthrotomy. But usually I like the lateral one with the tarpo approach, because most all of our hoffas are lateral condyle hoffas anyways, and we can look directly at them. As you go along, you see we are able to put the shaft together. I don't get too worried about what I call this little shield piece of the trochlea. That it looks big, but when you look at the total articular surface, it's not that big, and I usually fix that with little headless screws, something like that at the end. So that's the articular surface put back together anatomically. And then what I do is goalposts. So these are wires for 6'5" cannulated, partially threaded screws that'll squeeze the condylar reduction together. If we had a hoffa in this one, I would have had wires in provisionally. I usually reduce the hoffa and put wires in. I don't usually put the screws in for coronal plane fractures until most everything's done, just so I don't have hardware traffic. And then at this point is when you put the bump in. So now you've taken this one and you bring the femur around so you can see it. And this is a trick. If you use cannulated screws, you can just take the wire for the anterior of those two goalpost screws and poke it through the skin. And you can use that to ski on, essentially. You can pull it out of its extension back into line with the shaft, and you can do varus valgus with that if you need to. I think that and I show a picture like right here. That's a different case, but we can use it kind of as pulling, and you can see you can really align the varus and valgus of the distal fragment doing that, and it's a different case. From back in the days of my partner, Andy Burgess, he loved using this traction bow to do it. I mean, it's a little aggressive. You don't really have to do that. This is probably the most important slide of this, and I was talking about earlier, is that you want your hole of your starting point to remain a hole and not turn into an oval, just like the proximal femur. Right? Like if you start with a hole in the proximal femur and you're not attentive to reaming, you'll end up with a hole that becomes an oval, and then the nail has a place to go. In the distal femur, the same thing happens. The extensor is very strong, and if you just try to do it through a lateral arthrotomy, like my partners did, they kept asking, well, why is the nail drifting over laterally? It's the same reason. You just have to respect the starting position. And usually I can get interlocks through this. Sometimes we do a little percutaneous stabs to put the interlocks in, and that's what it looks like. When I'm planning it, thing I usually do at this point is I get a lateral of the femur, perfectly lined up the condyles, and the nail that I use, it has two that are perfectly lateral to medial. So I make sure I see perfect circles of those two holes, and I see perfect condylar overlap. And at that point, I know I'm where the nail designers wanted it to be. And that means that my off-angle screws in the distal femur are going to be not on the articular surface and are actually going to be targeting areas of bone. And I can tell you, because I was on one of the nail design teams where we were looking at screws, and really those are really well thought out. Like the angles, they're trying to go to areas of maximum bone quality. They're trying to get maximum crossing angles for stability. So super important. That's what it looks like in the end. You can see there are these little screws, that little shield piece I put down with some headless compression screws, which we use a lot of. They're super expensive, but fun. And then the great thing about this, no golf club deformity, abundant callus, right? I don't really have to worry about how many screws I put in where, like on how long the plate is and all that. So that's what it looks like. I can tell you on this one that I did not listen to myself and make the nail longer past the lesser. And that's essentially because I undershot what her length was, right? So when I get the distal fragment done, I kind of give it a tug and try to get everything back out to length. And I had underestimated by about 20 millimeters how short she was from the fracture. And I didn't do that one, and anybody can tell you after they've seen a subtroch from that ending those screws down there is bad. So I like to get limb alignment on pretty much all of these at some point, 6 to 8 week mark, just to keep me honest. So I'll go through a couple real fast here. 35-year-old guy. This is the guy that actually got me to do inarticular nailing because I couldn't believe that he did so well. So this one has a coronal plane fracture. Put it together. This is before I was using both the gold post screws, and we call this like the blow dart method of screws everywhere. You can see I have a screw that's out medially. That tells you how young I was when I did this one, because I wasn't paying attention that everybody hurts when you have a screw sticking out medially of distal femur. And this was him at 8 weeks. So this was an abnormal thing in my clinic to see with people that I was plating, was that they would have this kind of motion at 8 weeks and be totally comfortable, and that's him 6 months post-op. Now, my last one I'm going to show is just a lady, a 75-year-old female. It's just different thinking that I've had recently as far as, like I said before, I like to plate almost all of my periprosthetics just because I felt like the entry point of the nail and the nail that you had wasn't the greatest. But as we have nails that have more fixed angle locking ability to create essentially like an internal locking plate to get a short segment fixation, I think this has changed things a little bit. This is one where I used a bone hook to kind of take out the deformity, and we got really quite a lot of fixation in a very short segment, and that's her, and somehow she disappeared at 1 month, but at 1 month she was already making callus. So has my indication changed for nailing those? It has a little bit, because I think I'm not getting the hyperextension deformity that I was getting before with the other nails. I think the kick on this one and the kick on other companies where they're kind of going to this more periprosthetic bend, it gets you in a position where you can put the nail in and not malreduce it. So that's a picture from my backyard in Orlando. You guys can come and visit me anytime. And again, thank you for having me.
Thank you very much, Joshua. And with permission of Dr. Malhotra, do we go in for two take-home messages? Dr. Shakir Kapadia, two take-home messages from this talk which you got, and Dr. John Mukhopadhyay, you can be ready. Can you give us two take-home messages from this talk? Give the microphone to him. And we will have one burning question and one burnt-out question for this talk. Because this is a different one. This is distal femoral, and rest of them all are tibia. So we'll take all tibia together. Yes.
One message would be the bump below the fracture, which will
very important
help to reduce your fracture immediately. And number two is keep your options open. Don't decide on a plate or a nail when you start.
That's wonderful. And any burning question from distal femoral nailing? Yeah, can you send the microphone there? No, can't hear you. We'll need the microphone there. Quickly run up to him.
I'm Dr. Sridhar from Tamil Nadu, a retired ortho professor. Now, nice presentation, sir. But having opened the fracture site, the metaphyseal region, Now, do you like to apply bone grafting or simply you come with fixation? In which case you apply bone grafting, which case you don't, having opened at the fracture site?
So I try to be very respectful of the fracture site, especially in these. So that whole repair of the suprapatellar pouch has really made me question things because I've never even thought of that before. So now I'm scratching my head a little bit. I haven't bone grafted any of these. I think that in general, if you get, especially in this area of the body, you get stable fixation, that you have a comminuted fracture, it's going to heal with callus. It does very well without any bone grafting at all. The ones where I have real big bone loss, like where we've lost a whole segment of shaft, essentially what I'll do is I'll put in a little antibiotic spacer of cement, planning maybe to come back for an induced membrane technique of bone grafting. And so far, almost every one of those I've put in, bone has grown around it, and I haven't had to go back and do anything. So I don't do any acute grafting.
Oh, extra, we are discussing about the medial plating.
Yeah,
So
no.
when you go for lateral plating, we apply medial plate for comminuted fracture, unstable fractures. Now you apply nail. In just such cases, you go for medial plating or stop with the nail itself?
Yeah, I'm a chicken. So I don't like to weight bear articular fractures. It's not about the implant stability to me. It's about when you've had an interarticular fracture. I'm not a huge fan of weight bearing it right away. Replacements, yeah, like that periprosthetic, I'd weight bear that right away because I'm not worried about articular surface. I do think it's strong enough. I think that I don't want to be the guy that does that to test it. I think it is strong enough to weight bear. But like I said, I'm more conservative than I probably need to be.
What will be the post-operative protocol?
Oh, so post-operative protocol, they don't have...
Sorry, one question. And I think you have covered for somebody else also. So at the end of this session, if there are any questions left pertaining to the distal femoral, then we'll take them up. And we have a great orator as well as great surgeon from Patna, Dr. John Mukhopadhyay, who will enlighten us about the malunited proximal tibial fractures.
Thank you, and it's a pleasure to be here. I'm going to talk about basically intra-articular proximal tibial non-unions, and hopefully by the end of this talk, you would change the way you look at intra-articular non-unions of the proximal tibia. No conflict of interest with regards to this presentation. Just start with this 54-year-old gentleman who presents to you 5 months after this injury. And this is a dilemma all of us face, whether we do something at this stage or he's old enough, wait long enough to do a total knee replacement. So I think this is a problem many of us will face from time to time. These are significant clinical problems. There are no easy answers, and if you leave them untreated, they will end up in osteoarthrosis with pain and disability, which may need an arthroplasty. So is it possible to salvage the joint and avoid an arthrodesis or arthroplasty when they sort of come to you at this stage? So this is the kind of problems, unfortunately, we see from time to time. I think when you get these patients, you need to assess them clinically in terms of their symptoms, how much disability they have, is there any instability? So very often these bony malunions will present with instability rather than pain, and also, of course, the range of motion. And then you have to assess them radiologically. You need to see if the problem is mainly intra-articular, or is it extra-articular, or is it combined? And you need to look at joint incongruity. So what you would do is standard APN lateral x-rays of both knees, and also a long limb x-ray to look at the alignment. And you would do a CT scan to look at more details of joint incongruity, step-offs, depressions, etc. So I'm going to start with a few cases. Your treatment strategy could vary from extra-articular osteotomies, intra-articular osteotomies, and hemi-plateau elevation. You may have to elevate depressed segments. You may have to combine these procedures, or sometimes you have to do more complex reconstruction. So I'm going to start from relatively simple cases and try and work my way up to more complex situations. So this is a gentleman who presented to us a year after the injury. He's in his early 40s, and you can see he's got a varus in the knee, but if you look more carefully, this problem is from an intra-articular fracture which has malunited, and your problem, original fracture was here. So you can't just sort of do a simple high tibial osteotomy because there's an intra-articular problem. What you need to do is your osteotomy through that area, get up to the articular surface, wedge up, sort of lift up the medial hemiplateau, put in bone graft, and then plate it adequately. So once you've done that, you will get correction of the intra-articular problem as well as the overall limb alignment. So if you see the two sides, they are very similar. And this is him at follow-up at 1 year. You can see both the limbs look the same. He's got a good range of motion and good function as well. So what about intra-articular depressed segments? There, the whole plateau could be elevated. Here, you have a segment that is depressed. If you look at the lateral side, you can see that there's a step on the lateral side on the AP X-ray. You need to get CTs to really assess these more carefully. This is the CT, and here you can see how there's the posterolateral depression of that segment. And this lady was actually sent to me for instability of the joint, thinking about a ligamentous injury. So here you have to again plan how you would do it, because you can see the periphery of the joint is still in a reasonable position. So you need to get access to this articular portion. So you do your standard lateral approach with a submeniscal arthrotomy, but here you have to take off the lateral wall to get a really good visualization of your depressed segment. So we do that with an osteotome, a combination of saw and an osteotome. You look into the joint now, you can see clearly the depressed area going down there. So you can see the depression posteriorly here. You get into the area where the original fracture was, taking along with it a good area of subchondral bone, and then elevate this entire area. Since this is an old case, we don't normally put in bone grafts for fresh cases, but for these old cases, here we used bone substitute. Once you've got it reduced, you put a wire to hold it in position, and we actually take it across to the other side so that it doesn't get in the way of the plate once you're putting the lateral wall back. So here's the bone substitute that's gone in, and then once we do that, we put the lateral wall back, we plate it adequately, and so you've got a good stable fixation which you can start early range of motion. That's her post-operative X-ray. This is her at 1 year post-op. So again, you can see how the joint is nicely reconstructed and she's got back a good function. Different case here, you can see the problem is on the posteromedial side here. You can see this clear double shadow here. You do your CTs and you can see this huge step off on the posteromedial aspect, and this only involves the posteromedial aspect. And this is now 5 months down the line. So here you'd have to approach it posteriorly. This is the C-arm picture at the beginning of the surgery. Again, you can see that clear double shadow on the medial side. So you start from the posterior side, you do your osteotomy more or less in the plane of the original fracture. Once you've completed your osteotomy, you get that fragment up, you position it with a wire, you put in bone graft, and then you put your buttress plate on it. You also added a lag screw to hold that fragment in position, as you can see. And this is again her follow-up. You can see how she's got back a good range of motion, good function, and this is her 18 months down the line, still maintaining her joint quite well. And again, you can see now this double shadow on the medial side has completely disappeared. So coming back to the case that I showed you first, this gentleman, so here you have a problem on the lateral side as well as on the medial side. You can see on the CT there's a split depression on the medial side, while you've got a big depressed segment on the posterolateral segment. So here what we did, we started on the lateral side, we took out the lateral wall so that we could see the depression, and you can see the depressed area of the articular cartilage there. Once we've done this, we actually went back to the medial side. To get a good approach to that fragment, we did a sort of medial epicondylar osteotomy, and that gave us a good visualization of the depressed area. This is the posterior part, this is the anterior part. We did our osteotomy through that, elevated this part, and then put a lag screw from front to back, holding that position so that we could compress that, and then we put a buttress plate at the back there to hold that posteromedial part intact, and then we fix back the medial epicondylar osteotomy with a screw and a washer, with a spiked washer. And then we go back to the lateral side, we elevate the depressed area here, we put in bone graft to hold that area, and then we still have this problem of the lateral wall, because this being an old case, we can't get the lateral wall back. As you can see, the joint was not contained. We need to get containment of the joint. So to do that, we actually take off a bit of the lateral wall with the saw. You have to check how much you need to take out so that you get it back with the articular cartilage in the right place. You need to nibble at the back because you can't go safely through with the saw right at the back. And then once you've done that, you get it back again, you fix it in position, you check that now your articular surface is congruent as well as your joint is contained nicely. And this is him at 4.5 months post-op. This is him 9 months post-op. This is him at 15 months post-op. You can see he's walking quite well. He's able to squat. And this is him at 4 years post-op. Again, walking well. He's able to jog as well. So he's done quite well. So we've been able to salvage this joint at least for a reasonable amount of time. And hopefully he'll continue for some more time as well. This is a slightly more complicated case. This one, we actually got our assessment slightly wrong. This was the original X-ray. It was treated elsewhere. This was the area that is of significance, this anteromedial part, which is actually out of the joint, apart from a posteromedial depression. And he was treated by someone about 1 month down the line. And if you just look at these X-rays, it looks like a reasonable position, but if you look more closely, that fragment, that anteromedial fragment is still lying outside as it was earlier. So that's how he presented to us about 5 months down the line. You can see the CTs again very clearly. You can see that area which is lying outside the joint here, the anteromedial fragment there. That's the magnified just area of that. You can see this area is outside. And we started this off with the same idea of just elevating this posteromedial part. And then as we were in surgery, we did a medial epicondylar osteotomy. We got the osteotomy of the posteromedial part. And then we realized that this anteromedial part is lying outside. So here we had to then change our tactics a little bit. We had to re-osteotomize the lateral side. So this is the lateral anteromedial fragment lying right outside here. So then we had to do an osteotomy across here, across to the lateral side there, take off a bit of bone so that we could get this down into position. And we put a distractor on at this stage after we had done our osteotomy so that we could get this patient back into, get that fragment back into position. We fixed a screw across once we had got all these things nibbled out so that this fragment could get into place. We got it reduced. We clamped it with this collinear compression, collinear clamp, and then put a screw across from the medial side to the lateral side. This is a 6.5 canceller screw. And then we put one from anterior to posterior, which was a 3.5 screw. And then once we had done that, we completed the fixation with a buttress plate on the posteromedial side and went ahead and fixed the medial epicondyle with a spiked washer. We kept on the fixator as a spanning fixator for 4 weeks to unload the joint before we started range of motion exercises and mobilization. And this is him at 18 months post-op, and this is him at 3 years post-op. He came back quite recently, and you can see how beautifully he's still maintaining the joint and has a good function. So I think we are able to sort of get these patients reconstructed in many situations. Unfortunately, sometimes they also have combined bony and ligamentous problems. This is a young gentleman who was initially treated with this nail before they realized he also had a proximal tibial fracture. And if you look carefully, there's an avulsion of the lateral collateral ligament from the femoral part. So he came to us at 3 months. That was his clinical position. He has had significant varus instability. So we went in here, we did, those are the CT scans showing it. And again, you can see this fragment here, which has come off from the distal femur. So we went in, we did an osteotomy, intra-articular osteotomy for the proximal tibia, and also were able to fix back the lateral collateral ligament with a spiked washer and a screw, and he did quite well. This is him at 1 year post-op. He's stable now, he's walking all right, and his function is well restored. Like I said, unfortunately, not always that we can get a good result. This was a 55-year-old gentleman who was initially treated elsewhere at a late stage. So he initially went into malunion, then someone operated on him, but you can see how this joint is still not contained. He was very stiff. He had this fixed flexion deformity and almost just a jog of movement. And we went in, we reconstructed it, we put in this spanning fixator, and at about 4 months down the line, he was still very stiff, so we did an arthroscopic arthrolysis and got him moving to about 70 degrees. But then in his physiotherapy, they went ahead and they managed to fracture his distal femur. He did not want any further surgery, so we just treated that conservatively, initially in a cast and then bracing. And eventually we got him to heal, and that was his range of motion. And it wasn't bad considering what he came with, but it wasn't a great result. And we also got a CT done, so if you look at that, the articular reconstruction wasn't too bad, but the result was really not as good as one would have expected. So I think there are complications along the way, and obviously infections, stiffness of the joint, inadequate correction. You can have implant-related problems, and some of these will eventually end up with osteoarthritis. But if you're able to delay the total knee replacement or any other sort of salvage surgery, it is really worthwhile. So in conclusion, I would say that these intra-articular malunions need to be assessed very carefully, assess the clinical problem and the possibility of reconstruction. I think osteotomies need to be planned carefully to address both the intra and extra-articular elements of the deformity. And if you're able to do this, I think the results are really quite gratifying. We're able to salvage the joint in many of these patients. Thank you.
Thank you very much. And may I request Dr. Robert to come over? And there is one question, that why do we call it putty plat and not plat putty?
Can I make an announcement? May I request the audience to be reasonable and switch off your mobile phones or put it in silent mode? I know you're all busy practitioners, but not only are you disturbing the faculty, you're disturbing the person sitting next to you. It's a basic decency which I request from you guys.
Thank you very much. Either keep them on vibrator mode so that you are kept awake. And so the thing is, putty was the student and plat was the teacher, but it didn't rhyme well. So here also they have kept the speaker John first and then Robert. So Robert will talk to us about the tibial fractures, bicondylars. And he is going to have another talk immediately.
Yes,
so
sir.
Be prepared for it. Thank you. And please, phones on silent or vibrator mode or switch it off.
Well, I want to thank you. I'm honored to be back. This is actually my 4th time here in India. And one thing I've learned is you don't want to be the guy who has to follow Dr. Mukhopadhyay. I guess all I can say is that if you do some of the things here, maybe your patients won't wind up in the next edition of his proximal tibial malunions talk. So at any rate, greetings from Seattle. You know, this is about the time of the year when the official colors go from blue and green to light and dark gray, and it'll be like that till the end of spring, but it will come back, right? So we're going to start, just as Dr. Mukhopadhyay did, we're going to start with a couple of easy things, but then we'll get rolling, right? This is just a medial unicondylar fracture, dirt bike collision about 30 miles an hour. And you can see, not so displaced, but these are really vertical fractures subject to shear and displacement. You can see here on the CT, it is displaced, even on the, particularly in the sagittal, you can see it's already short, right? So these are ones we're relatively aggressive with. So we start with a posterior medial approach, supine, but you can do it prone or figure 4, depending on what you need. You get your incision along the posterior medial border of the tibia, mobilizing the hamstrings. And this is mostly an extra-articular reduction, although you can do little things to see your reduction at the joint as well. It's mostly fluoroscopic. So you want to get that clicked in. Valgus extension and traction are your friends to help you get the reduction here. Here's a couple of clamps. I like to get the anterior tine on that hard bone of the tubercle to help click that in. Here's our provisional fixation, and relatively simple, just a distal radius T-plate for our fixation here, right? Here's his post-op films, and at 8 weeks, he's not very painful. His motion's pretty good. He reports he's been cheating and has been walking with a cane since week 4, but hasn't displaced, right? So another relatively straightforward one, 58-year-old woman. She just fell 3 steps. It's an isolated injury. It's like not very displaced, but it is bicondylar, right? Her soft tissues are pretty good. So maybe acute management rather than staged is good for this, right? So you can see it's a relatively simple articular pattern. So our options for treating bicondylars are 2 incisions, 2 implants, typically, right? Or a single locked lateral implant. You gotta think about what conditions might favor using a single locked lateral implant, right? We look like we've got them here, right? A large medial fragment, non-displaced or reducible medial column, a simpler medial pattern, right? No comminution, poor medial soft tissues, a poor host who you may not want to risk having a second incision, or you've got arthrosis already, maybe you don't want another incision there for that reason as well. If you are going to do this, my tendency has been to use a larger fragment plate if we're trying to hang this off the lateral side. They use the 4-5 as opposed to a 3-5 plate, which can sometimes be rather flexible. Remember that it's pretty variable on which implants you use, that you may not be able to get as much fixation as you think posterior medially. So these are probably best for those full medial condyle fractures if you're going to do that, right? So here we're getting going with a reduction in provisional fixation. Here's our fixation, kickstand screws, the finals, 3 months post-op. Okay, so now let's get to some real bicondyles, right? This is a 46-year-old male in a motorcycle collision. There's a splinted view. It's a little bit better. What if he starts having a little increased pain, swelling, sensory changes? We've got to think about compartment syndrome in these patients as well, but we'll come back to that. He was fine, right? So here he is in the spanning external fixator. We're going to treat him in staged fashion because his soft tissues are not amenable to acute surgery, but you can see our goals have been met. We've got the tibia underneath the femur in both views, and we just ride this out until he's ready to go. And you know, this is good. Knee spanning is good for patients with higher energy injuries. I try to keep the pins from remote from incisions and implants. You know, the truth is like, you don't have to do this for all bicondylar. Certainly we wouldn't do that for the first lady. So here's our axial CT. You can see the central displacement there, sagittal reformats, and our coronals. Pretty big piece medial, but it's displaced enough that it really needs a little bit more than a locked lateral implant probably. It's the same approach though, but we start posterior medial. If you got 2 things to do, I want to do the simpler, more reliable thing first, right? Because if you don't get the first thing right, then you're not going to be able to get the second thing right either. So we do the simpler posterior medial, the medial column. We key in that metaphyseal reed. You got to put the plate such that it contains or buttresses that metaphyseal apex of the fracture. It's not unusual for me to use a distractor to get this out to length on the medial side. You can make a small arthrotomy. It's a little more difficult than on the lateral side where you can do a wide submeniscal arthrotomy, but you can make a small inline incision in the MCL to see that white border of the articular surface. You can't go very large because of the intimate relationship between the deep MCL and the medial meniscus, but you can get in there to see and just make sure you're correct. And remember, with your screw length and orientation, don't block your lateral reduction, right? So now we've done that. We'll often get an intraoperative plain film because we can't really trust fluoro for alignment. Here we come to our anterolateral approach now, and you can see from the bovine marks we've elevated the iliotibial band off Gertie's tubercle, so we make an anterior and posterior flap that will close later over the plate. We haven't done our submeniscal arthrotomy yet. Here we are. With that, we've put sutures into the lateral meniscus, and we've tried not to skeletonize the proximal tibia so we can repair that back later. Now, if you do skeletonize the tibia, you can just put your lateral meniscal sutures. There's always tons of tissue on the femoral side, but we try to leave enough so that we can close our arthrotomy nicely. Here are our goals, alignment being the foremost among them, right? But getting condylar width and articular congruence correct, maintaining our meniscus and getting stable fixation while avoiding complications is equally important, right? Here's her post-operative films, and here it's at 6 months. Pretty good. She doesn't have quite full extension, pretty good flexion. She's back to work in an office, right? We got another bicondylar. This is a gentleman, he was an isolated right bicondylar. He did have an acute compartment syndrome. He was actually in Montana and had that emergent 2-incision 4-compartment fasciotomy. Before he was sent to us, they did put him in an external fixator. So there's the two. This is actually a picture of another 2-incision 4-compartment fasciotomy. And now what are our options, right? Fixation at the time of fasciotomy. You know, you may want to think through this complicated fracture rather than doing that. Fasciotomy, closure, or coverage at the time of definitive fixation. That's sort of what I've tended to do, whether I may do a skin graft after I do my fixation, or early closure and split thickness skin grafting early and then later definitive fixation. I did that early in my career, and the skin graft never seems to be ready for you to do it. So that's sort of faded away from me, at least. So in looking at plateaus and compartment syndromes, that can happen before, during, or after the X-fix. So you got to keep an eye on these patients, right? It'll probably increase the rate of infection in non-union, probably triple the rate of infection in these fractures, upwards of 20 to 25%, right? And closure and split thickness skin grafting at the time of ORF may be better, at least through the Dabina article there, right? Let's think about our strategy here. Think about the underlying fracture and our next step. You may want to draw out your anticipated incisions. Do you want to incorporate your fasciotomy incisions? Well, here's a little food for thought. One of our fellows this year, this is unpublished data, looked at this stuff, single incision versus dual incision fasciotomies. Well, single incision fasciotomies, which is relatively over the fibula, right, is further from your ORIF incision, like a standard anterolateral. We looked at 190 plateaus plus acute compartment syndrome, and we found that the infection rate for the single incisions was 18%, whereas the dual incision was 41%. Now, there could be some selection bias in there, but it's notable just the same. Notably, the dual incision ones are more likely to incorporate in the incision, particularly on the medial side. A lot of people just extend the incision up from their fasciotomy to do their posterior medial incision. And particularly, if they were incorporated, they had significantly more infection, right? And if you had dual surgical approaches and infection, if you had a single incision fasciotomy, it was 21%, which is pretty much standard across the board for the data that's available. But if we had dual incision fasciotomies and then dual incision fixation, the infection rate was 60%. So think about a single incision fasciotomy, right? So here's our post-span CT. You can see that one of the pins is still pretty close to the fracture, maybe be in the way of the hardware, and you can see that tubercle fracture as well. So what he had done afterwards in Montana, he had IND of this fasciotomies a couple days later. They closed the medial incision, and then they transferred him to us. We did a fasciotomy IND of the lateral side. All the muscle was pretty good, so we did a DP, a delayed primary closure of that. And then we got on to fixing this. Through the distal end of our anterolateral, we fixed the tibial tubercle because that had a big piece of the anterior medial joint on it as well. We figured getting that set was going to set him up for success. So here we are with that. We've drawn out the whole anterolateral, but now we're fixing our tubercle, and we've got it clamped up, a little 1/3 tubular plate, and there it is. And now he's set up for the next stage. So when I first got started at Harborview, I was noticing that we had tibial tubercle fractures in a fair number of our bicondylars, and I looked to see if there's anything in the literature, and the only paper I could find was this Chakravarti paper. It's actually out of Harvard. What they had done was they wired around the screws and then over the top of the tubercle, and it just didn't make great sense to me. It just seemed like it would be better, like we'll get an anterolateral approach, you can just come over the top and do lag screws or a little plate like we did on the patient here. And right now, we initially protected them from active extension, but since in the last several years, we've made no change in rehab. We let them do active extension right from the get-go. In terms of the X-fix and the bicondylar, with the pin plate overlap, some papers say it's worse, others are less compelling. You know, if you're right there anyway in the OR, we decided to change the X-fix just to get that pin out of the site so there'd be less overlap. We did repeat the CT, which is unusual for us, but you can see that there's a little push out the back. He's got some posterior lateral, he's got significant depression. Here's a 3D. So we decided to start with a prone posterior medial approach, and I am not an expert on this. I am not Dr. Frosch, nor the gentleman who spoke last night so eloquently on posterior laterals, but just the same. We started with this prone posterior medial approach after Lobenhofer, but Berwin described this FCR, making the analogy this is like the volar approach to the distal radius as well. Here we're coming down on the medial head of the gastroc, and it's between the gastroc and the hamstrings, and then we lift up the popliteus, and voila, the fracture site is exposed, right? The gastroc and the popliteus protect our neurovascular bundle, and we can get a pretty good reduction, at least posterior medially here. We could get all the way over, and what I really wanted to do with this one is to make this a contained defect. I'm not reducing the posterior lateral thing. I'm getting this non-contained defect more contained. And you got to think about what you want to do on that posterior lateral side, right? So I can get to about where I am here with the incision I made. If you want to get further posterior lateral, you probably need to go over a transverse limb of that and maybe do a gastroc tenotomy, and you still have to stay deep to all of this to protect the bundle, of course, right? So you can get something like that. So most of our posterior lateral fragments are contained, and a lot of the time we're still doing this from the front. But if we really want to see this, sometimes we'll make a second posterior lateral incision so we can see that reduction, right? And we can see that elevated, get our provisional fixation, put our fixation in here, and sometimes what we'll do is we'll put screws over the top of our rafting screws after we've fixed it. You can see that anterior to posterior screw there, right? So now we've got what I like to call crossbar fixation. So you've got your rafters in, you've got this fracture in the back, and this is probably best if these are really not particularly displaced, but you want them well supported, right? So the rafter screws keep the anterior to posterior screws supported. If you want to see that, but you don't need to buttress this, you can do suprafibular approaches. You probably want to be more lateral in this case. The incisions, you can do that to 1 or 2 windows as well. And these implants really support, but they don't buttress these fractures. Now, if you really need to see and buttress, you probably need to do a pure posterior lateral approach behind the nerve and the biceps and taking that up. The problem is this is not particularly extensile, and whenever I've done it, I've always felt like I'm sort of working in a hole. If you really want to go on to heroic efforts, you can do transfibular approaches that really give you a pretty good visualization of this, although you have to contend with fixing. There is some problem with the fibula having trouble healing in some cases. So one thing we've done, which is significantly simpler than doing fibular osteotomies, is a lateral epicondylar osteotomy. Dr. Mukhopadhyay talked about the medial side. I've done that for medial Hoffas, but not plateaus. But on the lateral side, we do it for plateaus, and it's relatively simple. You can use a saw. You can just use an osteotome as well. It definitely increases your posterolateral exposure. You can add the popliteus insertion as well, and if you don't, you really need to work out the popliteal capsular stuff as well so you can see. And you can even do a central subluxation of the lateral meniscus to see a little bit better as well. So here's our guy. This is actually one of the times we did this on a lateral epicondyle. We've got this, we're tamping this up. We've done the epicondylar osteotomy. We can see in there, you can see how much wider it is on the lateral side just by having done the epicondylar osteotomy. And you can see the plate as well wraps around, but it's not a buttress plate. It's really corralling or supporting that re-elevated fragment. And here's the finals, right? So now back to our guy, right? This is like Kalila and Dimna, right? We're inside one of the stories and we've come back out to our original case, right? So we're doing the proximal extension of the approach anteriorly that we use for our tubercle approach, and now we're doing a submeniscal arthrotomy, maintaining that tissue at the level of the joint, and realizing that we got to look for a meniscal tear, right? More widening or depression, more likely to have it. About 30% of lateral menisci require operation and fixation. And the outcomes are pretty good. They're almost all peripheral tears. There's not a lot of data on this, but I can tell you, I think I've re-repaired one lateral meniscus in 24 years. We used a femoral distractor to improve the visualization here. You can see how wide it is on the lateral side, and you say, where do those pins go? Put the one on the femoral side up high enough so that the works of that aren't in your way when you're trying to see a lateral, and then the other one's down below, and then just attach that there. In terms of supporting the articular reduction, you can use autograft. We typically use allograft, cancellous allograft, but you can use hydroxyapatite. We use calcium phosphate as well. So those all work pretty well. One thing we use a lot of is metal, right? We still use K-wires and mini fragment screws to support our articular surface. Here are our final fluoros. He gets 24 hours of antibiotics, non-weight bearing for 12 weeks. We start him as soon as his incision is dry with motion, with a focus on early extension. No limit on active extension. So this is the last one. This is a rather extreme example. It works as a PA. He had a bicycle accident. He's got a hyperextension injury. It's about 55 degrees off. These are high energy injuries. You gotta look for neurovascular injury. He had anterior medial impaction. These often have massive anterior defects, and they do worse than other bicondylars. We noticed this, my colleague Reza Firuzabadi wrote this up about 6 years ago. And remember that because of the posterior slope is the other way, the deformity is additive, right? So we get him in an X-fix, and we get a CT. The joint is actually not that bad, but again, he has that massive defect anteriorly, and you gotta restore that posterior slope, so we're using bumps, distractors. We put multiple Steinman pins, trying to distribute the force. We'll use osteotomes. I'll use a laminar spreader and then put osteotomes on either side to broaden the area so you don't go through the bone. And think about flexible fixation posteriorly like a hinge, right? And then you got to get something structural in there. And here's using a cage to help support that. On our patient, we actually, after I elevated him up, I actually used a fibular allograft. It wasn't even enough, so I had to get another one and put a shim on top of the first one to get him back up to essentially just beyond level. And here we are fixing this. Here he is at 3 months. Okay, so that's a lot, right? So in summary, these are a wide array of injuries, right? Stage treatment with an X-fix can be useful in the higher energy ones. Anterolateral and posterior medial approaches are the workhorse approaches, but in select fractures, particularly posterolateral, these often require more creativity. And alignment, congruence, and stability and maintaining the meniscus are the goals for a good outcome, but avoiding complications is just as important in outcome. Thank you.
Thank you very much, and you can go ahead. Second part you want to take up, sir? Timing, approaches, and fixation strategies in tibial pylon fracture. As I told you that there was a big personality, Robert John. So we are having John Robert, so Robert is now talking. Keep your questions ready at the end of it if you are not feeling very hungry, because we have overshot by around 4 minutes.
Yeah,
so
I'm sorry I'm the one thing between you and lunch, and I wish I could tell you this was going to be quick, but I'd be lying, okay? All right, so we're going to talk about the rationale for stage treatment, the rationale for choosing surgical approaches, and the rationale for fixation constructs, right? I believe in stage management. I believe in that skeletal stability aids in soft tissue recovery, and I believe for pilons and most periarticular fractures that internal fixation is a good thing when it's possible. I have a lot of unpredictable patients, as you may also, with high energy, polytraumatized patients and with one or more comorbidities, right? So pilons are life-changing injuries, right? A lot of these people can't go back to work, can't do a single leg stand, may continue to have pain. Most will never run again. And amazingly, the SF-36 scores are worse than for cardiac disease, diabetes, or AIDS, right? So these are bad injuries. So why are they so bad, right? Well, there's a bony injury that adds to the soft tissue injury, the tenting of the skin, the kink in the vessels, bone loss in open fractures, right? Many have severe articular injuries with multiple fracture lines, impaction, potential for cartilage death, and then a propensity towards arthrosis, right? The bony injury is really easily defined, right? It's static, right? You just get the imaging, it is what it is. Unfortunately, the soft tissue injury is much less easily defined. It's dynamic, it's evolving, it's difficult to quantify, it's difficult to assess recovery, right? And the soft tissues don't tend to recover as well. The muscles become fibrotic and the tendons adherent, and as does the joint capsule and the ligaments, right? So it's problematic all around. So what are our goals? Well, we want function, right? And what does that mean? Healed, aligned, reduced, and mobile, right? And while avoiding catastrophic complications like the ones we see here on the right. No wound problems, no infection, right? The 70s, 80s, and 90s, there were high rates of misery when people tried to fix these things, and that led to this brief era of nihilism where this contraption, the hybrid external fixator, had a brief moment in the sun, at least in the US, in the 1990s, right? So by the end of the 90s, Mike Sirkin and Dean Cullett figured out that you could do stage management with an early X-fix, and this really mitigated the problems. Right? If you waited out the storm and had this out to length and aligned, this really made the infection rates lower, right? So what do? You fix the fibula often, right? You do an external fixer from the tibia to the foot, spanning the ankle, either a medial frame or a delta type frame. Then you get your CT afterwards, and you plan that out, and you wait for the soft tissues to recover, or you refer it on to somebody who wants to do this more than you do, right? So if your leg looks like this, red means stop, right? We just don't proceed for that because that's a recipe for disaster, right? When do we go? Well, when we start to reepithelialize after the fracture blister, and we don't go on when day 1 of the birthday party balloon, we go at day 7 of the birthday party balloon when the swelling is starting to come down, you see this wrinkling, right? There are papers that support early definitive surgery, right? With complication rates that they claim to be comparable to stage management, they do talk about exclusions, and they do say there's more problems in patients with diabetes, psych issues, ETOH, and neuropathy, which it sounds like my patient population, right? So what's the rationale for early definitive surgery? Well, it's easier, right? The fragments are mobile. They haven't been sitting short for 2 weeks. The hematoma is liquid. It's probably easier to do. It's certainly costless. You don't have to do an external fixer. There's less surgery, and we're sooner to recovery, right? So it's fairly compelling. But how can we predict the development of the soft tissue problems or how they recover, right? Well, my take on this is that this is probably appropriate for early surgery. For select low energy injuries, the more torsional ones, right, that happened moments ago in reliable patients with good physiology. And you really ought to have an experienced surgeon who's making this decision, because what if you guess wrong, right? That's hard to bounce back from. So stage 1, fix the fibula, right? Get the frame on, get the tibia, talus underneath the tibia, right? Fixing the fibula, there is support for not doing that, but the fixed bone is the best splint. Fixing the fibula helps you get the talus underneath the tibia, helps get that lateral column correct, and helps support your soft tissues. And it might be the only guide to tibial length in some cases, right? So having that is probably worthwhile. So the other thing that it does is if you get the fibula out to length, by virtue of its ligamentous attachments, the Schaput and Volkmann fragments, you get those out to length. You get a partial indirect reduction of those without even having gone after them, right? So the argument against doing the fibula in stage 1 is there's more soft tissue injury, right? Maybe that if you haven't done enough on the tibia, it favors varus collapse. Some people feel a short fibula is not problematic in the long term. And then what if you got to do a posterolateral approach, right? So maybe you'd have to reopen the wound you just made. So if you do it, okay, if you're going to do it, you got to get it right. You got to get it right in the coronal plane, you got to get it right in the sagittal plane, and even the rotational plane, right? So when do you not do it? Well, an unstable patient, in a patient with a rapidly evolving soft tissue envelope, you can see the fracture blistering appear before your eyes, a fracture that's likely to require a posterior approach, or if you're not the one who's going to do stage 2, maybe leave the fibula alone, let the next guy make the decision as to whether he thinks he needs it or not. Right? So what can we do to get the edge on these sometimes terrible fractures, right? You can do intermedullary fixation of the fibula. You get a simple pattern like a tension failure varus pilon, right, with a simple fibula fracture. You can do closed or percutaneous fixation, and then you don't even have a fibular incision, right? So you can use screws and fix that later. You can do flexible nails. There's even nails designed for the fibula. I don't have any experience with them, but they are out there, right? You can take advantage of open wounds, right? This is a medially open wound. After I do our debridement, we use a very low profile 2.0 straight plate with 2.4 millimeter screws, and that controls us so that jutting bone, that distal end of the proximal segment, isn't tenting that skin, and you don't even need to go back there, right? You can just do an anterolateral and leave that there, right? We can also upgrade some C-type to B-types, right? About 10% of pilons will have a long extension into the shaft, right? It's typically attached to the Volkmann fragment, and it's usually proximal to the vulnerable soft tissues down at the ankle. So what you do is you fix that acutely while you still have that liquid hematoma. You get your shaft component right, and now that's attached to the Volkmann, and you've turned a C-type total articular fracture into now an anterior B-type, right? And then you can proceed with the rest of the second stage when the soft tissues allow. Okay, in terms of approach, there's a lot of approaches, anterior medial, anterior lateral, essentially around the world, and these have all been well described because we're thinking about our major fragments. Peter Cole described this pilon map of the characteristic fragments. The only thing really left out, right, is that die punch, and we need to be able to get to that, right? So the two things that help you decide what approach you use are your fracture pattern, but even more than that, right, the condition of the soft tissues, what can they handle, right? So with a varus pilon, right, tension failure fibula, you can, you can have a valgus pilon, or you can have an axial load pilon with no fibula fracture, right? So for that varus one, well, you need a medial buttress, so that probably favors an anterior medial approach, right? With a valgus pilon, you're going to reconstruct the lateral column on the lateral side, probably fix the fibula as well, so that may favor an anterolateral approach. And with an intact fibula, your incision is based on your soft tissues and your CT. So in the sagittal plane, if you've got B-type dislocations, you're going to follow that in order to be able to buttress the displaced fragment. So the other way you decide your incision is, how big is a Chaput fragment, right? How am I going to get into this fracture, right? So if I have a small Chaput fragment and that exit is relatively lateral, well, I'm probably going to do an anterolateral. If it exits way medial, that probably favors an anterior medial, everything else be excluded. So you look at all these fractures, right, and you can decide which one. The ones on the left favor anterior medial because the exit point between the Chaput and the medial malleolar components are so medial, whereas the ones on the right, far smaller Chaput fragments may favor an anterolateral approach, right? And then that's also saying, how do you get to those areas of impaction, whether anterior or posteriorly, right? You got to get all that impaction sorted out when you're dealing with these pilon fractures. The other thing to think about is there can be entrapped posterior medial structures, right? These long tendons, posterior medial, and even the neurovascular bundle can get caught between the posterior edge of the medial malleolus and the medial edge of the Volkmann. So those sometimes need a specific approach to get those out and some stabilization so they won't go back in there, right? What can the soft tissues tolerate? Well, if you get somebody who's poor protoplasm and a high energy injury, an anterior medial approach is not relatively forgiving. In those patients, I may be more likely to push the envelope on an anterolateral approach, or maybe have limited goals, or maybe even use an adjunctive X-fix if I need to, and because the soft tissues can't handle a lot. If you got a previously open wound, that may favor an anterolateral approach. If you got crappy lateral soft tissues, that may favor an anteromedial approach, right? There are other patient particulars, right, that may make me a little more reticent to do an anteromedial approach as well. Comorbidities, patients' problems with compliance may make me do something, because if an anterolateral breaks down, you can skin graft that, right? An anteromedial breaks down, you may wind up with a flap, and if the patient's not a flap candidate, well, you may be looking at an amputation. Okay, so 37-year-old guy, 6'3", 325 pounds, right, 147 kilos, a little hypertension, works as a computer program. He fell 15 feet. You see what's going on here? He's short. The Chaput fragment is completely dislocated, right? So this is not a torsional injury. This is an axial impact fracture, right? He's splinted, but not much has gone on with that Chaput fragment. So what do we do now? We're going to start with a spanning external fixation. We're trying to get the talus underneath the tibia. We've done that. We distract him a little bit. And then we get our CT, and you can see the Chaput is still rotated. And what else do we see? Well, you can see there's some comminution up in the shaft. You can see there's articular fragments, like well displaced proximally, right? So what type of approach are we thinking about? Well, if we need to get up the shaft, the anterolateral is not particularly extensile, but the anteromedial is, right? This favors an anteromedial approach, and you can either do this following the medial edge of the anterior tibialis, or you can do the curved type approach where you wind up, you turn about 70 degrees at the level of the joint and wind up a centimeter distal to the anterior colliculus. I would say that I've been trending more to the first, because it just helps, and I don't like having that flap edge, particularly in unhealthy patients. When do we use this? You get a large Chaput fragment, you get extension of the shaft, significant work required medially. If the fibula incision was too anterior, if you got poor lateral soft tissues, these all favor an anteromedial approach. So here we are, we've opened this up. We try to stay outside the anterior tibialis peritoneum. We don't want to see the tendon itself, don't want that to desiccate. So we make our incision medial to that and sweep everything laterally, right? We've now reduced this. We've got our clamps on. We've got our provisional fixation. I've lagged this here. We've lagged the shaft components together, and now we work on the joint. And yes, you can put a anterolateral plate on from an anteromedial approach, right? Our closure is of equal importance. We put in all the sutures before we tie any, right? We put in, and then we bring them all together, and then we do the same thing with the skin, right? This is the Algar modification of the Donati suture that's been shown in a couple of papers to be favorable to flaps and leave the tissue well vascularized, right? Here he is at 3 months. A little bit of loss of reduction, right? But at 9 months, he's got not a ton of dorsiflexion, but no pain. He's still a little tight and still improving, he says, right? We got a valgus open peel on here, 33-year-old woman, pedestrian struck. Here she is splinted. Here's our X fix. Okay, and here's our wound at the time of external fixation. Now, her joint's not bad, right? And we don't want to probably go anteromedial because of our previous wound. We'd fix our fibula. It's a little short, so we worked a little bit more on that, got that out to length. You could see that it was probably externally rotated, so we worked on that. We got our CT scan post-spanning, right? And we favor an anterolateral approach here. The one thing I would take issue with this is I don't want to see these, the tendons that we see here, and I typically mobilize the superficial perineal nerve medially, so I'll mobilize that up higher so I can tuck that under the medial edge of that, right? So when do we do anterolateral? Smaller Chaput, more lateral comminution, poor medial soft tissues, poor protoplasm in general, right? And we save the ATFL and we just rotate that open so we can get into the fracture, right? We put our distractor on at the anterior edge of the talar body, or the junction of the body and the neck, right? And then we start from the back. We work from the back to the front. We derotate the posterolateral fragment. We fix the posterior medial, the posterolateral. We get the central comminution done, and then we reduce the anterior and close the door with a chaput to the medial edge, the lateral edge of the medial malleolus. Get our K-wire fixation, and get our fixation, and then hook that to the diaphysis. All right, so here she is. We fix that. I just want to go. She had crappy medial skin, so we used a bicortical medial malleolar fixation as opposed to a medial plate. And here she is post-op. She got a regional block. She's again 12 weeks non-weight bearing, early motion. We elevate her to minimize swelling and risk the flap. Right here she is at 3 months, and at 7 months. She says she hasn't returned to work, but she was able to walk for miles at Disneyland, right? Can we reduce the joint from the front? Do we need a posterior approach? We tried really hard not to do posterior approaches if we can avoid it. Most fractures get an anterior medial, right? But not everyone can be done that. So we got a 33-year-old guy who fell 20 feet. You can see his back of his joints out the back. Even with a CT scan, it still doesn't look like an ankle. Usually when you do X-fix, at least it starts to look like an ankle, but his doesn't. And we did first a prone posterolateral approach. And then we flipped him supine and did an anterior medial. Fixed our chaput reduction and stabilized that as well. And here he is at final radiographs. Here he is at 6 weeks, 3 months, 6 months, and a year. He's working in a warehouse. Okay, last one. So 35-year-old guy, fell from a second-story window, distal radius fracture. This is a closed fracture, and this is that long extension of the shaft that we talked about before, right? This one actually extends to the medial malleolus, right? So we did that C to B fixation, but he still has his, he's still out the back posterior. He still has a significant Volkmann fracture. So you can see here is a CT, he's got significant displacement. Now, 2 years ago or more, I'd have done a posterior lateral automatically. I think now I'd do a posterior medial. This is pretty medial, right? And I think I can get more lateral with a posterior medial than I can get medial with a posterior lateral, right? So he got a posterior lateral, but if I was doing him today, he'd get a posterior medial. So at any rate, we fixed him in the back. First we were able to get it, and then we flipped him anteriorly. We did a little rim plate for his articulus, and then hooked the whole thing to the articulus, to the shaft. And here he's at 6 weeks, starting to weight bear 6 months at a year, right? So in summary, Pilons are high energy injuries with axial loads, the characteristic mechanism. Stage management can be useful for a lot of these, right? And the surgical approach is determined by fracture pattern, soft tissue conditions, and other patient-specific problems, right? And mechanically appropriate fixation strategies favor but don't guarantee a progression to uneventful union. Thanks.
Thank you very much. And I'm sure if at all you are hungry, you may go, but do not make any noise. And if you stay here, you will get food for thought, and really it will be very interesting. Robert, you dealt with this situation of pylon fractures so beautifully well that I thought it will go on, and we'll learn a lot from you, but every good things have to end. If there are any questions, please raise your hand, and people over there, please send the microphone to the person who wants to ask. Dr. Ramprabhu, yes, sir.
Yeah, so John.
All of us can come in the center so that you can and pick up the microphones. Yes, Dr. Ramprabhu.
So, John.
Sir, please come.
This question, you have been managing such complex malalignment of this upper end of the tibia. Just to have a precaution and have a cartilage alignment, do you do any arthroscopy pre-op or post-op or during intra-op? Because, you know, just eyeballing this articular alignment sometimes is not good enough. Or Siam.
What we do is we do get MRIs in some of them. So the ones we think also have a ligamentous injury, we would get an MRI pre-op. We don't scope them intra-op normally because we can get pretty good visualization from both sides. So if necessary, you go medial and lateral, and you can get pretty good visualization. But I have no problems with someone putting in a scope, but we haven't felt the need for it.
Yeah, so intra-op, do you make always sure to go intra-articular and see the alignment?
Yeah, you need to see the joint
exactly
is adequately reduced, and alignment you check from your sort of diathermy cord, etc., and clinical assessment.
So if needed you do a submeniscal opening.
Arthrotomy always on the lateral side. On the medial side, like if you do a medial epicondylar osteotomy, you get a good view of the joint altogether.
Wonderful.
And we would sometimes go, I mean, didn't show a posterolateral approach to it, but sometimes if it's, the main problem is posterolateral only, we might even do a fibula osteotomy to get a good visualization.
So probably the same question.
Recently we've been doing the lateral epicondylar osteotomy with taking off the popliteus. Yeah, that is a lot easier, but I think the best visualization you get is with the fibula osteotomy. With the fibula osteotomy, yeah.
Yeah, so this question can get extended to the other faculty also, whether they do any intraoperative or pre-op arthroscopy to find out the intra-articular alignment.
It's well described, but we don't typically use it. We try to do we use a distractor, a wide submeniscal arthrotomy, and while it's and fluoroscopy, but we're not scoping these.
So sometimes if you have an avulsed ACL, then we would actually do a fixation of the ACL as well at the same time. So that the arthroscopy, I don't do the scopy myself, I have someone else who does it.
Dr. Bedi.
John,
Address to John.
You know, the biggest problem is sometimes get this playing open of the joint. When the joint is widened, I know you showed one, I didn't understand what you try to do almost like a reduction and squeezing the joint together in a malunited, and the second one was exit point of the osteotomy. I mean, how do you actually get it right? It's just K-wires and make sure you don't touch the eminence at any time, or do you actually have gone into the eminence?
So for the intra-articular osteotomy, yes, K-wires, you want to make sure where you're exiting with your osteotomy. For the reduction, we actually take off a bit of it. So depending on how much it's splaying out in these old cases, you would actually, with a saw, cut off a bit of it. Right at the back, we tend to use a nibbler to get off the last
bit. So you take out the periphery?
Yeah, so you take off the lateral wall.
Right.
And then you cut off a bit of it.
So the lateral wall you still keep, you go from, you take excise from in between.
From the central,
the fibrous tissue
part of the articular, and the even sometimes even part of the articular cartilage.
Dr. Josh, how you control the rotation in distal femur fractures?
How do I judge the rotation?
Yeah.
I think
because that is a big problem now.
Yeah, so I think that doing nailing of distal femur fractures, there's a lot of auto rotation to normal. And I think that when we use distal femoral plates, we often push a malrotation, right? So I don't ever use a bump under the operative hip because I think that causes you to internally rotate the proximal fragment too much. So in general, I haven't had a ton of problems with rotational deformities because when you're piping the center of the canal, you're not inducing too much force. I think that my internal one for rotation is that if I have, like I said, if I have the perfect lateral, the condyles and my lateral to medial holes are perfect, and then when I get done with my distal fixation, I pull a little bit of length on the femur. If I look in my proximal holes are not, my A to P proximal holes are not almost perfect circles when we're just laying flat, I start to scratch my head, really think about like what we're doing, or if the proximal fragment just looks weird, then I'll look more. But in general, just like retrograde femoral shaft nailing, it tends to want to go to position. And I think that the problem with rotation and plating is we actually push it out than just plating it in the wrong rotation.
I would say that also there's some that you'll have bone loss and it'd be harder. So assuming the other side is intact, we'll often measure the anteversion of the other side. And the technique, I think, described by Tornetta almost 30 years ago, get a perfect lateral of the contralateral side, roll the beam up, and then roll the beam up until the neck and shaft. And you know, like a lot of people like the lesser trochanter profile.
Yeah.
I think it's just I like having a number to chase, right? So like, you know, you roll the beam up 17 degrees and the head's in line with the shaft. That's what I'm going to try to chase on the operative side. But you know, that's definitely for ones with bone loss where I don't have any contact.
I'm overwhelmed by the presence of so many people who are here. And if you are listening to us, I think you will listen and you will understand more. My question is to Dr. John. You're using spiked washers for avulsed ligaments. Now, there is a very peculiar thing about this spiked washers that they should be autoclaved at least 12 hours prior to your surgery. You should allow them to cool. So is there any way that we can ETO? And the more you autoclave those spiked washers, they lose their strength. So what do you do about it?
So I used the ETO for these, but we had one patient who had infection only at the region of the spiked washer. So after that, I asked them to keep one autoclaved ready whenever we are doing this. So I'm just a little, but I'm sure ETO, because the sports guys use it with ETO all the time, so I don't.
You know, when I first did, the first few of these I used the little metatarsal T fusion plate as a buttress plate because it was low profile. But I think it's one, expensive, and two, it's too much. I think a spike, for most of these, a single screw or at most a second is probably all you need.
Any more questions? Those who want to ask, please stand up and raise your, Bedi, you have asked enough, but give somebody opportunity. Okay, then Bedi, you only.
Okay, Rob, give us the rule of thumb approach on what approach you're using for your pilon fractures. Your go-to seems to be look at the main Chaput fragment and try to go just where the Chaput fragment is exiting from the cortical margin.
No. So first and foremost, right, rule one is condition of the soft tissues and what the soft tissue is going to occur. Second is probably where the Chaput exits, the fracture between the Chaput and the medial malleolar component. But it's still the same approach. It's a Bowler's approach in line with the fourth ray. I'm not going to move that over and do an anterior approach. It's an anterior lateral in the same, and we just expose over. If we think it's way too medial, we'll do an anterior medial, right? Okay.
So essentially you're doing the anterolateral or the antro.
Those are our workhorse approaches, but you know, it depends on the, we'll individualize something, I guess, but typically it's one or the other.
Whenever there is a compound injury with a big degloving type of injury at the pylon area where we get the fractures, do you use VAC therapy and then give skin graft? How do you do it? Negative suction pressure.
You know, if it's been open, I don't typically, but like, you know, the wound vac or the negative pressure dressings, you know, if it's a 3B, I suppose, sure. If it's a 3A that we've debrided and closed, no, right? And if it is a 3B, we get our plastics colleagues involved early, for whatever that's worth. It's not always as fruitful as we hope.
So we've been using incisional vac at the end of these when we've gone back to operate on them, and if you find that the closure is a little tight, we tend to use incisional vac. So you use vac on top of your closed incision. That tends to get the swelling down a bit quicker.
I think one of the keys to think about those, like just like Bob, I try never to skin graft this area because we're often going to have to operate again. And so if I need something, I need durable tissue. I'd rather just have a free flap, have something I go through. And not like him, I use a direct anterior approach for pilons because as I've gotten more and more into ankle arthroplasty, I hate converting these anteromedials to arthroplasty.
So there's another approach which we use sometimes, which is a lateral approach, which we take the whole flap on, and that you can actually fix the fibula, the tibial pilon, and even the back. So we do all three through one approach. So we go to the back, we do the fibula, and we do the front with anterolateral plate through one approach. So that's...
The organizers, do you have anything to be given to the speakers, please?
Can I
Yes,
Excuse
where
me.
are you, please?
Yeah,
raise your-
here. You are not seeing me on your right.
Okay, yeah, sorry.
So I have been waving hands for about 10 minutes now and you are not able to see me. Anyway, so my question to Joshua first. You said you would like to operate as early as possible to the community lower and femur. In Indian scenario, it is quite often that they are compound. So grade 1, grade 2, you do a primary debridement and fix it. What about grade 3A, 3B?
Yeah, no, the only ones that I don't fix in Central Florida, I try not to fix lake water injuries. So the lakes in our area are really, really dirty. But even there, that's mainly on tibia. So almost every open fracture of the femur, unless it has like manure in it, I would debride it and fix it right away, because I think I think my ability to debride is good, and I think that soft tissue envelope is different, even though it's only like a couple inches away from the plateau, which is not nice to us. That area is pretty resilient, and as long as you do a thorough debridement, I haven't had problems with deep infection on that one, nearly the level we've had of other areas that are more subcutaneous.
I think I'll go with that because we've gone away from using the external fixator for especially the intra-articular distal femur fractures, because I don't find it, even the open ones, because it doesn't give you any good stability. So it's still flopping around, and so you're just as likely to get infection as if you do a good, more likely to get infection than if you do a good stabilization of the fracture.
I would agree. The ones that we're using are more probably the polytraumatized patients who can't, and I agree, it's not the same stability you get like with a peel-on frame. Yeah, exactly.
You are standing beneath a very illuminated pole and you are being eclipsed. So I can see you standing. So you want to ask one more question?
Yeah.
Go ahead.
Yeah. So talking about the pylon fractures, you tend to be more in favor of anterior approaches, that is anterolateral and anteromedial. So what are the prime indications of you going posteriorly and fixing the posterior malleolus? Prime indications.
Great question. So, you know, because these are highly traumatized area with not a lot of meat on them, right? We try not to ask too much of the area, right? So we do try to fix the Volkmann from the front when we can. If it's very low or very rotated, like the second to last one I showed, there's no way you're going to be able to get that from the front, or at least I can't, right? So I think that's one. It's also if there's comminution, if the posterior fragment is segmental, right? It's a couple of pieces. You can build that back directly, but that's going to be hard to do from the front, right? And as I said earlier, I'm trending more posterior medial than I did previously. Now, if I can do the posterior lateral and get the fibula through the same incision, well, I'm going to do that, right? But if there's no fibula fracture, that might give me the option to go posterior medial rather than posterior lateral.
So I think you need to differentiate between a pilon and a trimalleolar ankle fracture. So there we are going more towards buttressing that fragment from posterior side, while in a pilon sometimes that fragment is big enough that you can catch them with adequate screws from the front. So a slightly different situation, okay?
Yeah. So thanks.
Thanks everyone, and this was longer than the time scheduled. All of you had good patience. Just hold on for 1 minute.
I would request our chairperson to felicitate the faculties who are present on the stage. Please.
Yeah. We'll go in proper order. Robert. John.
And
to Joshua.
And I would request Dr. Dunbar to felicitate our chairperson. Thanks all of you. We will be resembling back in next 40 minutes. So, Dr. Gurinder Bedi, over to you, and we can begin the session. Yeah.
Sure, perfect. Okay, so I'm going to get Richard to come on the stage. So, Richard, can I tell you, ankle fractures for an orthopedic surgeon in this is like Sunny Leone calling you on the dance floor, and you're in an all-male kind of a conference. So, I mean, everybody's into it, or everybody's dying to get into it. So, you really have a tough job. The standards here are very, very high.
Well, yeah, please let me have it. I'm welcome to any criticism, but I want to go over kind of the stuff that you don't want to miss, and don't kind of underestimate certain types of ankle fractures. So, you know, even for standard bimal or trimal, you want to be really, really critical. Don't assume that every fracture is really standard. That's a mistake a lot of my residents kind of get excited for, because especially in the setting of poor bone quality, posterior malleolar or pilon variants are something that you don't want to miss also. And it's something I think we all kind of need to pay attention to, is the ligamentous stability, not only the syndesmosis, but also addressing the medial side of the deltoid ligament, again, in an effort to get earlier range of motion and better function down the line. So really, how do you avoid these pitfalls? Always assume the worst case scenario. This is an example of a 64-year-old active female, small business owner. My PGY1 orders 2 views. And really, this is something that's not adequate as an AP and a lateral. I asked for a mortise, you know, and this is a bad mortise view, but something that, you know, you can be hypercritical of these x-rays when you look towards it, is really looking at the area and seeing how poor the bone quality is, and if there's any level of comminution. So this is something that you want to identify early, and kind of be ready to have enhanced fixation techniques if necessary. Even when you're within your case, you want to critically assess your fluoros. We fix the lateral side first with a standard lateral plate. You know, medial approach, everyone in the room knows how to do this. Try to get, you know, cannulated screw fixation here. But here on the stress, sometimes if the bone is really bad, I'll do an inversion stress here. This showed that there was a tibial-talar tilt. Standard fixation of your syndesmotic screws. And then here on the medial side, zooming in, I really didn't like the look of this side. And when you kind of look in and you zoom in, you can tell that the screw itself is not holding this fragment appropriately. So I did not want to trust this in itself. And when you, also in the lateral, make sure that you're assessing that, because oftentimes you'll see anterior colliculus comminution that if you leave alone, you're going to be very unhappy as the patient goes on to probably fail that side. So I always tell my residents and fellow, don't leave the OR with incompetent fixation, because then you're not going to be happy when it fails. So this is something that we'll be back to screw out, re-reduce the reduction, and then using a small mini frag plate made of baskets for the medial side to get enhanced fixation for reliable fixation. Because you'd rather take the extra time in the operating room now, and then rather than have a discussion of failure later on down the line. And in all my x-rays, if you see this kind of metal in the view, that just means that I'm kind of stressing it. My fluoro techs in the States are not good at annotating, so I put something like that just to remind myself that's my stress view going on. 10 weeks out, back to the store, she went on to uneventful healing. Posterior pilon variant fractures are something that is, I think, oftentimes underestimated and overlooked. If you want to look at the posterior medial extension of posterior mal fracture, and look at that, because that's an inherent instability to the ankle mortise. Critical analysis is really important here, because if you see a posterior medial shadow above the medial malleolus and a double density above the articular surface, much like in this shot, that means that something is off, and usually that means your posterior mal is split into 2. 68-year-old female here, trip and fall, 1 pack-a-day smoker. You can see here there's a subtle shadow that's in the back there, and when you look at your CT scan, she was placed in an X-fix because she had blisters and because she was a smoker. I wanted to kind of have this calm down. Getting a scan after the span here, looking at it from proximal to distal, you can see that as you get more distal, that the articular involvement of that posterior mal is actually more involved than what you see on the x-ray. So this in itself turns this from, you know, what seemingly was a simple ankle fracture to, you know, what I like to call posterior medial variant. This is something that I think, just like Bob alluded to earlier, I think earlier in my career, I probably would have gone posterior lateral, and this is where it is. Now I'd probably go posterior medial in a supine position. But either way, as long as your soft tissue handling is appropriate, then you certainly can do a good, nice job and go to uneventful healing. Went into posterior lateral approach here, opened the book, flipped that articular fragment around, closed the book to address the Volkmann fragment, maintain and obtain the fibular length, address the posterior medial fragment, and then the medial mal after that. So you want to really be hypercritical of these x-rays, and if there's any question, get a CT scan, because you certainly don't want to be caught by surprise. At the end of every case, just like I said earlier, the shadow, don't forget the stress. You never know if there's an inherent instability. Oftentimes, if I'm not scrubbed in with some of my residents or fellows, I always check to see if they had inherently or accidentally had caused an iatrogenic PITFL injury. So stressing this is of paramount importance just in case. She's 6 months out, back to activities, actually quit smoking, which for some Americans is quite a miracle. But instead, she switched to smoking marijuana, which I think at some point we're going to have data that also doesn't help your healing potential either. Right, medical marijuana. 43-year-old smoker. Obviously, she has a history of some kind of trauma before. We always say trauma in our country is not an accident, it's a disease. On the lateral here, you can see kind of it's that slight posterior medial shadow here. This is someone who my spine partner at the time who was taking general call, X-fixed her, called me and said she had a really odd affect. This is a CT scan after the X-fix. You see that kind of double density that's there. And on the lateral, you can see also that there's a kind of peri-implant fracture next to that 1/3 tubular plate. In our country, illegal narcotics is a very epidemic at this point. She's one of the contributors to that epidemic. She had as a past tense, had an MD and a law degree. She was initially prosecuted for selling illegal prescriptions for 1,400 pills. She had lost licenses in 2 states in our country. But anyway, needless to say, the goals for this fracture pattern was to minimize incision length. I did not want a complication on this woman. I wanted a stable, reliable product because obviously I had trust issues. So for this kind of fracture pattern, which is not very typical, I wanted to use the same previous lateral incision, remove the lateral side of the X-fix, remove the old plate. I wanted to restore kind of that length with the anterior mini frag plate. And in order to get appropriate working length, I wanted to use an intramedullary device, a fibular nail. I wanted to get kind of enhanced fixation here to link the plate and the nail across the distal fracture, remove the X-fix, and then go posterior medial to fix the posterior medial fragment. And then again, dress the Volkmann fragment and the PITFL with a syndesmotic screw to kind of get enhanced stabilization. Because again, this is someone I didn't really trust. So looking at this slide here on the AP and lateral of the floral, you can see that we made our lateral incision, took that plate out, placed our anterior mini frag plate, which is custom contour to the patient's anatomy, obtained and maintained our lateral fibular length without having to open that skin incision all the way up by using this fibular nail. Then we subsequently went to link the nail and the plate, went posterior medial, buttressed that posterior medial side, and then added the syndesmotic screw to kind of support that Volkmann fragment. And again, having a negative stress exam here was really important. This person went on to have no wound issues. When she was discharged, she was lost to follow-up after week 6, which inherently I was very happy about, to be honest. Sticking to the principles and remembering the ligaments, this is a 23-year-old female, actually originally Indian in origin. She actually is from Australia. She was here to visit her cousin in LA, came across New Jersey. She was at LAX going into the airport, fell, thought it was just a sprain. Just to show how tough this young lady is, and again, like I said, I learned today how tough Indian patients are. She went on a cross-country flight with this ankle fracture, with her ankle looking like a giant, basically a cantaloupe by the time she came in. So when you're looking at these x-rays, you want to be super suspicious. It looks like a very simple pattern, but on this medial side, you see that there's already a wide clear space. Also asymmetry of the joint with the talus kind of already wanting to move back with the fibula, but anterior gapping here. So this is someone that we spanned first. Again, she was on that trans-country flight, and her ankle was severely swollen. We put her in a spanning external fixator here, just kind of get over soft tissues right. CT scan after that shows more than just bony involvement. Here you can see that the fibula itself is not correctly sitting in the incisura, which tells me that there was something off with with their ligaments. This could have been for the fact that she continued to walk on this and cyclically load her ankle during a period. But again, the asymmetry of the joint, either pre-op, intra-op, and post-op, is something that I'm hypercritical of to be suspicious of an additional ligamentous injury in addition to a bony injury. Here again, a posterior lateral approach, obtain the fibular length. I know that we're always taught to kind of go after a posterior fragment first, but I feel like if you can have a good read on the fibula and you can get a lag screw in, it does not hose your overall view of the articular surface in the posterior mal, and it really helps temporarily stabilize your fracture pattern to make your posterior mal reduction a lot easier. Posterior mal plate here, addressing the posterior mal, finishing the fibula to get your appropriate length and alignment and rotation. And again, just like I tell all my trainees, always stress the ankle no matter what. And here you can see on this stress example, there's a very subtle shift of the tibio-talar line, as well as some gapping on the medial side. Here we addressed, we reduced it and added a percutaneous syndesmotic screw. And again, being hyper-suspicious, stressed it again as an inversion stress. While the tibio-talar line lined up, the clear space on the medial side did gap a little bit. So there was an incompetent deltoid when we went to the medial side. This was an easy fix of using non-absorbable suture and then dunking a suture anchor. Stressing it again, you can notice that nice clear space kind of closed off to have a really stable lateral, medial, and intermediate columns of this ankle. She went home to Australia. 3 months out, I got a message from her and her mom. And at 1 year out, she let me know that she had hiked Machu Picchu. These are the x-rays I got from her and her mom. So it's really, really interesting to see kind of what you can do to stabilize these patients very early and making sure that you can get them up and moving very quickly. So when it comes to the take-home points here, and I think my moderator is going to be very, very happy because I'm staying on time, is to be really hypercritical of your standard ankle fractures. Be really assuming the worst, especially when you have poor bone quality. Don't hesitate to get a CT scan especially if there is a posterior mal fragment. Oftentimes, if you see a medial shadow and double density on the medial side, it could end up being a posterior mal or pilon variant, and you want to address everything in a kind of stepwise fashion. And at the end, you really want to make sure that your ligaments are stable, because I think the days of casting these folks in supination for a really long time and not ranging them early are gone. So for me, I'm very aggressive to address the ligaments so that I can start range of motion as early as 2 weeks to get them walking at 6 weeks. Thank you very much.
Thank you so much, Richard. Well, if you can come in the center while Mandeep makes his way. We're very fortunate. We got 2 presidents of the Indian Foot and Ankle Society here. Mahendra's coming on next after Dr. Dillon, who needs no introduction, from PGI. Has been around teaching us all on foot and ankle for a very, very long time. Now deeply attached to the AO traumas as well. So any quick questions for Richard? I think ankle's going to throw up a cauldron of questions and so many controversies. I think but we'll keep away from the old questions about how many cortices and cortical screw, cancellous screws, those kind of things. So let's elevate the level a bit, because those controversies are never going to finish. But I'll take one question before Mandeep is all. Mandeep, are you all set?
No, take a question.
Okay, just one question. Anybody? Very quick question from somebody. Yes, sir.
Mike,
I just want to ask you the definite criteria for putting the syndesmotic screw, and what time would you remove it? Because you're the last one, it was broken.
So we're just going to do the syndesmosis one in the next section. Any quick ones? Sorry, I'm not going to miss you out.
Oh, thank you. My question to you is, are you always dogmatic of doing lateral first? In a situation of a bimalleolar or a trimalleolar fracture, all 3 fractures at the ankle level, would you fix the lateral malleolus first or the medial malleolus first?
In a bimalleolar, because we're not going to, trimalleolar is the next question.
Okay.
So in like a standard bimal, the question is whether I address the lateral mal or the medial mal first. To be completely honest with you, most of the times with my trainees, I start both sides at the same time. I don't think it matters, because as long as you get anatomic reduction of the medial or lateral side, and as long as you obtain the appropriate length and line rotation of the fibula, then it's not going to really matter either way. I think when it gets to a tougher level, if you get high energy trauma in a log splitter, that's when you have complete stripping of the distal fragment in the fibula. That's when you want to really pay attention to the rotation. For those kind of higher energy injuries, I think that I pay more attention to the lateral side first and then go medial. But for your standard bimal and trimal, I don't really think it matters whether you go medial or lateral first.
Excuse me.
Perfect,
Can I take a call on this question? I have never been to an orthopedic conference in India where this question has not been asked. I do not know.
I think we need to give a definitive answer to
The
people.
answer
We're
is,
not giving definitive answers.
The only time when you stabilize the fibula is when you want to get the length and rotation of a very unstable fracture. Both bones forearm. Which one would you fix first? I want you to answer that. Which one would you fix first?
Ulna first.
No, it's not necessary. If it is, if the radius is it doesn't matter. You have to reduce both of them first and then stabilize them.
My dictum of radius and ulna, I'm sorry of drifting it.
Sir, it's not.
My concept of radius and ulna is relatively a fixed bone and therefore should be fixed first.
Sir,
Radius
after
is a
that you're not
mobile
able to reduce the radius then. So
it is a
don't
mobile
fix
bone, more
Sir,
chances of radius getting reduced.
It's not, the question is you should not be dogmatic.
So,
You should be able to reduce both. Sometimes when there is a lot of comminution, fixing the fibula gets you the length and rotation right, and you are able to do the rest. So it's not which first, which second. This is not a political question.
For all practical purposes, this question is laid to its grave now. So do whatever you feel like. It doesn't matter.
No, it matters sometimes, but let's take a call on that. Okay, guys. I'm going to talk to you about syndesmosis injury. It's probably, everybody thinks it's the easiest thing possible. And I'll try to shed some light on this. So when I'm shedding light, I'm going to ask you in the audience to raise your hands. How many of you have fixed 5 syndesmosis injuries in the last 5 years? What are the rest of you? Pelvic surgeons? Okay. Those of you who have fixed the syndesmosis injuries, how many of you think you're good at it? You know, I've done the right thing every time. 1, 2, 3. Would you like to come here and give the talk? Anyway, the aim of this is firstly to understand syndesmosis anatomy, find out what's the instability caused by the injury, and you must realize that the syndesmosis stabilization is often the key to ankle stability. And we'll show as we go along, and we must understand the fixation techniques and the methods used. It's almost Christmas, so as Moses had 10 commandments, I'm going to give you 10 tips for managing syndesmotic injuries. We'll start with the first tip. First thing is first, you must understand the syndesmosis anatomy. Understand that the ankle, like the pelvis, is a ring. You have to stabilize it to reduce ankle instability. So if you look at the syndesmotic ligaments, there are actually 4 of them. The anteroinferior ligament, the posterior-inferior interfibular ligament, the interosseous ligament which goes high up there, and then you have a small inferior transverse ligament. They are not always all ruptured, but they rupture in some kind of a sequence. So we have to understand what happens, because you understand this according to the injury mechanisms. So I'm going to show you a couple of injuries, because unless we understand the injury mechanisms, we may not be able to understand where the syndesmosis injury happens or does not. Supination external injury, classic lateral oblique fracture. But look at the AP view, there is no medial opening up. So this is considered as a stable injury. And here the syndesmosis may not be injured, or it may be partially injured and it may be stable enough to be not operated. On the other hand, this is the case which I'm talking about. On the other hand, a similar injury in the fibula, but you look at the shift of the talus, which implies that the medial ligament is torn and there is an opening of the syndesmosis. So this is a case which would need stabilization of the ankle with or without the syndesmosis. What about these pronation external rotation injuries? The fibula fracture is higher than the syndesmosis. The syndesmosis is always damaged. Otherwise, the injuring force cannot go there. So you need to look at this and you need to address this, because the syndesmotic injury here is obvious. As I said, the ankle mortise is like a ring. And the more places the ring breaks, the more unstable it is. The first session in the morning was how to stabilize the pelvic ring. You can't fix it from one side and leave the rest of it alone because it is important. The stability of the ring has to be reconstituted for a good ankle fixation. Point number 2, we're talking about the fibula. Fibular length restoration is essential, otherwise you cannot reduce the syndesmosis. Fibular rotation also, and this was a case, you see, if you cannot get the length and rotation of the fibula right, the syndesmosis will not reduce. And this is an example, 40 years ago. I mean, 5-7 years ago, my residents told me in Rockwood and Green it is written that if you have a high fibular fracture, you can put 2 screws into the fibula to the syndesmosis, the ankle, there's no need to fix the fibula. We actually wrote to the editors and got it changed. Because unless you get the fibular length right, you cannot get a reduction of the syndesmosis. And this case was taken up for refixation, but still developed late ankle osteoarthritis. So remember, fibular length and rotation are critical for syndesmosis reduction. Tip number 3. If you know preoperatively it is unstable, that's fine. But do you need to fix the syndesmosis? For that, you should evaluate the syndesmosis after stable fixation of the fibula. And what do I mean by that? You can do an external rotation test over here. You will see that it is opening up, it is unstable. That's fine. But then you fix the fibula. And then you do your tests. Because when you do your tests over there, and if the syndesmosis is not opening up, or the talus is not moving, it has now become stable. That means some part of the ligaments were attached to the fibula and the tibia, and the stability has come back. And remember, you need to check the instability in all directions, not only hook, anterior, posterior. All directions you need to check so that, and again check it after putting the syndesmotic screw. Because after that, sometimes it may still move. That means there is much more to the instability. Okay. Tip number 4, whatever you do, understand that accuracy of reduction is the key. The key point is the accuracy of the reduction because the instabilities or the displacements can be in any plane. They could be anterior, posterior, they could be a shortened fibula, they could be rotational. So you have to understand all of that, and only then will you be able to get an accurate reduction. And how do you get an accurate reduction? The best way is looking at it. You open the syndesmosis through a small incision and check the reduction right there in front of you. And this is a case example. The stress view shows that the deltoid is torn, the syndesmosis is open, the talus is shifted, although the fibula, tibia don't look to be so much distracted. But when you open it up, you can see that the ligaments are torn both over there, and what you want to do is get the Mercedes-Benz sign on reduction. What I mean by that is that when you have reduced it, you should get this, the so-called Mercedes-Benz sign at this level. And this you cannot see unless you've got an open reduction. And that's the way of substantially reducing the rates of malreduction. Tip number 5, if you want to screw it properly. If you want to fix it, you've got to get the screw right. Where to put the screw is no longer a controversy because high, low, everybody knows you have to put it between 2 and 5 centimeters of this. Try and avoid going through the joint, and try and make sure you do not compress it. It's a positional screw holding the reduction, not causing compression, because I will show you that a compressive malreduction is equally bad. Another thing is the fibula is posterior. So you have to insert the screw at an angle of 30 degrees. It should go forwards, pointing in that direction. Otherwise, the fibula will tend to slip backwards, especially if you tend to compress it. All of you said we did a good job with our syndesmosis. But let me tell you, malreduction is a significant problem with screws. You know, Mike Gardner did a study of post-operative evaluation, and he found that 30% of all cases which looked good on X-rays were actually bad on CT scans. So this is something we must understand. Just because the X-ray looks good doesn't mean that the position is good. And this was also shown by Nabil Ibrahim on his work, who said that the CT is the best tool to evaluate syndesmotic reduction. I mean, centers like AIMS and PGI, we have intra-operative CT scans, we can do it at the table. But if you don't, then try and use it as a post-operative tool. Tip number 7, no compression at the time of reduction. Because if you compress it, especially when you are holding it with the clamps to reduce it, you will put even a positional screw in a compression mode. And that is a problem, because compression also is a point of malreduction, because remember there's a joint there. Although it's a cartilage, if you compress it, it will cause pain. And there will be problems, and you would get reduction of talus dorsiflexion. So you should only hold it, not compress it. That's why people number 5 may be moving towards, tip number 8 is, maybe dynamic fixation is good. But in association with fractures, it is still not an established entity. But as a standalone injury, if you get a syndesmotic strain or an injury in an athlete, it's a very, very good option. But there is data coming out, and as early as 1994, there were people from the US and Japan who were talking that should we omit this transsyndesmotic screw? Because with the screw, you are rigidly fixing the fibula to the tibia. And when you are walking, remember, your fibula has a little bit of rotation involved when you are walking for you to normal. So if you do a rigid fixation, you could get restriction of motions. And there are some publications which are coming out that if you do a fixation, maybe a dynamic fixation could help, but we don't have the literature to go to it as of now. Tip number 9, you could maybe avoid the syndesmotic screw even in an unstable syndesmosis. That means if you reconstitute the rest of the ring, you may need not to put a screw over here. And what do I mean by that? If you have a large fragment of the posterior malleolus to which the ligaments are attached and the fibula is fractured, if you do an accurate reduction of both of these, it will retension the posterior ligaments, and the reduced fibula will get the syndesmosis right. And you can do some movement, it will allow some fibular movement, and this is an example, I would say, where we don't need a syndesmotic fixation. This was a surgeon at my institute. Few years ago, he came with this kind of fracture. And look at, you evaluate it. Weber C means above the syndesmosis gone, large posterior fragment with talar displacement. Syndesmosis disruption has taken a piece of bone with it. The ligaments are attached to that bone, despite the fact that the medial joint space is increased. Talar has shifted with the distal tibial fragment as well as the fibula. So what we did was we evaluated, and the CT will show you this broken ring. So we went in, we got the length and rotation of the fibula right, and we rigidly stabilized the posterior malleolus, and under all kinds of stability testing, there was no talar shift. So this worked as an indirect syndesmosis stabilization, and he did not need the screw, and he's doing fine. He's a consultant working in my institute. If it was bad, he would have come and sat up on me. Now, sometimes you get interior instability. You can get an avulsed Chaput fragment in addition to all the complex fractures. So here, when you're exposing the syndesmosis over there, I mean, why do you want to give up this ligament? So here you could fix this back with a small suture anchor, which further puts the syndesmosis in its place and makes sure that even if you put a screw to offload this fixation, you are not putting the screw in a malreduced position. So this makes the ring more stable. But if you reduce this Chaput, the syndesmotic reduction automatically becomes anatomic. Tip number 10, again, one of the most frequently asked questions. Should you remove the screw? I would say no. Only if they are painful, you can remove it. But tell your patient that I'm leaving this screw, which may break. If it breaks, good for you. Your fibula is going to start moving. And then they never complain. If you haven't told them that the screw is broken, will break, they will get after you. This screw broke. What happened? So you tell them, the screw may break, and it's good for you because the fibula will start moving. So they come back with an exercise. See, sir, it's broken. Good thing, good thing. But there are some of them who are painful. So if there is pain, you could perhaps remove the implant. But there is no evidence that says that either screw breakage or screw removal helps the pain. Because it may probably be a malreduction which has got stabilized in that place, which is causing the pain. So I cannot give you what to do for the screws. I personally do not remove these screws. So folks, what's the take-home message? Badly reduced syndesmosis can cause significant disability. So before we do it, let's understand the anatomy, the injury, and whenever the syndesmosis is out, it needs stabilization. Currently, with fractures, screws are the commonest method, but you have to be careful with screws. You could get a malreduction, and you can get a malreduction in 35% of the cases. So for this, maybe dynamic stabilization. In the next conference, we may say that this is the only way to go. But sometimes you can get away by avoiding the screw by an indirect stabilization. And screw removal is not mandatory. So those of you who are interested can look into the foot and ankle manual, of which I am the author. And this is, all these details are given there. Thank you so much for your time.
Thank you so much, Mandeep. Always an interesting topic, loads of controversies. I hope we've put some of them to rest. But let's wait for the question and answer session before we say the last word on it. My next speaker is Dr. Mahinder. Mahinder is, as the Punjabis would call it, local Londa. Our man lives in Goa, educated in Goa. Huge practice of foot and ankle, has been the president of the Foot and Ankle Society. We're going to talk to you about posterior malleolus fractures. Oh, so we can take a question, right? So we can take a question on what Mandeep just said. Anybody with any questions, any queries, any comments?
If you have a situation where you have to put an anti-glide plate in the posterior aspect of the fibula, how do you put the syndesmotic screw there?
You leave the space over there. You just leave one of the screw holes wicker.
You can't target from the posterior aspect.
You cannot. Then that is a situation where a tightrope helps.
No, so you would go anterior to that, right?
Yeah,
At the
because
right time.
when I'm putting in a screw, I mean, even if I've got a syndesmotic, look, the issue is, if I'm using a screw with an unreduced or an unstable syndesmosis, then the direction of 30 degrees is important. But if I'm sure everything is right, I could put in a screw like that. But the problem is I may go out through the back of the tibia. So you could get a lesser angle. You can still put it in. Doesn't have to be 30 degrees. But remember, key point of any fracture is reduction before fixation.
You cannot put an independent screw because it may fracture.
It depends upon the fracture site.
Which is up and down, this one?
Where is the fracture?
Yeah.
When you put an anti-glide plates, their fractures are a little lower. So you have problems over there. So this is one of the areas where, you see, I have not been able to answer all the questions. You saw half of the light went out of the backside. So whatever light you can retain is important. The issue is that everything is not rigid. So sometimes you have to compromise. So if you find you cannot put a screw, use a tightrope.
And if somebody comes late, do you have an answer to that?
Yes. We have a full talk on neglected syndesmotic injuries, maybe in the next conference.
So as a short thing, Mandeep, are you saying we go and debride and hold and fix and those? Just as a short answer to
the short answer to that is when you get a neglected syndesmotic injury, the talus is usually, it depends. If it is undisplaced, then you just have to stabilize it. We use a graft. We use either a hamstring graft to reconstruct the ligaments. But if there is an associated malunion and a deltoid ligament also whilst the talus is shifted, then you get a fibular reconstruction, and then I reconstruct both the deltoid and the syndesmosis. I mean, in the question hour, if anybody wants, we got videos of that. You're going to show us a video.
Are you okay? Are you okay to go?
Yeah, all right. Thank you, guys. I know it's post-lunch. We'll try and keep you awake. The previous two speakers have almost, started the warm-up sessions for this. So I'm going to speak about posterior malleolus. It's just like the pain in the ass for the ankle, which is just right behind you. But you don't know what to do with it because, before I sort of started training for foot and ankle, I could see only the medial and lateral malleolus. I never saw the posterior malleolus. I mean, I didn't even knew it existed. Once in a while you could see it and that's it. And nobody bothered to fix it. So what has changed since then? So posterior malleolus fractures always existed because we have to realize that we now have to see ankle as a ring. All as my previous speakers have, we cannot look at it in 2 dimensions. We have to look at it as a ring, and only then you will try and understand how much that posterior malleolus makes a difference to the ankle stability. 14 to 44% of all ankle fractures have a posterior malleolus. Why can't we see it? Where the eyes do not, the mind doesn't know, the eyes won't see it. It was as described as early as 1932. 46% of the Weber type C or B fractures have a posterior malleolus fractures, because if you look at the Log-Hansen classification, it goes into stages, SER 1, 2, 3, 4. So depending on how much of force has occurred on that area, only those fractures, in those patients, you're going to see the posterior malleolus fracture. It is rarely isolated. It can be seen in all 4 types, that is SER type, the supination abduction injuries, pronation external rotation injuries, but SER is the most common. Usually the mechanism of action, basically what happens is there is an avulsion of the PITFL, because that is where the big broad ligament extending from the fibula is attached to the posterior malleolus. The pressure from the external rotating talus, the pressure from the lateral malleolar fragment, axial loading, and if there is an axial loading to the injury, the fracture usually tends to be posteromedial. So basically an abduction external rotation combined with high axial loading or a hyperpentile flexion can cause a posterior malleolus fracture. So the points to ponder in my presentation will be, basically I'll just give you a preview of the anatomy, how to locate where that fracture is. Sometimes, in a standard film, you may not be able to see it. And you wonder, maybe it's not there. So then once you have seen something shady there, like you can see the mountain mist sign, or you can see the double shadow, you need to confirm. Then once you have seen the fracture, you need to classify it. Because once you classify it, you would know how to go about it. Whether to fix it, can you conserve it, what approach you're going to take, what implant you're going to fix. So let's take it one by one. As far as the anatomy is concerned, we've always been obsessed by the size of the posterior malleolus. Everybody said 25%, 30%, you should go ahead and fix it. But basically, there was a flaw in that science. So let me tell you why it is. It also the shape of the posterior malleolus. It doesn't matter, because you have to understand the shape or the size of that posterior malleolus is not so important as far as what it contributes to the integrity of the syndesmosis. How much does this fracture posterior malleolus is going to make your ankle stable? What ligaments are attached? Try and understand that posterior malleolus is just not a fragment by itself. It has got ligaments attached to it. So something is pulling on it. So something breaks either at the ligament level or at the bony level. It's going to make that, it's just like you have a deltoid ligament tear and you have a medial malleolus fracture. It's exactly the same scenario. How much it contributes to the ankle stability and the congruity. Now, how are you going to locate it? For that, there are a few things that you need to understand. That you have to have and ensure that there is an adequate film. What I mean by an adequate film, in the ankle, you need to understand that the fibula can fracture right up to the top. You can miss a mesonerve injury, you have not included the knee. So have your films right from the knee to the ankle involved. The joint above and below should be included. Do the entire ankle series, AP lateral mortise. Don't compromise on these 3 things. That is a standard foot thing x-rays that you have to do. Sometimes if you want to get out those subtle x-rays, you have to use the stress views or a gravity stress view. So once you try and do that, you're going to see a different range of posterior malleolus fractures. There are some very shady, very fine, you don't even know whether they're there or not. Then you have the obvious ones. And sometimes you have those ones where you're in doubt. They may be there, may not be there. So what can help you to sort of, get to a confirmation? Because you want to be prepared. Now, one of the reasons I felt before being a foot and ankle surgeon is that why I did not see those fractures, posterior malleolus fractures, and even if I did see it, why was I not fixing it? Because I just knew a lateral approach and a medial approach. I never thought that there was another way of approaching the fibula or the back of the tibia. Now, this is one, if you want to find posterior malleolus, this is one view you must try and do. Do a 50 degrees external rotation view, because that gets the posterior malleolus in line with your view. And you're going to discover so many more posterior malleoluses once you try and do this view. 86.67%, that is 26 of the 30, you will be able to see the standard lateral radiographs. But if you do an extended lateral rotation view, almost every posterior malleolus you will be able to see. If not, of course, there's the next step, CT scan. Because we tried and did now lots of CT scan, now we were able to not even just see the posterior malleolus, we were able to classify them. Haraguchi's classification came in because he saw that the posterior malleolus is, not all of them are the same animal. They came in different shapes, they were in a different location. And this study which was done, that those surgeons who did a CT scan were convinced that once they saw a CT scan, they would definitely go and fix it, which they would have done if they had just only done the X-ray. Because the X-ray really doesn't tell you the whole picture, because as orthopedic surgeons, we are so trained to see that only if the size of the fragment is big. We are not thinking in terms of soft tissue, and not thinking about the rotational stability. So once you become a foot and ankle surgeon, you look at ankle in a much different way. So this is what the message is going to. So there are various classifications, but Haraguchi was probably the most simple ones. The first type 1 was a big posterolateral fragment. The type 2 was a fragment which was extending right from the fibular notch right up to the posterior malleolus. And sometimes those flaky ones, like a type 3, they have been subclassified. But of course, there has not been still a conclusion on exactly how you're going to treat each one. But what is important is that all of them can contribute to instability. Can some of them be saved from the knife? Well, there are 2 prospective studies where they did SCR positive patients, PR stress positive patients, and if you can regularly follow up with regular X-rays, you may be able to get away with it. But they require a very close follow-up. But you have to understand, you have to tell the patient, even if I'm trying to do a conservative treatment, there is a possibility you might have to go in for the knife. So what is the surgical aim? Once you have decided that I'm going to fix it surgically, you have to restore the articular congruity. You have to correct the posterior talar translation. You have to address articular impaction. Now, articular impaction is one thing that you're going to see only if you do a CT scan. Because those articular impactions, if you do not correct, they are going to lead to post-traumatic arthrosis. When you try and reduce them indirectly, if you're trying to do sometimes, I remember in the past days, if you see a posterior malleolus, some of them fix the posterior malleolus from anterior to posterior by a screw without even trying to attempt to reduce it. And they never got reduced. Why? Because you could find small osteochondral fragments that are there, they're not trying to. Many a times you reduce the fibula and the posterior malleolus falls into place, if it's like a nice chunk. But if there's a comminution, it won't. Here is the reason that you need a direct approach, open, visualize it, and reduce it. It's not easy sometimes to reduce a posterior malleolus, because you have to right down, because there's thick periosteum on the back. You have to go right to the apex of that thing and then push it down. And of course, you have to realize that posterior malleolus is a fragment which contributes to syndesmotic stability. Like a lot of X-rays that have been shown in the previous presentations, you have fixed the fibula, you have fixed the posterior malleolus, but still you see that there is a medial clear space. So you have to close the ring on all the sides. Decision to fix was initially based on size, but those studies were based on joint biomechanics and tibiotalar instability. They were not looking at ankle rotational stability, and they were not looking at the posterior translation. So now, does that size of the fragment matter if it shifts a little bit here and there? A study by Van den Beckroms found that most of the time, the shift of the pressure, the contact pressure moves anteriorly. So it is not that, it is not even contributing to the instability. The moment you have a posterior malleolus, and if you do not fix it rigidly, it is going to cause these contact stresses to move anteriorly. Indications to operate on the X-ray, greater than 25 articular surface, which are standard, greater than 2 mm articular step-off. But I think those things are no more relevant. You have to understand that once you have fixed your posterior malleolus, you are going to make the syndesmosis stable. That is how you have to think about it. You are going to prevent the lateral talar shift. You can prevent the talus from shifting backwards. So does size matter? So many studies have been done, and even a 40% size of the posterior malleolus still did not, have a problem, as long as your rotational element was taken care of. So size really does not matter. If you, along with the posterior malleolus, if the AITFL goes off, or there is a frozen fibula, then yes, that is what is going to matter. So do not look at posterior malleolus in isolation. It is all one part of the ring. There were some of the studies which showed, again, involving even a 10% or more. So these are very contrasting studies. One person is saying at 40% also doesn't matter. And some of them saying, why even at 10% you got to fix? This is simply because that injury or that size of the posterior malleolus, how much is it contributing to the rotational instability? That's what matters. So size basically is not important, even 10%, 25%, everything is going to contribute to instability, provided you close the ring. So stiffness restored after fixation of posterior malleolus is up to the 70%, and on 40% it restores the syndesmotic fixation. So sometimes you can get away, fix the posterior malleolus, and you don't have to put in the syndesmotic screw, because putting a syndesmotic screw itself, as Dr. Dhillon has very clearly mentioned, has its own pitfalls. It's not just about reducing the syndesmosis back into its place. Most of the time, once you reduce the posterior malleolus, it adds to the stability. So the contact stress, as I said, also significantly increased with the size. So size also matters, because if you do not, you just say that it is rotationally not unstable, but it's a big size, there is always a shift. So fixing the posterior malleolus makes a lot of difference. Here again, Oglives-Harris also found in the study that 42% of the stability for the syndesmosis comes from PITFL. So if that is true, then you have to fix the posterior malleolus. Where can we fail? We can fail at many places. We can fail at restoring the fibular length. We can fail at restoring the fibular rotation. Just fixing the fibula has got no meaning. Have you got length back? Have you corrected the rotation exactly? Then posterior malleolus by itself can also contribute to malreduction. If there is an impaction, articular impaction, if there are comminuted osteochondral fragments, and here comes the reason why you have to do an open posterior malleolus reduction. And again, syndesmosis malreduction. That can occur again because of various reasons. Either you have over-tightened it. So one of the tricks that you can do is, generally the malreduction occurs when you put in the screw, the fibula gets shifted anteriorly. Because if you see the fibular notch, it's a little deep on the back, but very shallow in the front. So you can put a blocking K-wire there, and then reduce it, and then put in a screw, so that it will prevent that the fibula will move forward. Or, as Dr. Dhillon said, just do an open reduction. And when you do that, just put in a K-wire, block that fibula from moving in the front, and you will have less problems.
Mahendra, can you round it up now?
Yeah. So fix which first? Well, I won't go into this. Most important is you temporarily fix the fibula, and then go ahead and fix your posterior malleolus, come back, finish your fibula fixation, and then go medially and fix your medial malleolus. Why? What happens if you fix fibula only? Well, you have to realize that, again, fixing the fibula only will not completely close the ring. Approach. So, if you want to fix the posterior malleolus well, you need to realize that you have to know the posterior lateral approach. And once you know the posterior lateral approach, it's a cakewalk. Because then you're right there. It doesn't matter. If there is a big posteromedial fragment, go posteromedially. You have to address these fragments directly. The only problem you have to watch is the sural nerve, which comes in your path. You have to be careful about it. Which implant? Again, most of the implants that are used on the posterior malleolus are buttressing. You don't have to actually put a screw into that distal fragment. You may fix it separately with two malleolus screws and yet put a buttress plate. But you don't have to put screws into the distal fragment, because it's like a volar barton. Even if it just remains there, it's going to hold it in place. Because the posterior malleolus has a tendency to move upwards. The fibula can be fixed in the antiglide mode. I'll just quickly go through. So final message, posterior malleolus, remember it's not just a single fragment, it's part of a ring. Look for it on the X-ray. If you can't see it, confirm with the CT. It's part of the syndesmotic stability. It's part of your articular congruence. Long-term outcomes, worst if not fixed. There's studies, enough studies to prove that. Approach, as I said, either posterolateral or medial, depending on where the fragments are. And implant, usually a buttress fixation is more than enough. Try to avoid putting a screw from A to P. It should be ideally posterior to anterior, and that's where the stability comes. Additional plate, you may add depending on the size of the fragment. Thank you.
Thank you so much, Mahendra. Josh, if you can make your way up very quickly. So, Mahendra, can I ask you a very quick and easy question? Is there any posterior malleolus fracture which you will not fix?
So that question will be depending on, once I fix my fibula, and then if I take a stress view, and if I feel that nothing is moving, well, I might get away with it. But that point is, again, whatever you fix, post that on fluoroscopy, stress it. If there is an opening, like you can fix the fibula, you can.
My problem with that is, Josh, that the train has already left the station. So, sorry, not Josh, Mahendra, the train has left the station.
So I will not decide pre-operatively that I'm going to fix it or not. I'm going to go in a sequential mode. Because for me, every fragment of the posterior malleolus can contribute to the syndesmotic instability or failure of the ring. As long as I'm satisfied that I fixed the fibula and I'm giving an external rotation stress view, nothing is opening up. So this is the problem. We always thought that every fibula needs to be fixed laterally. So now here you have to change your view. Why can't you take a posterolateral approach for every fibula fracture? You can still put your plate laterally. So I would think of it like this. If I've not seen it on X-ray, and suppose you have not done the CT scan, you do a posterolateral approach, you can dig for it, you can look at it, and so many times you'll find it there. But if it's just a flake, the type 3, which is just a flake, you might be able to get away because really not too much of injury has been transmitted to that joint.
So let me give you another scenario. You put the fibula on. Now you're actually, it's a posterior plate. Now you see it opening up. You decide, look, this is too small a flake. I think I'm just going to put a syndesmosis screw. You put a syndesmosis screw, the ankle will become stable at that stage. When do you decide now whether you want to put a plate or you don't want to put a plate?
So if I've achieved closure of that syndesmosis and there is no rotational element found there, but there are other points. So it says he's trying to make it so simple. It isn't simple. If there is articular impaction, I'm worried about it. No articular impaction, I'm not concerned. As long as I've restored a stability, because PI-TFL has to be tightened. Now, if I put a screw through the syndesmosis, I have taken care of the PI-TFL instability. Yes, it will be stable. So, but as I said, for me, it's more mandatory or I will be more comfortable fixing the medial malleolus, and I might not put a syndesmotic screw because there are too many complications of putting in a screw. So that's what my gain is. Thank you.
Josh, the easiest part for you to manage?
All right, so I have the pleasure of giving a talk on post-traumatic ankle reconstruction. So this is essentially, in Central Florida, I am like the drain hole. So all things bad come to me. Those are my disclosures. So indications, as we're thinking about, this is going to be basically a talk just on some cases, but what am I trying to achieve? Is it an unstable situation, a limb-length discrepancy, post-traumatic DJD, osteonecrosis of the talus, or infection, plus or minus all of these? And the workup, obviously, is a thorough neurovascular exam. The big one that people forget about is to note gastroc tightness and toe flexor tightness, because that can actually affect your end outcome of doing this. And really see whether you have, is your deformity osseous or is it soft tissue? And obviously a CT scan here helps, and thankfully for us, usually chronic infection is pretty obvious, but I do things like ESR and CRP. So these are all your treatment options, and I'll go through just cases on showing kind of things I've done over the years. These are some old cases, some newer cases. But just basic post-traumatic DJD, and I'll tell you that this is all, some of this has changed my thought process on it as I've entered more into the arthroplasty world of ankle arthroplasty, and I do both fusions and arthroplasty, and so the cases that I show now, I probably wouldn't do the exact same thing now, so it's entertaining. But this is a guy that had come to see me, and he is really having a lot of trouble with a foot that would just always invert when you stand up. He has pretty solid post-traumatic arthritis with a solid varus deformity and a really big talar tilt. And this is evidence when we take him to the operating room and do that. My workhorse approach for the reconstruction of the foot and ankle, because I do a lot of double hindfoot fusions and salvages, and this is essentially my incision for everything. I do a fibular osteotomy, and I turn down the fibula, keeping its blood supply on the back, so I can use essentially a vascularized fibula to help with any reconstruction that I need to do to try to get fusion. By doing that, I can pretty easily see the tibio-talar joint, and then if I move down, I can see the subtalar joint pretty easily. And even though the fibula looks like it's being tortured right there, when the tourniquet comes down, that still has blood supply to it. So it's still something that's a vascularized graft. And in this case, this was so long ago, this is before I really cared about the fibula. It was 2014. So I just took it out. And I don't do that very often, because I think that, whoever made us put it there for a reason, and unless we have to, we should probably keep it there. But for him, this is what I did in my fusion construct. and he goes on and does very well. Just a standard ankle fusion supplemented with a plate. As you look at post-traumatic DJD of previous infection, so this is a lady that we talked about these ankle fractures that are stable. She had someone in Central Florida plate a stable ankle fracture and then subsequently got osteomyelitis. So there's nothing we can't make worse by operating. This is the other, one of the guys that trained me had this saying. He's a shoulder surgeon. He said, Mrs. Smith is doing very well after her 23rd shoulder surgery, all of which were indicated but the first. So sometimes you get these ones delivered to you. And so this lady had previous fibular osteomyelitis, and we'd gotten that cleaned up pretty well and got her to heal, but then she ended up having post-traumatic arthritis. And this is a simple one from back in the day, and I can tell you now, I probably wouldn't think of an ankle arthroplasty for this one because of her history of infection. That'd really get me a little creeped out on trying to do it. But this is back when I just did a 3-screw construct. This was, I trained in Tampa, so Roy Sanders was big on the 3-screw construct, and because she had previous fibular osteomyelitis, I just got rid of her fibula and got it out of the way. What that will do, though, as I found out, nothing hurts good results like follow-up. So 5 months later, she's complaining. I'm like, I don't really know. Everything looks good on the X-ray, and hey, lo and behold, you got a stress fracture. So when you put big holes in the tibia and then you take out all the supporting structures, it's wonder of wonders, almost right where the level of fibula is no more, and you get that. So, but the good part is that thankfully that'll heal on its own. It just has some callus. So there's 18-month follow-up, and she went from being a pretty miserable person to pretty good. I think the reason that people ask me why I've changed over the years as far as arthroplasty goes, because I've followed enough of these people. I've been in Orlando for 15 years now, so essentially somewhere in the 6 to 8 year range after doing this, if these people still have insurance, I will see them for subtalar arthritis. It's almost just like write it down, it's gonna happen. Lots of people don't have, sometimes I'll see them and I'll see them for something else and they'll have an x-ray that has arthritis, but not be symptomatic, but they all get it, so. Here's one, post-traumatic DJD and deformity. So this is a guy that was treated by one of my partners. This is one of my partners that was letting the fellow do everything and really scrubs in. Had a pretty smoked pilon fracture that was spanned. And back in, one of the reasons I put options on this earlier in my life, I would have said, this guy might actually just go to an acute fusion, because I did a solid amount of acute fusions for pilons, and man, they really had pretty good results. People, one surgery, people seem pretty happy. But again, as my thought changes to more long-term reconstructive options, that's changed how I'm thinking. But this was put together, and if you can see something that's, that should stick out to you, that when you follow up, that the medial edge of the talus should never be medial to the entire tibial shaft. That's bad. This is when you trust a pre-contoured plate too much. All right, so the fellow trusted that pre-contoured medial plate was going to put them in the right direction, and they did not. So we said, is that good enough? And we take all the hardware off, and we see that they've got a pretty solid varus deformity. They had a little bit of translation. So after debriding the whole joint, and you can see that I did my fibular osteotomy, turned everything down, debrided it. After debriding everything, I kind of put this little pivot screw that I call in the corner, so holding the tibio-talar fusion site together, and then that's a jiggly saw doing an osteotomy, and so a supramalleolar osteotomy combined with a tibio-talar fusion, and that guy goes on to actually really like it, and much better, has a foot underneath them. These are, obviously if you guys have big foot and ankle practices, these are really appreciative patients, because they went from being really miserable to, in my mind, this is just sort of miserable. And usually I tell people when I'm doing surgeries like this is built for comfort, not for speed. And when they ask me what I mean by that, well, this applies to my patients a lot more. Like, well, if I'm walking behind the hallway, I won't know that you have a fusion, but if you try to run from the cops, then I'll know. And that, most of my people can get that because they run from the cops, just like Rich said. So that's him all fused up. Everything went well, looking nice. So another case of post-traumatic arthritis, and this lady was 100%, I'm not getting a fusion, One of the other foot and ankle guys in town was like, you know, the only way I'll do an arthroplasty, this is before I was doing arthroplasty, the only way I'll do an arthroplasty on you is if you go see my buddy and he gets you lined up, right? Because I don't want to put an arthroplasty in and have a non-aligned limb, which I was like, that seems like a reasonable thing. So she came to see me, and her big complaints were really, you know, that she had a bad ankle and that she had some shortening on the right side because she had a previous open tibia fracture managed by serial casting, open bone grafting, like back in the 70s. So a big deal to get it to heal. So this is back in the day when I thought that the guys at HSS were really bright with their distraction arthroplasty of the ankle, and I followed everything that they do, and I've done it a couple times, and I haven't been happy with any of them. There must be something different about the New York patients that they get, but my patients have been pretty miserable after this, and I don't think I've helped them out, so I haven't really done a distraction arthroplasty for probably about 6 or 7 years now. But this is doing a distraction arthroplasty at the ankle in addition to doing an osteotomy of the previous malunion and correcting or using a hexapod frame up top. And then we're letting her actually move through the frame before. Those are temporary struts, and I have hinges in, so I'm able to be able to unlock her so that she can work on ankle range of motion while she's still in distraction. And this is poor planning right here. That's a left behind fragment. Again, earlier in my days of planning for where bones are going to move. And she did not like that, which I was able to shave down later. But showing that we get her out to length, we take off the ankle distraction frame, we let her walk around, and let the osteotomy consolidate, and there she goes with the frame off, and there she goes at 1 year. And so, you know, did I make her better? I made her straighter, like, that's for sure. And I corrected her limb length discrepancy. She was really happy about that. But ultimately, you know, ankle arthritis is ankle arthritis. So like, she still had pain from ankle arthritis, and I think eventually she'll get something done about it. Interestingly, after I gave this talk, I was putting this talk together, her ex-husband was a spine surgeon in our area, asked him if he'd heard about her ankle, and still not fused or replaced. So as we move on to more of my bag of tricks and chronic infection, so this is one of our standard, you know, open injury, ankle injuries, and he is a knucklehead, did not do any, you know, equinus and drainage and poor follow-up. So these people get a whackectomy, just take everything out that's infected. So the further I've gotten into my life of dealing with infection, because I deal with a lot of it, both in post-arthroplasty and post-trauma, as I have become more like a tumor surgeon. I'm pretty good at growing new bone, so I just cut everything out and get back to where I feel healthy. So this is taking out the ankle and trying to just put them in a temporary fixator, and then letting everything calm down. We come back, we do an open preparation for fusion. This is back when I was using, I'd do a frame for this because of his previous infection. I feel like now if I get it cleaned up, I probably would go more towards internal fixation, but this is a frame. And then for the knuckleheads, for the true knuckleheads, we leave them like this, really in compression. And then I see whether they can tolerate a frame, because there are a certain amount of people that are completely insane in these frames. And once he's tolerated the frame, then I go back and add the stuff at the top so we can get back length. And that's where I made my osteotomy go, or my osteoplasty for lengthening go a little crazy. It's a little kooky when you do it, but it actually provided a big long surface area for healing, and he goes on. So that's a transport ankle fusion. Out to full healing and back to life with no drainage. So again, this is back in the day that I thought the subtalar joint would be fine, and it turns out it's not all the time. But he got back to equal limb lengths, like I said, no drainage, and I'm pretty happy. Here's one, chronic drainage and infection after a pilon fracture. You can see the hole that's in the bottom of his calcaneus. Had a previous hindfoot fusion nail placed and then was sent in. And this is the skin you're working with. So this is why when I was talking about earlier, when I have my own patients, I really prefer, if I know that we're gonna have trouble, is to just get durable tissue there. I mean, my workhorse is an anterior lateral thigh free flap because it's normal skin and it can be opened and closed a bunch of times, but this is the hand I was dealt. And you see that he's got some instability. This is back when I was younger. In these days, I would have taken out more bone, but I went and just did a resection. And again, he gets the knucklehead treatment where we put a frame on. We wait a couple weeks and see whether he's going to tolerate that, and then come back and add the next level for length. He goes on and does this. I told him I wouldn't take his frame off until he could stand on that with one leg and not use crutches. That's one of my tests for when you ever get your frame off. And he went back to painting murals and smoking a lot of marijuana in the coast of Florida. And contrary to Rich's, I think that marijuana use is actually not bad for bone healing. So I've got a lot of patients with experience on that. But so here's a talar osteonecrosis. This is a guy that was sent in to me. This was a skiing injury that he was put back together in Utah. I didn't get to do the initial fixation, but he had a talar plate put on and then had a spanning fixator to kind of hold it in position. And you look at this and you go, okay, yeah. And this is one where they told him everything was good out there. And I saw his initial x-ray, so I'm like, everything is not good. Like, this is going to go poorly. And so that's what he goes on with. So what do? I take out the whole talus, right? So you don't need a talus. The talar head is nice that it's still alive. And so what I do is do a tibiocalcaneal fusion. This is where I do use a hindfoot nail. I find this works really well. And again, I had people that I'd done this procedure on and gone for length in the same setting, and they didn't really like that. There's a lot of stuff to go and do the osteoplasty to lengthen them. So really what I do is, I like my people that I'm doing limb lengthening on to be full weight bearing. And this person I usually leave about 6 to 8 weeks where I don't walk. So for this one, I put this in, get great bone-to-bone contact. I wait about 8 weeks. Because that's when I'm going to start weight bearing them, bring them back to the operating room, put on a simple 2-ring frame. You can see the frames are getting simpler, right, as I get older. and then we start limb lengthening. We come back, when he gets out to length, we drop 2 screws in and let him go full weight bearing. And then you get that. You can see that he had, his regenerate was a little lighter than I like it to be. But he went on to this, and people always ask, like, this is a hard thing to show, but I mean, he still has pretty good motion. And this guy's I follow him on Instagram. He's a personal trainer. So I mean, when you, like, again, you walk down behind him in the hall, you can't really tell which one we've done. And you know, but you ask him to jump, and he does not have good vertical. But let's see. So, and now this is where my life has changed a little bit. So post-trauma arthroplasty.
Josh, you'll have to round it up a bit.
This is my last case. I'll be done. So this is a lady that I fixed bad, kind of pan ankle injury with talus. Went on to have some pretty solid osteonecrosis of the talus, but not complete osteonecrosis with pain. We do flexion extension views, and I use a system that does CT-based guidance for creating blocks so you can get good cuts in the OR. And that lady goes on to get a arthroplasty, and now 1 year post, she loves it. And there was enough talus that was still alive, and this was a revision component for the talus, and really liked it. So take-home points: look for infection; it's super important. And sometimes we miss it, but don't forget the subtalar joint. Be familiar with all the approaches to the ankle, just like all these guys talked about. I know every approach to the ankle, and that's how you got to have everyone in your quiver to do it. If it's crooked, make it straight. If it's infected, clear the infection. And I used to think ankle arthroplasty was the devil. I don't think it is anymore. I'll let you know in about 8 years when I got to revise all these. It'll be a different talk. So thank you.
Thank you so much, Josh. Can we get all the speakers to come out here, and if we can start the question and answer session? Can I just say, guys, I think, the supramallear osteotomy is a very underrated thing. If you actually do it early, you will save yourself quite a few ankle arthritis, but it's just that most of the time it's neglected. You don't get to it when there is a time to get to it. Okay, guys, questions. So we've had talks on ankle fractures, the ones which you need to be wary about, syndesmotic injuries, posterior malleolus injuries, post-traumatic ankle reconstructions. Any questions from any one of you on these topics at all? Any comments? I think a lot of you do this kind of a work, so I'm sure there's a lot of queries which you always had in your mind. Don't get intimidated just because we got a highly select group of faculty.
The other thing is, people don't necessarily have to wake up. I mean, if you're asleep, it's okay.
Okay, guys, very quickly. So anything, let's say any posterior malleolus fractures. So can I have a show of hands amongst all four of you? How many of you fix 100% of posterior malleolus fractures? I know I've asked the question, not asking you. There's nothing, okay? Right. Sorry, my apologies.
Given a choice, you almost got one. Given a choice, there is no controversy about stabilizing the ring. Where I have to put in the implants and the fixation is the point of discussion. So if the posterior malleolus is adding to the instability, it has to be done.
Sure. Okay, let me ask you one more. Syndesmosis fixation, tightrope or screws?
So I don't like the tightrope because the anchor points to the medial section of the tibia. I use a FibuLink. That's the one I've been using recently because the actual point of fixation in the tibia is very close to the syndesmosis. So I like it because it has a lot of stability and a very short dynamic section. So for me, that's been.
It's actually a very funny thing. When you look at the literature, the 3 trials which are printed on this, all 3 actually were sponsored by the manufacturers.
Yeah, no, and the first one says one's good enough, and then they said you need 2. Okay. Yeah, so I'd say but the one I'm using for FibuLink, I think that one is, I mean, that's proprietary for Synthes, whatever, but it's.
But the question is, you asked the question the wrong way. You used a proprietary name. So the question was screw fixation or dynamic stability.
I've tended towards dynamic.
Dynamic.
Same, dynamic.
Preference in ankle fractures?
Depends. We've been doing screw stabilization for a long time, and I would still do it depending upon this thing. But there are situations because number one is the cost for me.
Yes.
My patient can't afford, in India the only FibuLink is still not available, but it's coming in. But tightrope is very expensive, number one. And number two is that if you could, we have an intraoperative O-arm, like a C-arm. So we can check the syndesmotic reduction right there. So holding it in place, like he said, with a wire in front and a temporary wire, and then putting in a screw works for us, very cheap.
Perfect.
Yeah, so I think more important than whether you're going to fix it dynamically or statically, important is first reduce it well. That's the key. Don't think that mal reduction cannot occur in the syndesmosis. If you just get your screw 30 degrees posteriorly, aim for the tibia, and you've done a great job. All the post-operative CT scans that you do shows how good we are at mal reduction. So if you are in doubt, open it. As I said, one more thing is put in the K-wire so that the entire translation of the syndesmosis, and you can fix with a single screw through the plate, outside the plate, depending on how you have positioned the plate. If you have a dynamic fixation, well, go ahead. And nothing is proven that one is better than the other. But how well you fix the syndesmosis, how well you reduce it, makes a huge difference.
Yeah, I 100% agree with that. I think a lot of us have gone away from using the big clamps. I mean, I haven't used that in forever. But where I always use rigid fixation also is diabetics. I still use screw fixation, quadricortical, renal patients, end-stage renal, as well as very severe osteoporotic patients. I'm going to go for rigid fixation over flexible.
So I think he's talking about the super constructs, but I mean, diabetic foot ankle fractures are a different animal. So don't even try to mix it with this. That's something that nothing is enough.
So the take-home message from his lecture was, if at all the posterior malleolus is making a difference in the dynamics of the ring, only then it has to be fixed. Now, how to judge it preoperatively? Because your incision you are going to make is according to that.
The issue is preoperatively you have to check for the degree of instability and the degree of talar shift. Because if the talus has shifted significantly towards the back and towards the lateral side in your pre-op x-rays or in the CTs, don't think of a lateral approach. Go with the posterior lateral approach. He told you, you can even fix the fibula laterally from there. But do not make the mistake of going laterally and not leaving yourself a window at the back.
I'll answer that question in a different way. If you start doing stress views every time you get an ankle fracture, you will start going posteriorly. right? Because, you know, once you start doing stress views, the obvious, the subtle, what looks stable looks unstable.
And I think that what he's talking about on the initial trauma film, if it went out the back, they're going prone and I'm putting stuff in the back, because that's the way it went.
Remember, the tail is always follows the fibula.
Thank you so much for your wonderful 10 pointers on syndesmosis. On a lighter note, I just want to ask one thing. In your last point, the syndesmotic screw broke, but why did the medial malleolar screw broke?
I don't remember that case. Yeah, okay. But that must have broken out. That's why he had pain. You see, that means the whole thing is unstable. What I'm talking about is if everything is okay and the syndesmotic screw is breaking, it is because of the fatigue. So, and that is one of the reasons why people were putting 4 cortices, so that if the patient wants the broken screw removed, it can be removed from the opposite side. You can't remove it from this side. Yeah, he was awake.
There's one more point I want to make about medial malleolus. If you're going to fix medial malleolus, your screw should engage the opposite cortex. Those short screws really don't help much, can give problems. So try and have a screw 3.5, 4 mm cannulated, get to the other cortex.
Opposite cortex. But so the guide wires are so thin. So actually first you have to drill with 2 mm K wire, pierce the opposite cortex, then put the thin guide wire. Otherwise it will not pierce the opposite
So if you have a very small fragment, you don't have to feel sorry. Just do a tension bend wiring.
Yeah, tension bend.
Yeah.
Can I just say, totally disagree with Mahinder's statement. The best screws you can put on it's a proven thing, you need a 35 millimeter screw. So the screw doesn't engage in the medullary cavity of the tibia. It engages in the subchondral bone. The worst thing you can do is try to engage a screw neither in the subchondral bone nor the opposite cortex. So that's the worst. So your best size of the screw is a 35 millimeter fully threaded cancellous screw, which is a proven, but it will be debated, I am sure.
Everyone is a different size, yeah.
But okay, but there is nothing about you have to engage the opposite.
Addressed to everybody, syndesmotic screws. You allow it to break, but how long do you need the screw, and why you cannot remove it at the end of 3 months?
3 months?
Why?
You can, so if he's in government practice, he doesn't want to do it, we want to do it, I'm quite happy receiving all his patients.
All private practitioners will remove it. In the government sector, we do not have time. We have to remove those screws and plates.
Yeah, so I don't routinely remove my syndesmotic screws.
We don't.
Leave it to the patient. So I tell them, if you want it removed, it's up to you. Otherwise, after a certain time, if it breaks, it doesn't bother them. As long as it's not bothering them, you don't need to remove them. So I won't.
Just coming to the ankle fractures, you have a lot of these osteoporotic fractures where the talus impinges on the anteromedial aspect and there is a depression there onto the tibial side. So how much is sort of acceptable and when do you have to get it back and where do you source your bone graft from when you get it down?
You're talking about almost the impaction fractures?
Yes.
Like an SAD on the medial
That's
side?
right, yeah.
Yeah, I think that's a great point. I think you certainly have to identify it. If you're gonna see that, you see asymmetry of the medial corner, then oftentimes you just get an osteotome parallel to that, bring it down, put a screw across to hold it, and you can oftentimes that's a vertical fracture there. Once you have that screw in, you can just put an anti-glide plate and you should be done. The ones I worry about are the ones that go out laterally. I think those do way worse because the blood supply is not as good. Medial side, I think, is not as important because it's medial to the mechanical axis, but you still have to keep that out of varus to protect the cartilage.
Okay.
Second part of the question was, where do you get the graft? You can get it from anywhere. You don't need too much. But one of the screws there, you can use it as a raft screw, like you use in the proximal tibia. It'll keep that fragment from depressing.
Question from there.
Sir, syndesmotic screw, sir.
I'm telling you, there's no end to this controversy.
Sir,
Go on.
I have fixed the ankle perfectly well, which I think I have. and I've checked it. And even if I do a syndesmotic screw, am I overdoing it?
Sometimes you may be. I've shown you.
And what's the harm in overdoing?
There is no harm. Well, I can show you so many cases which have been harmed also. In my next talk on Taylor's complication, you will see fixation of Taylor's done all over the country with a lot of harm. But the issue is there. It is not whether you fixed it and you feel good about it, whether you can demonstrate or not demonstrate instability, which is the clinical and radiological issue. So if you cannot move the fibula and open the syndesmosis on radiologically in all directions, you do not need the screw.
I tell you, if God destined there to be no movement there, he would have made sure they would have fused both the joints. If there is a joint in there, there is always a reason. The fibula does have to move in that syndesmotic area. Do not overdo it. It doesn't help. You'll see a lot of patients who, they can't get their ankle to move better, and they say, look, it's just not happening. And one day they come and say, it's much better now.
I can answer this.
And what has happened is the screws broken.
In Davos, 10 years ago, at AO Foot and Ankle Masters course, the most famous slide was shown by a German doctor. If in doubt in the syndesmosis, just do it. And there was Tiger Woods saying, just do her. I mean, excuse my grammar. You know Tiger Woods, who had this problem. So he was, just do it, Now that no longer holds true, because we have shown so many syndesmotic screws being malpositioned and causing problems.
Sure. One question. Hello, sir.
So, hello, sir. So, one regarding distal third tibial medial locking plates, the plates are having very thick profiles. They lead to wound breakdown. So, what is the solution for that, sir?
The question is distal medial locking plates.
plates.
Distal medial locking plates.
Did we speak about it in these 4 talks?
Yeah, so I hate that plate. So the only time I ever use a distal medial plate is when I can't nail below a total knee for tibia fracture, and I have to use that. Otherwise, I hate it.
I agree. I think addressing the medial column is really important, but those plates are super bulky. They're really, really subcutaneous. And again, in one of the things, cases Josh showed, you end up trusting the pre-contour a little too much. My preference is either use a metaphyseal plate and contour it myself, or even something simple like a mini fragger or a 1/3 tube. I also hate those medial plates.
But the medial plate is a problem. There's zero doubt about that. That's why you need to make your cut very well. Don't try to raise flaps. Just go directly inside. Put it inside. High chance of a wound breakdown on the medial side.
Oh, thank you.
Oh, okay. That's a low profile.
Okay. So I think so. With this, we'll end this session. I would request our chairperson to be on the stage, and Dr. Mandip Dhillon and Dr. Mahendra to be on the stage. Yeah, I would request him to felicitate both of them with a memento. Yeah. So we are late by 15 minutes, and there was a tea time from 3:30 to 4:45. So I would request, if you want to have a cup of tea, please grab a cup and come so that we'll start the session without any delay. So 5 minutes are yours, and after 5 minutes we'll be starting the lectures.
Yes, sir.
At the last end, okay. I would tell you, I mean, whenever it comes to final. Good. Thank you.
Hello. I would request all the Alchem team members and volunteers who are there, please request all the people standing outside to come inside so we can start. Under pressure. JES, Research and Development Society. So I request Dr. Ram Prabhu to begin this session on miscellaneous topics.
So, good evening. Now we come to the penultimate final session of today, and it's aptly called as miscellaneous because we have various different topics which we'll be discussing and interacting. So for a starter, I would request Robert to talk about fixation of talus fracture and fracture dislocations. There will be little change of topics. The second one will be Mandip Dhillon talking on the talus non-union, and then the third will be fragility fractures. So Robert.
Thank you. Well, welcome back. Alrighty, so we're going to talk about the acute management, and Dr. Dillon's going to talk about when things go sideways on these. So we are going to try to cover neck fractures, but also body fractures and some of the peripheral fractures as well, like the lateral process and the posterior body or process and the talar head as well. And we'll just speak on the pan-talar or extruded talus as well. Our objectives are to know what is and isn't an emergency, learn surgical techniques for fixing these things, and then understand the factors affecting avascular necrosis, right? We're gonna just go really quickly through the anatomy. There's no muscular attachments, but there's strong ligamentous attachments and complex articulations in the talus. The body's trapezoidal. It's most congruent with the ankle and dorsiflexion. It's got this convex superior surface with a little bit of, you know, a guide right down the middle of it. The lateral shoulder is curved and pretty good for fixation, but the medial shoulder is pretty short and steep. It's hard to get fixation over there. It's just really interesting to see how much of this is covered in cartilage. Pretty amazing, over 60% of the talus, right? So, and then here's, you know, reminding you that the posterior tibial artery through the artery of the tarsal canal is the major contributor to the body of the talus, right? So over 40 years ago, they looked at figured out the mechanisms of these. These are typically high energy injuries, car accidents, falls. Forced dorsiflexion will often cause the neck fracture. More axial will cause a body fracture. If you keep going into dorsiflexion, a lot of the time the body will get kicked out the back, and that's how you wind up with things like the Hawkins 3 fracture dislocation. And then eversion is going to, if you have that as part of the component, you're going to get a lateral process fracture maybe too. So we typically get foot and ankle series. A canale view is really important, but I think it's probably more important intra and then post-operatively as well. Intraoperatively to see that you've got your hardware safe and that you're not in varus, right? It's just an AP of the talus itself. It's inverted, so you're essentially getting the calc out from underneath it. The Broden view can be used to look at the posterior and middle facets as well. But we use CT scans on a fair number of these, right? Timing of the fixation, though historically was this, you know, considered very important, does not seem to matter. Heather Valier's paper in 2004 out of our shop pretty much confirmed that, and it said essentially the AVN was really more related to things that were surrogates for high energy, like open fracture and comminution. In the Bellamy paper in 2011, they looked at Army recruits, and even at 12.9 days, the average time to fixation, no increase in AVN. And then Heather's paper in 2014, the follow-up to her other paper, showed that even the reduction, the timing of the reduction didn't seem to make that much of a difference. So then is anything an emergency? Well, yeah, the open fractures are still a concern, right? Closed dislocated fractures as well are, and then closed fractures with soft tissues at risk, right? Or ones with neurovascular compromise are ones we really need to get on earlier, right? Closed methods are really non-operative, really for truly non-displaced fractures, or really minimally displaced, maybe in a not so firm patient. But closed reductions of dislocations prior to actual fixation, like if you get a Hawkins 3 and you get that reduced closed, you're not compelled to then do your open reduction immediately. You've got more time if the patient is unwell or if it just doesn't work logistically, right? So in terms of surgical principles, you really want a high quality reduction because that's going to help delay or mitigate your post-traumatic arthritis. Avoiding varus optimizes foot function. I'm not going to get too far into that. I'm going to let Dr. Dillon talk about that. We really want stable fixation to maximize our revascularization potential and allow for early motion, right? So there's a lot of different exposures. For the talar neck, the combined anterolateral and anteromedial are the workhorse, you know, of what we do. We do combined both, okay? And then you can see for the talar body, there are multiple different options depending on where the fractures are, and we'll talk about that a little bit further. So, as I said, dual approaches are the default answer for talar neck fractures. The anterolateral approach allows you to get to that tension failure, usually the simpler pattern that you can often plate. You can clean out the subtalar joint, and if you get a combined lateral process fracture, you can take care of it there. Anteromedially, you can help deal with that dorsomedial articular injury and span that and often put a position screw down the medial column. Use both to reduce the fracture, right? So the anterolateral approach is in line with the fourth ray. It's the upper end, the lower, the extent rather, of the pilon anterolateral we talked about. You protect the perineals and sural nerve plantarly and the SPN more dorsally. The deep dissection goes through the retinaculum and then you retract the EDB plantarly to get to the lateral talus, right? This allows access to the lateral talar neck, the distal lateral dome, the lateral process, and the subtalar joint. And the anteromedial approach is essentially between the anterior tibialis and the posterior tibialis, right? It's from the anterior colliculus of the medial mal to the NC joint. We extend it more proximally for medial malleolar osteotomies, and that'll give you exposure to at least the midpoint of the dome or so. So in terms of the reduction, right, the lateral reduction of that lateral tension side, which is usually a simpler pattern or is a fair number of times, is what we typically do first. We compress that, get our provisional fixation, and then we'll go over to the medial side and see how we're doing. Obviously, we want to keep that out of varus, as we said. There's really no good or great place for fixation. Plates and screws are typically placed on the non-articular surfaces. As what we saw earlier, there's not so many non-articular surfaces. The exception to that is on the medial side where countersunk screws through the talar head are placed often in a retrograde fashion. I'm trending towards smaller and smaller fixation there because the talonavicular joint is fairly important. There's less room for plates medial than lateral, right? All right, so here we are. We've got this, we've done the lateral side, we come over to the medial, we're just looking at this, and you can see the lucency in the neck here. And this is of some concern, and it's not that uncommon, right? So medial neck comminution is fairly common, and it's a recipe for instability. Varus is a problem, and you need a solution for it. So we get this pie-shaped defect, right? And what are we going to do about it? Well, I'm not going to get too far into this because, again, I don't want to steal Dr. Dillon's thunder, but varus malunion, either through a surgical misadventure or through postoperative collapse, is problematic. It leads to uneven loading of the facets and really just disrupts the kinematics of the hindfoot, and patients do poorly, right? So what are we going to do about it? If you've got this defect, you need something to help with stability? Do you need something to help with union, or do you need both, right? So there's a few different things you can do. We just took the 3265 tissue protector, right? It's got a serrated tip on it, went to the medial malleolus and took some local graft right there and fed that right in there, and we were actually able to fill that right up right there. So that's one answer, right? Here's our finals on that. Here we have a 39-year-old female, 8-foot fall, arrives 3 days post-injury. You can already see this is trying to dislocate, right? So she gets splinted. Maybe it's a little bit better, but you get a CT, right? And her head is essentially sitting on her medial body, just anterior to the medial malleolus, right? She's got a pulverized comminuted medial neck. We put a frame on to try to get this out to length, and then we do our anteromedial and anterolateral approaches. We've got a plate on laterally to support it, and there was no medial neck, essentially. This went all the way to the talar navicular joint. So we temporarily spanned to the navicular to keep this out to length. We did acute Gertie's grafting for this, and then we left the external fixator on for 6 weeks just to neutralize this until it could consolidate some. And we took the medial plate out at 4 months. I would have probably taken it out at 3, but she didn't show up. And you can see she's already a little arthritic, but she's maintained her alignment. There are other ways to fill the defect. You can do a tricortical autograft from the iliac crest. You can use a fibular allograft, or we've even bent 2O plates to try to keep the head out to length. So there's a lot of different things you can do. So that's Hawkins, that's like a Hawkins 2 with a medial defect. Now we're moving on to Hawkins 3 type fracture dislocations. This is a 14-year-old, again, in Montana, airlifted to Seattle. It's about a 10-hour drive. 15 hours since injury, closed and isolated. She's got contusions and blisters. She's got decreased sensation in the plantar foot. So, you know, this is getting to be a little bit more urgent. She's got a progressive neurologic deficit. This was a CT that was obtained in Montana. Really not much in the way of comminution. Pretty simple pattern, but dislocated just the same. So she went to I like to call these Hawkins 3 a.m.s because that's when it seems like I wind up having to do these. So she went to the OR urgently because her soft tissues were getting worse and her neurologic condition was declining as well. So we did try closed reduction, general anesthesia, paralysis. We flexed the knee to relax the gastroc, traction on the hind foot, valgus, angulation of the calcaneus, direct pressure on the body, and, well, it didn't work, right? So now we move on to, with that closed reduction unsuccessful, she gets general anesthetic, chemical paralysis. She gets a medial external fixator. You can do a delta frame too, but I believe we just put a medial frame on her. You do get better balance. If you have a century-threaded calc pin, you can actually steer that pretty well. And then you use the open compressors to gain length, to open that up, to reestablish the space to bring that back in. So once you do that, I did an anterolateral approach, and then you sweep the posterior capsule to make sure it can get back in, and there's nothing in the way of the reduction, none of the posterior medial structures, right? And then we used a 2.5 terminally threaded Chance pin as a joystick into the broken, fractured surface of the body. And then once we do that, we take a freer to serve as a skid and to unhook the posterior facet, and then we just guide the body back into its happy home, right? So if that's unsuccessful, you have to think about what are the next step if that doesn't work, right? So I had to make my anterior medial approach. I don't know how much that would help, but sometimes being able to come at this in a perpendicular fashion rather than around the corner may help. You can do, I've had to do a posterior medial approach once or twice just to clear stuff up, because it seemed like the body was about to come out the skin back there. But that's extremely unlikely, extremely uncommon. I've had to do Strayer, gastroc recession as well to get a little bit more length as well. And occasionally you may have to do a medial malleolar osteotomy, but we already have one here, so that's not a big deal, right? So now she has a reduced body, it's, you know, reasonably reduced. It's 3:45 in the morning. You may proceed, but it does not always follow. We did not, okay? We chose to do this in a more elective time, particularly if you get a polytraumatized patient. You may not want to do that either. This was done 5 days later with combined anterior medial and anterolateral approaches. So on this, like we said earlier, we repaired our lateral column. Now we did medial screw fixation. Here's her finals. We did the medial malleolus as well. 2 months later, she's still non-weight bearing. We usually keep them off it for 12 weeks. Plantar sensation is improved. At 6 months, she's healed walking. Ankle and subtalar joints are a little stiff. The body's a little dysvascular, but without collapse. And at 9 months, she's a little stiff, but not painful. And we'll probably follow her for at least, 1.5 to 2 years, right? Okay, so we're going to move to talar body fractures, less AVN, right, but more arthritis than next, right? Makes sense. The highest rate of arthritis because it involves both the tibiotalar and the subtalar joints, and up to 50% of talar body fractures also have a talar neck fracture, right? So here we got a 36-year-old roofer, fell a couple stories, right? Any thoughts? You want to reduce this? This is, you know, like half a Hawkins tree, right? It's got a piece out the back. Soft tissues on him aren't good either, right? So you got to think about what type of approaches we're going to need for that. He's got medial fracture line more posterior, but the lateral fracture line's more anterior. He's got debris in his subtalar joint. He's got a separate smaller dome fragment. So you really need to get he's got a fibula fracture, right? So our closed reduction failed, so we did a percutaneous reduction, again with a 2.5 terminally threaded Schanz pin, and then we pinned that, right? And then we released that we had placed an external fixer on him. Then we released the excess distraction, and then we thought a little bit more about this and realized that the visualization was we're going to need to see anterior to the dome. Most of the fracture exits sort of anterior to the dome, so we're going to need like anterior medial, anterior lateral approaches more than a posterior approach on this one. So now we're just lining this up to get started, and we decided this would benefit from a medial malleolar osteotomy. So we got that set up, and just as John said earlier, you got to be a little careful as you come through. You don't want to go into the posterior tib tendon or the posterior medial structure. So when we get a little close in the back, we go a little slower, maybe nibble, as he said, and then we flip down the medial malleolus and complete. We sort of lever the whole thing out with an osteotome and reflect it distally. The clamps, when we're doing this, you know, you should really compress these. This is articular fracture, so you want compression. And we got our provisional fixation with K-wires, independent 2.4 and 2.7 screws. We did place some of the 2.4 screws in the K-wire paths, is essentially using those as our drill bits. And then we used just bioabsorbable pins for that osteochondral defect anteriorly on the talar lateral dome. Here are our final radiographs. Okay, here's another, this is a more posterior medial one. You can see this here on the CT, it's mostly posterior medial. So we do this prone, right? We got a frame on this as well, so it help us get some length. And the modified posterior medial is good. We're just medial to the Achilles, and we incise the FHL fascia and then work between the FHL and the Achilles, and then having that over helps protect, adds to the things protecting the posterior medial neurovascular bundle, okay? And here we are again prone. You can see you're in a little bit of a hole, but you can, in the bottom right, you can see the fixation there. And here, wait a second. It doesn't want to play. So that video played when we looked at it before. How come that won't go? It's not a big deal. You can see the subtalar joint and the plate on the posterior. Yeah, thank you. Perfect. Okay, so here we are in the subtalar joint, right? You can see just above it the plate that's fixed the fracture, and now we're coming into the tibiotalar joint. This is a little distracted. You can see the frame on the medial side providing that distraction, and we can feel over the top and make sure that everything's smooth. And now we're going to expose the FHL, show you the FHL. It's right over there. And now you can see it's moving freely, and that's enough of that. Okay, so moving on to lateral process fractures, you know, known as the snowboard's fracture. A lot of these are missed on plain radiographs, and a lot of these will also, a lot of talar neck fractures, 40% will have a lateral process fracture. They're often bigger than they look on a radiograph. So you get a CT and you're like, wow, that's bigger than I thought it was, right? So it's important because there's articulations with both the posterior facet and the fibula, lots of ligamentous attachment. So don't excise these, right? And look for impaction. So here a guy who's had 2 weeks of ankle pain, okay, and you finally saw that on a CT. The incision is just from the tip of the fibula parallel to the plantar surface, right? And you want to use a distractor so you can see into the subtalar joint. Address your impaction, right? We use K-wires as provisional fixation. 2OT plate with 2O screws, independent K-wires if there's a significant comminution. The plate goes on the front of the lateral process, and then the K-wires come around the side a little bit, and then we just bend those over so they're not proud. Okay, so these are pretty important to fix. They should not be ignored, okay? If the lateral process was addressed, only 50% of them get subtalar arthritis. But if it wasn't 100%, so really we should be fixing these if you can. So just a quick word on talar head fractures. This is the all-important talonavicular joint. It's like the universal joint of the foot. This may be part of a show part fracture dislocation, and usually it may often be in combination with other foot trauma. And you may need length with a distractor to see into the talonavicular joint in order to get a high-quality reduction. And you may need to leave the X-fix on 4 to 6 weeks to neutralize that as well. So finally, okay, the extruded talus, the pan-talar dislocation. You know, without an obvious contraindication, wash it up and put it back in. There's really not great reconstructive options, and surprisingly, the outcomes of doing this are not bad. One of my litter mates from my fellowship in Seattle, Carla Smith, wrote on 19 of these, again out of our shop, and 12 out of 19 of them didn't need any further procedures. And then Bowden in Cleveland had no deep infections out of the 19, and while 14 out of 16 showed some signs of AVN, only 2 collapsed, right? So this is, you know, surprisingly good considering what a horrible injury this is. Okay, so when we're done with these, we splint them in the OR. When their wounds are sealed, we get them going on ankle and subtalar motion. They're non-weight bearing for 12 weeks. We just use plain radiographs. We're not getting MRRs and CTs unless there's something that we're working towards, at least not routinely, right? And then the weight bearing, we typically start their weight bearing at 12 weeks despite questionable vascularity. It's not uncommon. In terms of the outcomes, right, varus and subtalar arthritis is common and leads to poorer functional outcomes. The most common indication for a next procedure or secondary procedures with subtalar arthritis. There's no association between a delay to the OR and AVN and talar neck fractures. And AVN, post-traumatic arthritis, and lower functional outcomes are more related to comminution and presence of an open fracture. This is very interesting out of Heather Valier's paper from 2014. This is in JBJS. Okay, she looked at this and she found that AVN never happened without a subtalar dislocation. So she divided the Hawkins 2 fractures into body, subluxated, right? The fracture subluxated, the subtalar joint subluxated as opposed to this 2 Bs where the subtalar joint was frankly dislocated. And if it was not dislocated, they didn't get AVN, right? So half of these folks would get post-traumatic arthritis, okay? 80+% if they also had an associated talar body fracture, and 60% with a Hawkins 3 injury, right? So in summary, reduction of these dislocations in Hawkins 3 and 4s are more urgent for the skin and neurovascular issues than they are for the risk of AVN. The timing of surgery does not affect that, right? You want to access the articular segments and reduce anatomically through dual approaches in neck fractures. Avoid varus. And subtalar arthritis is the most common complications. It's really the natural history of these.
So thank you, Robert. I think we'll take the questions at the end of Dr. Mandip Dhillon's lecture. He's going to talk on talus, non-unions or malunions.
You can take a comment or a question while we are silent.
Yeah, what is it? Yeah, so is there any question now till then? Mahendra wants to ask something, I think. So, Robert, looking at the X-rays, yeah, I'm here. I'm the podium. So, when you see the AVN on the X-rays, maybe after 1 or 2 years, you're not really scared of it, right? So
well, it depends on the extent, right, and how much it's
no
affecting.
collapse, just AVN.
If the patient looks dysvascular, we will follow them further, and if they're asymptomatic, you know, we will follow them, but we're not going to pursue a secondary procedure.
Okay.
Ram, the
Yeah.
AVN will manifest within a few weeks. Okay? And it also depends, as he said, from the history, whether it was a full dislocation or a type 2 with a subluxation. Number 2, we've classified the AVNs from our center. We've had a follow-up study. They often involve only half the talus neck. If they involve the full talus, if you on a AP view of the ankle, if the whole top of the talus is involved, then we offload them. And I have got about now 9 cases of frank full AVN who have been offloaded with a special brace, pattern-ended prosthesis with no collapse. The problem with AVN is only when it collapses. Otherwise, if the fracture unites, they revascularize. Even some of the malunion cases I'm showing have AVN too. But if the fracture unites, you see the difference between an AVN and the hip is there is almost no protection. Like in the Perthes, you call the lateral column or this. Even in the talus, if half of the body is not avascular and you are careful, this does not collapse.
Okay, fine. So I think we'll
on
get...
that, the Hawkins 3 I showed you, there was actually some dysvascularity in the lateral body.
Yeah, it doesn't matter. You follow them up long enough. I've got now post-AVN follow-up of almost 9 years. If they heal up to 1 year and they have not collapsed, they will not collapse.
Okay, go ahead.
So, I'm going to talk about something for which you were denied tea. You remember that? You went out, got no tea. It was because you had to listen to this talk. How many of you have treated a malunion of the talus? Only 1 or 2. So I can say what I want, it doesn't matter. Okay, now I'm going to be talking about a combination of malunion and non-union. And remember, as you have been told by Bob, these guys get a deformity, they get joint incongruity, and they get significant disability. In the US, they come to this because they have not been treated. In India, they come to me because they have been treated. And you'll see that I've got so many of them with treatment and without treatment, and some may be associated with AVN and some with arthritis. So this influences the ultimate management. So if that is the problem, what can we do? The first thing is we must recognize what is this. And there are many options available short of fusions. And as has been shown to you, if you fuse one joint, I remember Dr. Tully telling me, once we were in a conference, I was a young, enthusiastic guy. He says, remember, in orthopedics, if you do a joint replacement or a joint fusion, that is not the end of treatment. It is the beginning of some other problem. If you do a joint replacement, the patient lives long enough, he will get a revision. If you do a fusion in the lower limb, patient lives long enough, the joint above and the joint below will give you problems. So these are not end-stage treatments. It is just a temporizing thing because till you that, so we have to think of the other options which are available short of fusions. So firstly, we need to understand the problem. And there is a classification by Zwipp and Stefan Remelt which talks about malunion or non-union associated with other things. So there are types 1 to 5. So if there is an active young patient with no arthritis, we should save the joints. But if there is associated arthritis, then you should not be heroic, you should think of fusing the joint. So keeping this in mind, I'm going to show you a few case examples. This was a 20-year-old male, came to me at 5 months. This is many years ago when even my experience was limited, but you can see his deformed foot. He walks badly. According to Heath Wellier, this is a 2B. The subtalar joint is subluxated. And this is one of the reasons why the first guy who tried a closed reduction was not able to reduce it. So there is a problem in the joint there. So we were brave. We did the fracture exposure through a malleolar site, and you see the malunion site. And remember, if there is a malunion, there's always a degree of rotation. So I put in K-wires to give me an idea of how much derotation I'm going to do. So they act like joysticks, and then you go and expose the malunion side. And then we mobilize this. After an osteotomy, we try to mobilize the fracture to bring it down into plantar flexion and do it from the medial side, but the subtalar joint would not move. So we went on to the lateral side. We tried to, through a sinus tarsi approach, we struggled to reduce the subtalar joint, and I probably think I ended up damaging the subtalar joint. We temporarily got it there, fixed it with a K-wire, came back from the medial side and fixed it. And here, you didn't, not only do you need to check the reduction of the dorsiflexion element, you have to look after the inversion. So you have to use these K-wires as joysticks. You reduce it, and you can see that we have fixed it, and it doesn't look that bad. But remember, the subtalar joint has been fixed and held in a position, with, although temporary, but which did well. So here also, the patient did well. There was no avascular necrosis, but they accepted the subtalar joint subluxation. There was a fibrous ankylosis probably, and did well. Not come back, but he's not the best person in the world. Now this is another girl. She came from Himalayas, Himachal, this July. 4 months old, ununited, malpositioned Hawkins type B, 2B. Actually, this year itself, I have treated 6 malunions of the talus. I do not know, they just somehow seem to be coming to me. But you can see the problem, and you can also see by the CT and the MRI that there is an element of avascularity also. And there is a significant subluxation of the subtalar joint. So look at how she walks. The foot is deformed. There's an element of cavus, varus. Everything is wrong with this. And she's 19 years of age. So we went in. Here we have a little trick. We extended the lateral approach, and we identify the calcaneofibular ligament, and we cut it and retract it, which exposes the subtalar joint very nicely. So I'll show you a video of another case of what we did. And then you can go in, you can see the subtalar joint, you can attempt to reduce it using various devices. Before we put in a distractor, we tried a laminar spreader, which helped us. Then we went on the medial side. And from the medial side, you reduce it and fix the talus. And I did not want to fuse the subtalar joint, so I temporarily held it in position with a transfixing K-wire. And at the end of, because this was done in July, at the end of 4 months, her avascularity is improving. You see, it's only half the talus on the AP view. Union is doing well, and that's the screw with which we've anchored, with which we've fixed back the calcaneofibular ligament. Her alignment is good, union is progressing, some element of partial avian, so I've given her protected weight bearing. And I'll come next year with the follow-up. Now, some people fix these. Bob says he fixed them all the time, but some people fix them like this, and they come to me with fixations in a bad position, which are a much bigger problem than if they are virgin, malunited, or ununited talus. Now, this is a policeman who had bilateral injuries. The ankle on the opposite side was fixed fairly well, but the talus on this side was fixed like this. I do not know what to define what kind of fixation this is, but it was fixed like this, and by the time he came to us, his screws had broken. The body was sclerotic, and he had a problem. Again, this was many years ago, so I did the same things. I did an osteotomy of the medial malleolus, I did an osteotomy of the talus, and we fixed it, and we left that broken screw over there. And again, our struggle at the subtalar joint, we were not able to reduce it. But it was still left in the position, because my primary aim was, can I save the talus and get the ankle functional, so that even if I have to do a fusion or an arthroplasty later, it may be of some use to me. Uneventful healing by 6 months. You can notice that the avascularity is reducing, no collapse, but the subtalar joint spontaneously fused. The first one was fibrosed. This was the third case or something. This spontaneously fused, which allowed the vascularity of the talus to come back. So this is something I've discovered on my journey in treating these cases. But this guy had anterior impingement. There was this little fragment which was lying over there. So at 4 years, we went in. At 6 years, we did an arthroscopic excision, and his impingement improved, but his subtalar fusion was solid. He's done well from this point of view, and this is a 10-year follow-up. Look at the other ankle. The subtalar joint is fused, the other one is not fused. This ankle has no arthritis, but the trimalleolar fracture already has arthritis. So we've been able to save this ankle from arthritis by doing the correction of the malunion. You see, so if you follow up your ankles long enough, 30% of them will get some arthritis. This is a study I'm working on right now. So guys, another case, neglected, put in a plaster. Put in plaster, POP, you can see the subtalar joint, subluxated, dorsiflexed, head of the talus, plantar flexed body, and that's again how he walks. They come to you walking surprisingly 4 or 5 months down the line. See? Foot is deformed. There is a lot of pain, and there is cavus and a varus over there. Same thing. We modified the lateral incision, but here it's a video which showing that you identify the calcaneofibular ligament. You cut that ligament and you retract it. We've retracted, which allows you to easily see the subtalar joint. And using a Hintermann retractor, you can open up the subtalar joint. You see, this was an older patient. So here we were now looking at a primary subtalar fusion, because we know that it helps us to get the talus to heal. So we denuded the subtalar joint, and we then exposed the talus medially, identified the fracture, and tried to reduce it to the best of our ability. So this fracture has to come down, has to come out of varus, and maybe a little bit of bone graft is to be added to it. And then with a laminar spreader, we were able to reduce the fracture. We fixed it, and we also then fixed the subtalar joint with a little bit of bone graft. So this led us to a well-fixed talus with a suspicion of avascularity, and he went on to heal. This was his x-rays last month, about 15 days ago. His subtalar joint is fusing. Look at the avascularity, no evidence of avascularity over there. And his fracture seems to be healing. So this is an end result which I would be very happy with. So remember that in delayed or ununited cases, your lateral exposure needs to be extended to get to the subtalar joint. Subtalar joint needs stabilization, and reduction is difficult, and if you're fiddling around there, you're probably damaging that old reduced joint, so you fuse it. And the head neck fracture needs to be brought out of brought into plantar flexion because it's dorsiflexed. The rotation has to be corrected, and distraction is an essential tool for you to work. And I think in my experience, in some of them, primary subtalar fusion helps. But some cases cannot be corrected. This was a type 2 talus, referred to me in 2013, and this young man was operated in Rajasthan, and the referral slip said, well-healed talus fracture, minimal evidence of avascular necrosis. But look at what the problem is. The talus is mal-rotated by 60 degrees. The subtalar joint is not beneath the talus. And this is what his foot looks like. He walks like this. But the surgeon was satisfied with the union. Anyway, CT scans told us what the problem was. The talus was badly malrotated, the subtalar joint was dislocated, and this is what it looks like in surgery. We went to surgery with all the options open. The deformity was not correctable even under anesthesia, and you can see the old scar. They'd done all the surgery through an anterior approach with a medial malleolar osteotomy to boot. So we went in. I exposed it through the medial incision, tried to see if I could move the subtalar joint. Nada. Didn't move. Went on to the lateral side, exposed the subtalar joint, and we started denuding it for a primary fusion. And then we found that it's not going to be working for us to be able to do an osteotomy. So in addition to the subtalar joint, we also denuded the talonavicular joint. And at that time, I never used to do a double fusion. I used to do a triple fusion. We denuded the calcaneofibular joint. And now, with a deformed talus right there, the foot is totally correctable. So we left the talus deformed, and we did a fusion with a normal looking plantigrade foot with a mal-rotated talus in place. Now I have a follow-up of 10 years, but the video doesn't seem to be working. And he's very happy. He sends me mithai every New Year's. But again, Bob was talking about the avascular necrosis and collapse. Some people, in our country, we try and do something like a Blair fusion. It still works. Tibiocalcaneal fusion we are keeping for the bad extruded taluses and etc. But Blair fusion works, and the Blair fusion everybody in India knows. The original Blair fusion was take out the dead body. I try and keep it because it will revascularize to some extent. It will give some space over there and it can help over there. So this is a guy who was taken up for Blair fusion. The ankle was exposed through this anterior incision, and you take the tibial graft harvest, you prepare the ankle also properly, and then you slide the graft into a notch in the talus. You fix it there, you temporarily stabilize it with wires, and then you fix it with screws. That's how it works. And at 1 year, it all heals up. So this guy has got a fused ankle, but a functional talonavicular and subtalar joint. Now what will happen to these joints 20 years from now or 10 years from now, I don't know. But right now, he is happy because he is able to walk with a plantigrade foot. He is a manual laborer, so this is the best I can offer him rather than an ankle arthroplasty. So folks, the take-home message. These cases are not uncommon. If you become some kind of a referral surgeon or something, you will start seeing them, and they get into malunion or non-union even after fixation. Now I have a series of about 27 cases in the last 10 years. These cause pain and deformity. And there is always a fear of avascularity. So the plan should always be to salvage and try reconstruct this, the anatomy over here. So without AVN, the osteotomy and talar reconstruction work well, if you plan it properly. When there is a problem in reducing the subtalar joint, you should fuse it, because then the talus will start getting vascularity from this joint, and the AVN would be helped also. If osteotomy is not possible, and I've done it in 2 cases, we used to do it for poliomyelitis, if you remember, the guys who got as much gray hair as I've got. And when associated with AVN, Blair fusion is the best. Thank you so much for your patient hearing.
Thank you, Mandeep. And are there any questions?
I have a little comment. Bob showed extruded talus. How many of you think that an extruded talus does not do well over a long time? Extruded talus.
Can you
doesn't
talk
do
with
well.
Mandeep, can you talk on the mic, please?
Does extruded talus do well over time, or it's a bad outcome? I have the literature for a long time was talking about taking it out.
Does well.
Does well. I agree.
Yeah, so
one of our faculty is an example of 40 years follow-up today.
So extending that, Robert, you were lucky to get the close reduction of that extruded talus in the case that you showed at 3 o'clock in the morning. But in case you are finding it difficult, so should you have a low threshold of straight away going ahead and operating it? Yeah, exactly. So not that, in fact, I would say that many of the cases it's not possible to reduce it primarily.
So we were unable to, the 14-year-old girl, we weren't able to close reduce that. We did do an open reduction. I do think the reduction matters in terms of time because her soft tissues were getting worse and her nerve function, her plantar nerve function, I mean, essentially her hallux was flexed down because the body was on the FHL, right? So it's not surprising. So, but that's important from a time standpoint. Getting the fixation into that, once that's, the body is reduced, okay, it's not stabilized, but it's reduced, is far more important than the fixation. Now, you can make an argument that, like, that's another use of an OR time or what, you know, you could absolutely make that argument, but we went the other way.
Thank you. Dr. Rajesh, can you just come to the mic? Meanwhile, discussion can go on.
Valier. she published one of the largest series when she classified these into 2A and 2B, Hawkins 2A and 2B. And she's the one who's actually shown from a meta-analysis that it's the urgency is in the reduction, exactly what he says, not in the fixation.
So, Robert, you also said that the lateral process fractures could be missed. So should you also take the CT scans in all the possible or suspected fractures of the talus?
I think you hate absolutes, right? So if you have somebody where things aren't making sense, right? Certainly, and you've gotten imaging and there's nothing there and they hurt in that area, that would be a consideration, right? You can also do selective injections in those areas, but like I don't think we need to be doing CT scans for every ankle sprain by any, but but if this is unrelenting and it's not right on the ATFL, right, then that would be one consideration, right?
Okay. Yeah, Samir, you wanted to ask something.
He was wanting to find out if they could be replaced with these artificial talus or 3D printed taluses. There's a study out of Japan which is talking about these replacements. But they tend to, the problem is how do you fix it? There's no places for the ligaments, etc. That is one. And they tend to erode the joint in one place, number one. Number two, in the presence of an open wound, it has now been shown you should not be putting all of this. So the consensus is actually, I've just been getting messages from Sampath Dumbrepate. Our study is pending an injury of 23 cases of extruded taluses, out of which we put back most of them. Only 3 needed tibiocalcaneal fusion later on because of collapse. And 2 or 3 of them have a low-grade persisting infection. Because they came in late and there was contamination, talus was picked up. The persons who have soft tissue attachment and the talus is lying right there. There are people who come with talus in their pocket also. No, it's true. You want a real-life example? One of my faculty members in this conference took it in his pocket in a handkerchief 40 years ago. You can talk to them. So those guys, you can do it. But the trick is lavage them, stabilize them, and hope for the best. The message I give today is, I can give you no absolutely good solution for extruded talus. But you've got to work with the best, because if it heals and there is cartilage loss, you have a good potential for fusion or arthroplasty later on. But remember, an extruded talus involves 2 joints, the ankle and the subtalar. So we hope that the subtalar fibrosis, and then you can do something for the ankle.
Yeah, so I would invite Dr. Rajesh Malhotra, who is going to talk on fragility fractures. Professor Rajesh Malhotra has been from Delhi, AIMS chief. He's a professor and head Department of Orthopedics, chief at Jai Prakash Narayan Apex Trauma Center and All India Institute of Medical Science, New Delhi. He has been the past president of Indian Orthopedic Association and president-elect of Asia Pacific Osteoporosis and Fragility Fracture Society. So we have Rajesh Malhotra, who's going to talk on fragility, who is going to be the president next. Rajesh Malhotra.
Thank you, sir. Thanks for having me here. I'm going to talk about fragility fractures because these are the patients who you want to send back alive. You want them to be mobile, and then you don't want them coming back to you. And this is also the fracture where very often, without realizing, you give them a care gap. You don't look after them as well as you should, all your patients, and that's what I'm going to prove. So we'll just quickly take you through the fragility fracture definition, the burden, why should we bother about it, and whether it is a sign of failing physiology, whether it's like we call it hip attack, or whether it's something impending doom for the patient overall, need for multidisciplinary approach, treating conservatively sometimes, surgical principles, rehab, prevention, and taming the dragon. So a lot to cover in 15 minutes. It happens when you fall from a standing height or a minimum trauma, or whether without any history of trauma, usually elderly, but they have underlying frailty. It's on the rise. We know that, something called silver tsunami, and the numbers are really mind-boggling, but most of them are going to be in Asia. So that's why it's very important to discuss this in this part of the world. And it has been said that the change in population demographics will lead to 2.28 times increase in incidence and more than 1.5 times increase in cost. And surprisingly, as they look at the rate of growth of different populations, the maximum growth is among people who are more than 85 years of age. And that's what is worrisome. The vertebral and hip increase with age, and the wrist predominantly occurs in younger patients. I'll talk about it again. That's something, a slide I love to talk about. And then, of course, we know about the burden. There's one every 3 seconds. And then the combined risk of heart attack, stroke, and breast cancer in a lady is less than the risk of an osteoporotic fracture. Now, this is what I like to talk about. Now, if you look at the curve, the wrist fractures occur in younger patients. That's because when they fall, they have good reflexes. They put their hand down and they break their wrist. When they get old and their reflexes get slowed down, they fall sideways and break their hip. The message here is that that the wrist fracture is a harbinger of subsequent fractures. But more than that, even if you're 80, 90, or 100 years old, if you're cognitively alert, if you have good reflexes, then possibly you will not end up with a hip fracture even after falling at the later age. And it's also during this osteoporotic career, each of these fractures presents an opportunity for intervention which is often missed. So if I get a lady who's 40 years old, comes with a Colles fracture, I find out all the risk factors, including whether her mother had osteoporosis or whether her mother had an osteoporotic fracture. And when you are not doing that, you are really missing an opportunity and making sure that she comes back to you with a hip fracture later on. And the COVID saw the problems. We know there was a talk about denosumab. We know that if denosumab is not taken on time, it actually causes rapid decline in bone density, which can be as early as within 1 month of the due injection, and then that actually also caused problems during the COVID. We must understand frailty, which is distinct from aging. Frailty is decreased physiological reserve, cognition, and social function. And then there is something which is being increasingly recognized, which is sarcopenia. Now, sarcopenia is the gait speed less than 1 meter per second and a reduced low muscle mass. So, in fact, out of the 3 risk factors, a slow gait speed, a low grip strength, and a low muscle mass, if you have 2 out of 3, then you are suffering from the sarcopenia. And that actually, along with physical frailty and general frailty, is the recipe for disaster, because up to 95% of the males with osteoporotic fractures and 68% females with osteoporotic fractures have sarcopenia. Then, of course, the fall. You break because you fall, and approximately 1/3 of people above 65 years of age fall every year. Half of above 80 fall every year, 20% need medical attention, and 10% sustain fracture. And then this is the 6th leading cause of death among people more than 65 years of age. And we know the statistics about the hip fractures. So it's a deadly trinity of force, fragile bones, and fall itself. But then why worry? We worry because these are the patients who have medical comorbidities, the complex fracture patterns, they are frail, and they have the poor purchase of implants. So when a patient with fragility fracture comes, the first aim is to keep the patient alive. So that needs the acute medical management, and then you fix the fracture. Then there are the surgical challenges about that. Keep the patient mobile. That needs a multidisciplinary rehab, and then keep patient from returning to your fracture unit by the osteoporosis management and the secondary prevention. Now, of course, there has to be a quality control of the process. Now, it has been proven that if you have a multidisciplinary approach, you could decrease the postoperative complications, hospital stay, and mortality. So I tell my geriatrician, you admit the patient with a hip fracture, we'll come and operate, make him stand and walk, and you take care of him before surgery and after surgery. That's the best chance they have for survival. So there is a decreased time to surgery if you admit it with them, and shorter length of stay, improved outcomes, decreased mortality, and lower costs. So surgery, of course, is for fragility hip fractures is a must, because that's what can save the life. But the medical care is equally important. Delay in surgery could be because of coexisting morbidities, the system errors or hurdles. Who should operate if it is so urgent? Should attending come at night and operate, and who should be in charge? And then the problem here is that the impaired biology, though it's not absolutely correct statement, there is some impaired biology, but implant fixation is the real challenge here, and the operative complications in terms of failure of fixation, secondary loss of reduction, and iatrogenic fractures are problem. I believe that a hip fracture is a sign that a person is on his way to death in most cases, and of course, majority will survive, but a much larger than I like number will die. So this is a sign of failing physiology, as I like to say, and we like to call it a hip attack, because they have very often comorbidities. They have impaired metabolic response to injury. They have hyponatremia. They can get into delirium around the perioperative side. They are in polypharmacy. And then, of course, there are problems related to management, including the theater scheduling. All of us, even at the Jayaprakash Trauma Center, we aim to operate on them within 36 to 48 hours of admission. They should be operated and they should be out. Now, this is the only indication where the patient's surgery may be delayed in a hip fracture, that is an ongoing or recent acute coronary syndrome, decompensated heart failure, uncontrolled arrhythmia, and severe valvular disease. The other things are not, other conditions are not a contraindication, and there has been shown that there's no role of preoperative echocardiography, which your anesthetist is often asked, never changes the outcome. So, surgeon's perspective from operating it is just to keep it simple and short, or simple and sweet, stable fracture fixation, prevention of secondary loss of fixation, possibility of impaired fracture healing, requiring some kind of help sometimes, and then find, this was said in the morning, find a balance between minimally invasive and restrictive surgery versus high stability and early functional mobility. And we would remember from his message right in the morning. But then there is an excellent role of conservative management as well. Treating them conservatively is not neglecting them, particularly in patients with comorbidities, patients with spine osteoporotic fractures, upper limb fractures, COVID, this was seen, and then in the resource-limited settings. So there is no absolute indication for conservative treatment, but then we have reviewed the non-surgical treatment, including using some indigenous braces, and then of course there are certain braces which have been designed by our hospital in collaboration with Department of Biotechnology. They are the braces which can really help you with mobilizing the joint. And then this was a very landmark trial, the PROFERT trial, which showed that the displaced proximal humerus fracture involving the surgical neck, there was no significant difference between surgical treatment compared to non-surgical treatment at 2 years. And in the 5 years reports of the PROFERT trial, they again continued to show, I can see the upper extremity surgeon smiling, but then this is just one perspective. And of course, she's going to talk about it tomorrow. But then there are people who believe that the reverse shoulder arthroplasty compared to non-operative treatment, the only benefit RSA has in terms of less pain perception at the cost of surgical morbidity. And locking plate synthesis, just look at the topic, why do we continue to perform a low-value procedure? So these are all perspectives, but then having said that, if you had a patient where you were in doubt whether to operate or not, I think you are better off not operating. Operate only when you are very sure about the benefit you are going to give to the patient. We have had this term when we were training, which is called bag of bones. It is still believed that it's still not all that out-fashion or out of fashion. After all, has been shown in displaced olecranon fractures, you can treat them conservatively, it doesn't matter even if it doesn't unite. And then in distal radius fracture, again it has been shown that no significant difference in the patient-reported outcome between surgical and non-surgical group. Close contact casting, this was a study in NHS, and it showed that there were greater malunions but greater infections in the surgical group. So there is certain role of close contact casting in the treatment of osteoporotic fractures also. This was my resident's mother. She had a tensile type stress fracture, which would be a indication for surgery at all times, as I understand. But she had a T-score of -5, and she had multiple comorbidities. Put her on teriparatide, and she went on to heal. So this is we published it, but then there is always another way in case you think that the surgery may be fraught with hazard of a screw breakout or not getting enough purchase. But then conservative is not an option in hip fracture, generally as a general rule, as we all understand. So general principles of fixation in osteoporotic fractures are fracture reduction, fracture fixation, preservation of blood supply, early and safe mobilization, and they do not change. So decision making is easy for diaphysial. You have to do osteosynthesis. Metaphysial, again, you prefer osteosynthesis, but for intra-articular fracture, we are moving towards replacement if required. We know that the periarticular locking plates have made life very easy, particularly for periprosthetic fractures and other osteoporotic fractures. When you plate them, make sure this was discussed for a short while in the morning. Do not leave any stress risers. You don't want a plate to end at the mid shaft or the lower third and have a stress riser and a fracture subsequently. Make sure that the plate is long, the screws are well spread out, and there are non-locking screws at the end. You can consider dual plating for the distal femur or the proximal tibia. You have polyaxial locking plate. They are really a boon. You can, this again was mentioned by Richard, nailing, try to use a large nail, and he told you 5.0 locking bolts. And of course, we have more locking options now, but splint the entire bone, that's what is important. Blocking screws can really help avoid the malpositioning or malreduction of the fracture. And then, of course, the multi-axial locking options are useful. Frank was here earlier this year, same venue a few months back, and Richard is here now. So I think this place has seen, the Goa has seen both of them talk about something related to this, but Frank did speak about the nail plate construct in Goa just a few months back. It's again a combination technique for very bad osteoporotic fractures. Then the nail plate constructs is also now being used for periprosthetic distal femoral fracture with poor quality. Just want to show you this mother of a doctor and a lawyer. She had a fracture for which nailing was done, and she sustained a fracture neck of femur sometime without even realizing it. But the lower end of the nail was like this. So they came and interrogated me for 2 hours saying that, what will you do? Will you remove the nail? What if it doesn't come out? And then when you do the hip replacement, will it go into the same track? So what we did was we took out the nail and we did this prophylactic plating before actually going ahead, left the top 2 screws drilled and took them out, and then the cemented bipolar hemiarthroplasty, and while the cement was setting, put the screws in. So we actually could come out without leaving any stress risers. So this is the message here. Never leave stress risers, because if I had not done all this and it had fractured, the treatment would have been still the same to put a plate there, but then she would not have been able to walk. So this is the situation. So we did publish it as a technical tip. Of course, we need the augmentation, which could be cement, HA-coated screws, locking attachment plates, and strut allografts. I do use a lot of strut allografts from the bone bank. You can use the calcium phosphate cements or PMMA cement, although PMMA cement does not osseointegrate and can cause some bone necrosis. But then we know that we have devices now which can help you improve your hold in the head and neck by using a cement at the same time. And then, of course, you can use the bone substitute to fill in the voids. You have injectable cements. This is my favorite. I'll just show you where I use it in complex acetabular fractures, where I do primary THR. And then you have these special devices called the LCP attachment plates, and they can really augment the stability of locking compression plates. Also in the presence of the periprosthetic fractures, you can use intramedullary fibula, you can use intramedullary plate. You need something to augment the stability of the fixation. And of course, we in India are very fond of using intramedullary fibular grafts. Some of our senior surgeons are very fond of that. Then this is something called emergency arthroplasty. It has been touched upon in the morning. There have been articles about the total knee arthroplasty for distal femoral fractures. We used to reserve it for patients with concomitant arthritic changes or where the fixation is likely to fail. We have done a lot of this work on acute total hip arthroplasty in elderly patients with osteoporotic bones. We have used cup cage constructs, and we make them bear weight immediately. The octopus cage, this was published in Journal of Arthroplasty, again for elderly patients using for the acetabular fracture. And then we have also shown that if you use modern porous metal cups, it can really give very good purchase and stability. So this is the uncle of the spine surgeon in Hospital for Special Surgery, who was visiting India and fell down and fractured, and I got a call to work on him, and I said the best thing, I think, because the head is damaged, the best thing would be to do a primary total hip arthroplasty like it was discussed in the morning. Use a trabecular metal shell. Look at all those the kickstand screws. And I use injectable bone cement with the morcellized autograft in this case, and that actually solidifies pretty quickly on the table within 15 minutes, giving a solid continuity here. And then with this and a dual mobility shell, we could make him bear weight immediately, and this is the X-ray. Similarly, osteoporotic fracture, now this is an osteoarthritic knee, and there's a fracture here. There's no point in putting implant here and then coming back for another surgery, like Richard said, coming back to operate on them again. So do what you can do for them in the first go and give them a total knee arthroplasty, and then they can be mobile and weight bearing. So other thing we must remember is that periprosthetic fractures are going to be the next fragility fracture epidemic. The increase is going to be 13% every year, with 4.3% inpatient mortality risk. Also, a short word about vertebral body augmentation. That has been quite popular, but that it has been shown that they really have nothing to contribute to the benefit of the patient and is fast going into disrepute, if you like. The rehabilitation is extremely important because it's not all that ends well. It's only what begins well that ends well. So post-fracture care is critical to long-term outcome. You want to make them immediate full-weight bear. You want to train them in balance and fall prevention because they have 2 times risk of falling again at hip fracture. At the cost of repetition, I'll tell you, I see many patients who come with a hip fracture when they have had another contralateral side hip fracture in the past. And I think the fault really lies with the surgeon who operated on the first hip fracture and never put the patient on treatment, which could have avoided the fracture on the other side. 10% of the hip fractures are the other side fractures, and I think the orthopedic surgeon is to blame for that. Now, when you operate on them, have only one aim, that they should be able to bear weight, because the geriatric patients cannot maintain weight-bearing restrictions. Of 16 patients told to comply with less than 20 kg weight-bearing restriction, only 1 could comply with it. So don't expect them to walk with weight-bearing restrictions, but if they bear weight as tolerated, that does not increase the risk of failure. And then if you restrict their weight bearing, it does lead to more adverse effects. So remember, whatever you do for them, make sure that you allow them weight bearing, and that rehabilitation will help them reduce the hospital stay, lower mortality, and the likely to be discharged to the nursing home. Next few minutes, I'll just talk about what we have to do as responsible orthopedic surgeons, because we can treat the fracture and it can heal, but really that is not enough. And the real care gap in these patients is when we fail to prevent these fractures, and these are the patients who have, it's like, you know, you saw that graph where Colles fracture led to the vertebral fracture, led to the hip fracture. If you don't intervene in time, they will have multiple fracture, and the risk may persist up to 10 years. And this is where we fail. We fail to diagnose and treat osteoporosis when the patients are with as dramatic conditions as hip fractures, leave alone the incident vertebral fractures and the wrist fractures. So that is approach for lifestyle changes, taking care of the secondary causes, and the pharmacotherapy. We have a facility in my hospital, I call it SATHI, S-A-T-H-I, which means Save the Hip Initiative, but in our local language in Hindi, it means a companion. So there, what we do is to teach the patient to improve their balls, the balance, and we have a balance and fall balance master, where they can, like a game, play on the, by shifting their weight on the platform, they can actually move a ball and actually play it like a game. I wrote this book for Indian Society of Bone and Mineral Research, which is the exercises for bone health, and it defines who are the patients who are most prone to fall. And most important of these are patients with either hearing loss or deficit vision, or who are on polypharmacy, or there was a very interesting article called Stops When He Talks. So when you are talking with an old man and you speak with him and he stops when he is talking to you, he cannot continue to speak with you when he is walking, he is the guy who is very prone to fall. So you can actually self-assess. As per this, we tell the patients to do this self-assessment to know whether they are more at fall, because the falls are preventable, and we can do everything in our armamentarium to help them improve their strength, their balance, reduce the hazards at home, vision assessment, and medication review. And there are several exercises, basically balance exercises, strength exercises, and the exercises do improve the BMD, it has been shown, and they decrease the fractures, that has also been proven, and then they actually really have long-term benefits. So that's what we need to advise to our patients, and of course yoga is now catching up. There is something called task-oriented motor learning exercise program, where you can actually use the performance for specific activities, like stepping forward, across. You can actually set their speed, you can change their direction, and all these things can help the patient gain their balance faster. And of course, there's something called hip protector, which can prevent those patients who are at high risk. I was surprised when I saw that the statistics say 18% of the Indians smoke, and we know that smoking is associated with all kinds of problems with the musculoskeletal system. So improving fragility fracture care is our combined responsibility. Just treating them and fixing them is not enough. You may have done a good job, but you have not done a great service to him if the patient keeps on coming back to you with multiple fractures. So you need to have a secondary fracture prevention, and the most important thing for that is a fracture level service, and that prevents the, because you have to identify, you have to investigate, you have to intervene, you have to inform, and then you have to also assess. So that
Rajesh.
actually helps, last couple of slides. Okay. It actually has been shown to work very well to improve the outcomes. Of course, there's medical management, the anti-resorptive and anabolic, you have to keep in mind, because if you treat it, the patient will follow it. Many orthopedic surgeons say it's not their job to give this, but then the patient only listens to the surgeon. Then of course there's a FRAX tool which can give the possibility, and there are actually ways to define high-risk patient needing treatment. Denosumab actually can be given for 10 years. There was a question about fracture healing. No anti-resorptive or osteoporotic medicine has been shown to interfere with fracture healing. I would just be wary about a shaft fracture treated with the rigid plating, which is hardly ever done, which has to rely on primary bone healing. That's the only time I would stop bisphosphonate or a case with atypical fracture. And you can give denosumab for 10 years. It can be given in kidney disorders also. And then the best combination therapy is teriparatide followed by denosumab, and you can monitor the response. There are several community-based programs. They have been outlined here, but then we must make sure that it is not just a fracture. It's a systemic disease, and it needs systemic treatment. So I would summarize by saying it's very prevalent, underdiagnosed, undertreated, and this is going to rise. You need acute management, of course, to save the patient's life, but you have to rehabilitate and give lifestyle modification, put them on pharmacotherapy, make sure that they do not fall, and then we have to have guidelines. Thank you very much for your attention.
Thank you, Dr. Rajesh. Can I request Dr. Samir to come for the next lecture? Are there any questions from the audience? Any questions? So the basic, So the summary of this was fragility fracture is not pertaining to bone, but it's a multi-system problem, and you got to really look at other systems when you're managing it. There's
Hello,
some
sir.
question. Yeah.
So osteoporotic patients which we operate, usually they are taking clopidogrel medicine for stroke or ISD. And when we start the DVT prophylaxis, that is oral drugs like rivaroxaban and all, whether both can be continued together, clopidogrel plus rivaroxaban, or
Mike.
But then you do not give both, because these are elderly patients. They are as much at a risk of having bleeding than they are having of the DVT. But in our country, it's not at all uncommon to get a patient with hip fracture report after a week or 5 days or 10 days. The first thing we do is to get a Doppler and then put them on also on the low molecular weight heparin and the foot pump and all. But make sure if a patient is reporting to you late and he has been bedridden, make sure he's not already having a DVT. But do not continue more than one anticoagulant. You know, clopidogrel, you need to stop for 5 days, but we have, in agreement with our anesthetists, operated almost immediately under general anesthesia. The patient is fit for that. You cannot give spinal anesthesia if the patient is on clopidogrel, but it can still be operated after 1 or 2 days if the general anesthesia is given. But do not give more than one. Why do you need to give anything else? Just ask them when you can start. Otherwise, put them on low molecular weight heparin in the meantime, and then switch over to clopidogrel as required.
Thank you. Thank you, Dr. Rajesh. Samir is going to talk on venous thromboembolism in pelvic acetabular trauma.
So since morning we are talking about fractures, I am going to talk about one of the complications which was neglected for such a long time in India. So it was Virchow who first identified in 1856 the basic three interacting factors responsible for development of this venous thromboembolism. That was circular stasis, endothelial injuries, and hypercoagulable state. And pelvic acetabular trauma and subsequent management tends to activate each of these three components of this Virchow triad. There is circular stasis because these patients are immobilized. There is endothelial damage while during surgery also, while during injury also. And trauma increases the thromboplastin levels. And that is why all these three factors are there, and that is why these factors. If you see the 20 to 25 of calf vein thrombi extending to popliteal, femoral, and pelvic vein causing proximal DVT. And half of these patients with proximal DVT will develop pulmonary embolism. In Western population, the following pelvic acetabular trauma, the incidence of DVT is 35 to 61%, proximal DVT 25 to 35%, risk of symptomatic pulmonary embolism is 2 to 10%, and fatal PE is as high as 2%. So out of 100 patients, if you have a pulmonary embolism, you will lose 2 patients. There are conflicting reports of differences of VT in Asian population as compared to Western. Some papers say it's 0%, some papers say 72%. And studies suggested till date that VT is not that common in Indian patients or Asian patients than in Western countries. There are studies which says the incidence is only 2.2%, 1.9%, 3%. As compared to this, there are studies which say no, it is as equal as in the Western population. If you talk about Indian population, there are few studies, one done by Agarwala, 112 patients more than 40 years of age, no prophylaxis, color Doppler was used, and incidence was 19.6%. Dr. Sharma in IGO, he published that 50% of hip replacement surgeon and 60% of knee replacement patient may develop DVT. Similarly, study done in South India, 50 South Indian patient age above 50, incidence is 28%. So this is a strong case for prophylaxis. But till date, no study was focused on pelvic acetabular trauma in Asia when we think of conflicting opinions were there, which one to believe. What about patient having pelvic acetabular trauma, which is very high energy traumas? So we did our studies in 2011. First study, 56 patients with pelvic acetabular trauma who underwent open reduction internal fixation. Mean age was 36 years old. They were all young. And all patients with comorbidity or those who were prone to DVT were excluded. Pulmonary angiography with indirect venography of bilateral lower limb was done, which was a better diagnostic tool for detection of the DVT. And these are the findings. And if you see the results, 16 patients out of 56 had radiological confirmation. So incidence was 28.6% in pelvic acetabular trauma in India. But however, if you see the clinical features, only 37% of these patients were symptomatic, rest were not symptomatic. So we should have lost 1 out of these 10 asymptomatic patients who have a pulmonary embolism. So we published these results, both the risk factors. Then there comes a paper by Staley from Bristol. He says that proximal DVT was developed in 3% when prophylaxis was given within 24 hours as compared to 22% when it is administered more than 24 hours after the injury. So it means without prophylaxis it was near about 25%, after 24 hours it is 22%. Should we give the prophylaxis? So problem in India, patient presenting late, so prophylaxis is delayed. They don't come to us within 24 hours. Usually they are polytrauma patient with head injury, BTC, BTA with relatively contraindication to give chemical prophylaxis. Only mechanical prophylaxis can be done. And till date, all the studies done were color Doppler and compression, except the PJ study, which don't give us the true picture of a DVT. So we planned a second study in 2019. All cases of pelvic acetabular trauma which were enrolled came to our NC were taken into consideration, and they were divided into 3 groups. Group A, where patient came to us within 24 hours, he was hemodynamically stable, we were able to start the low molecular weight heparin. Group B, when the patient presented to us after 24 hours, or with patient has come within 24 hours, but he has some minor issues, which was contraindication to start, and he was hemodynamically unstable, we were able to start after 24 hours. That was part in group B. And group C, which has a contraindication for these chemical prophylaxis. So what were there? There was open fractures. They come within 24 hours, but first we have to operate them, make them stable, and then we have started the prophylaxis. Similarly, blunt trauma chest, mild patients with mild hemothorax, or when ICD was put, we were unable to start the chemoprophylaxis. So you can say in our series, there are about 1 patient we have that coming to group B. Blunt trauma abdomen. In cases of hemoperitoneum without solid organ injury, major wall contusion, they were stabilized, waited for 24 hours, then we started it. So all the patients were screened by, head injury patients were screened by head scan, and they were waited for 24 hours for second head scan, and if they are found normal, then we started. So they were put in the group B. So all patients get the prophylaxis of deltaparin because it comes in a multi-dose vial, and mechanical prophylaxis and physiotherapy was given to all the 1 patients. And at day 10 to 14, we done the CT angiography, and at 4 weeks and 8 weeks, we done the compression ultrasound for follow-up. In 1 year, we were able to see 171 patients of pelvic astrum studies. There were 33 patients in group A, which were given prophylaxis within 24 hours. Group B, which was biggest group, more than 24 hours prophylaxis was started. And group C, 62, where no chemoprophylaxis was given, only mechanical prophylaxis was given. And what was the incidence? In group A, it was 5 out of 33, means 15%. Even after starting the chemoprophylaxis, there was DVT. In group B, where we were unable to start within 24 hours, the incident again was 13%. But in group C, where there were no prophylaxis given, the incident is 25%. That was as equal as what we have studied in first. So there was no significant difference between group A and B, early versus delayed, but significant high in comparison to group B and A in group C. So incidence of VT is very high in Indian patients. We have to keep this in mind. And our results is in contrast to classical paper of Stelle, where he has seen 103 patients only. Our series was 171, and he has used color Doppler. So we have also observed that there's no difference in VT between acetabulum, pelvic fractures, all or combined pelvic astrum fractures. And among pelvic fractures, transverse fractures with posterior wall are at a higher risk. Associated spine injuries, significantly more risk for this. Associated orthopedic injuries do not have any correlation with development of DVT, but however, known orthopedic injuries like BTA appears to have more risk for VT occurrence. If you have a patient with pelvic astrum fracture with BTA, you should be more suspicious about this. And injury severity score. The patient who has more than 15 injury severity score were more prone to have developed DVT, and there was no influence of sex, age, and development of VTE. Injury to surgical time. Mostly in our scenario, patient comes late. That is a significant correlation between if patient is operated after 10 days, within 5 to 10 days, and 5 days, there was a significant difference in the development of this. So we published these 2 results in JTO. So my take-home message for our paper is administration of VT prophylaxis plays a major role in VT in contrast to not giving prophylaxis. There is no difference between early and delayed prophylaxis. Giving prophylaxis is more important. Thank you.
Thank you very much, Samir. Any questions? Yeah, Richard. Can I ask Mr. Pawan Gupta to come to the stage, please? Yeah. Samir.
Great work.
Richard.
The question I had was, when you were looking at your DVTs, did you differentiate between superficial and deep?
Yes.
And was
No, but we have studies by venography only. So we look for the deep VT only.
John? Yeah.
Have you looked at any this thing for bleeding as opposed to DVT?
Yes.
When you're doing this prophylaxis?
Talk on the
Yes,
mic.
sir. We were not able to find any adverse reactions during this surgery.
Because we've had some in the elderly, not so much in the younger group that you're talking about.
Mic
Yes,
is not on.
Maybe that may be the reason. Because pelvic extraabdominal surgery, mostly patients are young patients. TKR, THR may have this bleeding issue.
Yeah, so thank you. Mr. Pawan Gupta is going to talk about stem cells in knee osteoarthritis.
Good evening, everybody. So, this being the last talk of the day, I'll try to keep it as short as possible. Let me introduce myself. I am Dr. Pawan Gupta. I am basically a hematologist by profession. And I did my hematology from All India Institute of Medical Sciences, Delhi. And I worked in the armed forces for 24 years. And now I'm working in the field of stem cells for the last 14 years with an organization known as Stempeutics Research in Bangalore. So I'm going to talk about allogenic off-the-shelf pooled bone marrow-derived allogenic mesenchymal stromal cells, which has got a trade name of STEM1, which has been recently launched by Alchem, and plus also it has got a GCGI approval for grade 2 and grade 3 osteoarthritis of the knee joint. So STEM1 is a first-in-class allogenic stem cell treatment for osteoarthritis, providing prolonged efficacy and maintains the cartilage integrity. It is a single intra-articular injection of 25 million cells, and we have a strong phase 2 and phase 3 clinical trial data for more than 200 patients, in which it shows that with at least with the one injection, it has got prolonged efficacy for 2 years. There is a decrease in the pain and plus the improvement in the function and improvement in the physical function and improvement in the stiffness with the actually minimal side effects, and most important thing is it maintains the cartilage integrity. And the whole process is developed in India. We have done the in vitro studies, we have done the preclinical studies, we have done the different phases of the clinical trial in India, phase 1 to phase 3. And then the whole process took us 14 years for the development of this product. And then actually this year we have got the GCGI approval, and they are recommended for grade 2 and grade 3 osteoarthritis of the knee joint. So why MSCs for the stem cell therapy? Because of the properties of these cells. These cells are immune privileged. That means actually they can be used across the HLA barrier without HLA matching. Why these cells are immune privileged? Because actually these cells express very low level of MSC class 1. They do not express MSC class 2. And there is a lack of co-stimulatory molecules. That means that once these cells are injected, it will not stimulate the allo T cells. So chances of rejection becomes less. And the second most important property of these cells are immunomodulatory and anti-inflammatory properties. And because of these, for the properties both of immune privileged and anti-inflammatory properties, they have been recommended for use in osteoarthritis. So what is the possible mechanism of action for osteoarthritis? It has got multimodal mechanism of action. The first actually, the first effect is it should actually reduce the inflammation. The inflammation should be controlled, which is controlled by liberation of anti-inflammatory factors like that of PGE2 and plus IgO, which actually inhibits the T cells for liberation of the inflammatory cytokines. And once the inflammation is controlled, the process of chondrogenesis is being initiated by liberation of the chondrogenic factors like that of thrombospondin 2, hepatocyte growth factor, and BMP2 amongst others, which causes stimulation of the resident chondroprogenitors, leads to the formation of the new chondrocytes. And lastly, actually these cells also inhibit the cartilage ECM destruction by the liberation by actually inhibiting the MMPs. So both the anti-inflammatory and the chondrogenic potential of these MSCs leads to the cartilage repair and formation of the hyaline cartilage. We have a strong preclinical data also available that once these cells are injected, there is a formation of hyaline cartilage within a span of 12 weeks of injection of these cells. So what is STEM1? STEM1 is a bone marrow-derived MSCs. It is a pool technology where we pool the cells from 3 different healthy voluntary donors. And the advantage of pooling are numerous. The first is it actually gives a better immunomodulatory response, a better anti-inflammatory response, and plus increased number of doses. And our lead indication is osteoarthritis of the knee joint, apart from other indications. So before we had gone for the phase 3 trial, we have done a phase 2 trial, which was a dose-finding study. We did in 4 different doses of 25, 50, 75, and 150 million cells to see that which is the most dose which can be effective for this disease. And we found the lowest dose of 25 million cells to have a better efficacy in all the efficacy parameters, which include VAS, WOMAC, and intermittent and constant osteoarthritic pain, or ICOP, by more than 30% as compared to the placebo arm. So based on this data, we have selected this 25 million cells as the most effective dose for osteoarthritis. And with this dose, we have gone ahead with our phase 3 trial, which was a randomized, double-blind, placebo-controlled phase 3 trial, which was a multi-centric study in 15 different sites across the country. We had 146 patients, 73 in the cell arm and 73 in the placebo arm. And the actual cell arm received 2 ml of cell suspension followed by 2 ml of HA, and the placebo arm received 2 ml of placebo followed by 2 ml of HA. The most important thing is that both the arms received HA, 2 ml of HA. And it was a single intra-articular injection given under ultrasound guidance. We have followed these patients for 2 years, and the primary endpoint is WOMAC composite index as compared to that of placebo arm. The secondary endpoint are the WOMAC subscores like the WOMAC pain, stiffness, and physical function, the VAS scores, and we did the MRI imaging also at various time points, which includes baselines, 6 months, 12 months, and 24 months follow-up to assess the cartilage quality, actually by doing the T2 mapping, the cartilage volume, and the cartilage thickness. So this is actually the cryoshipper in which the cells are shipped to maintain the temperature between -195 to -185 degrees centigrade, so that the viability of the cells are maintained. There actually is a cryo vial which contains 1 ml of the cell suspension. This has to be thawed at 37 degrees centigrade for 3 to 4 minutes, mixed with 1 ml of plasma lyte or multiple electrolyte solution, make the total volume of 2 ml, injected intra-articularly, followed by injection of 2 ml of HA. The role of HA is actually twofold. First, it acts as a scaffold, helps in homing the cells, and plus the second most important thing is prevents the fibroblast invasion and formation of the fibrocartilage. So it has been approved for grade 2 and grade 3 osteoarthritis in non-obese patients with BMI less than 30 kg per meter square, recommended to be avoided in subchondral sclerosis involving both the compartments, complete grade 3 ACL-PCL tear, and grade 3 complete root tear of the meniscus. So there were 73 patients in cell arm and placebo arm. The grade of OA, grade 2 and grade 3 were equally distributed in the cell arm and the placebo arm, and 133 patients completed 1 year follow-up, and similar number of patients also completed 2 years follow-up. So the primary endpoint is actually was the WOMAC composite score. So what we see is that immediately at baseline after injection of STEM1 or placebo, there is a decrease in the WOMAC scores in both the cell arm, which can be seen by the red line, and plus the placebo arm, which can be seen by the blue line. And this decrease is maintained for a duration of 3 months. The effect may be because of effect of the HA, and once the effect of HA wanes off after 3 months, the WOMAC composite score gradually increases in the placebo arm and comes to more than baseline at 2 years follow-up. Whereas in the cell arm, because of the anti-inflammatory and chondrogenic properties of these cells, the WOMAC composite score continuously decreases for a total span of 24 months. And this difference between the cell and placebo arm is statistically significant from 6 months onwards and maintained till 2 years. That means by a single intra-articular injection of 25 million cells, there is a decrease in pain, improvement in stiffness, and improvement in physical function for a minimum duration of 2 years. The same, and plus if you see the percentage change, you can see there 23% improvement in the cell arm can be seen actually by the red bars, and which increases to 46% at 1 year follow-up, and 89% of the patient improved, more than 20% improvement in the cell arm at 1 year follow-up, which is also clinically significant. Now coming to the heat map to see actual number of patients which has been improved over the span of 1 year, what we have seen is that if we look at the treatment arm, you can see maximum number of patients, there was improvement in the mean change, and there is an improvement in the percentage change in the cell arm, whereas in the placebo arm, maximum number of patients has worsened in that mean change and the percentage change. So it means more than 89 to 90% of the patient improved after giving a single intra-articular injection. Now we looked at comparison of the grades between grade 2 and grade 3 osteoarthritis, whether it is more effective in grade 2 and grade 3. What we saw is that it is equally effective in both the grades. So grade of OA has got no effect on WOMAC composite index scores, and it is equally effective in both the grades. Next, we looked at the data for the WOMAC pain scores, and WOMAC pain score also had a similar trend as the WOMAC composite scores. It actually improved by 46% at 1 year follow-up, and a similar trend of 89% of the patient improved at 1 year follow-up. And WOMAC stiffness also had a similar trend with 55% improvement in the cell arm at 1 year follow-up as compared to the placebo arm. And WOMAC physical function also showed more than improvement of 45% at 1 year follow-up as compared to the placebo arm. Again, 89% of the patient improved. Now coming to the VAS score, the VAS score also had a similar trend as that of the WOMAC scores. For that of cell arm, which can be seen by the red line, it continuously decreases 2 years follow-up, whereas the placebo arm, it increases, and the difference is statistically significant, and 81% of the patient has shown improvement. Next, we looked at the quality of the cartilage by T2 mapping. T2 and plus we measured the T2 relaxation time of the articular cartilage, which is a function of both the water content and the collagen ultrastructure of the tissue. As the increase in the T2 relaxation time is caused an increase in water or increase in hydration and damage to the collagen network. And plus we have evaluated both the medial femoral tibial compartment and the lateral femoral tibial compartment, and we have divided the cartilage into superficial, intermediate, and the deep cartilage. So what we saw is that in that of deep cartilage or the medial femoral tibial compartment, which is most commonly involved, for the placebo arm, which can be seen by the blue line, there is a gradual increase in the T2 relaxation time over the span of 1 year, and this difference from the baseline is statistically significant, whereas in the cell arm, which can be seen by the red line, the T2 relaxation time is maintained over the span of 1 year. So it means that the poor cartilage quality is seen by the T2 mapping in deep cartilage in the medial femoral tibial compartment in the placebo arm, whereas the cartilage quality is maintained in the stem 1 arm over a period of 1 year follow-up. Then we looked at the cartilage volume. The cartilage volume also increased in the cell arm at 1 year follow-up. 2 years data is being evaluated now, and this trend is seen in most of the patients. We looked at a very important biomarker, which is CTX2, which is measured in the urine, which is a measure of C-terminal cross-linked telepeptide type 2 collagen secreted into the urine and indicative of disease progression. So what actually we have measured the CTX2 in the urine at different time points over the span of 1 year, and we have seen that, as seen by the red bars, that there's a decrease in the CTX2 levels in the cell arm over the span of 1 year, as compared to the placebo arm, which shows an increase in the trend of CTX2. That means once the cells are injected, there is a decrease in the cartilage breakdown and decrease in liberation of the CTX2 in the urine. So we looked at the treatment emergent adverse events and the relationship to the study drug. So out of 73 patients, 4 patients in the cell arm had injection site joint pain, joint swelling, which lasted transiently for 1 week and treated with symptomatically and improved. So around 2 to 3% of the patient may have these treatment-emergent adverse events, which will improve within a span of 1 week after giving symptomatic treatment. So to summarize my data, SEM1 product has shown safety and efficacy for grade 2 and grade 3 osteoarthritis. Safety has been established by different clinical trials using stem cells, and the efficacy has been established in our phase 3 trial, where there was improvement in WOMAC composite index, WOMAC subscores, pain, stiffness, and physical function over a span of 2 years, and plus the VAS scores also improved over 2 years, and cartilage quality is maintained by T2 mapping, an improvement in the pro-inflammatory marker HSCRP, anti-inflammatory marker IL-10, and CTX2 in the urine. So STEM1 has been approved by GCGI for grade 2 and grade 3 osteoarthritis of the knee joint. These are actually a few of the publications, and our phase 3 trial data has been accepted for publication in the American Journal of Sports Medicine. So actually the product is allogenic off-the-shelf pooled bone marrow-derived mesenchymal stromal cells for grade 2 and grade 3 osteoarthritis. The product has been developed by Stempeutics along with the help of Alchem for the last 14 years. And plus the product is based on the patented Stempu cell technology. This has been patented across 18 countries in the world and available at the brand name of STEM1. This is a small video which will show that how actually the cells will be shipped. This is the cryo shipper. You can see the temperature minus 196 degrees centigrade, and this temperature is maintained by using the liquid nitrogen gas. The person should open it by actually wearing these cryo gloves, and you can see the fumes of the liquid nitrogen gas. Then gradually we can take out the canister containing the cryo box, which contains a single vial of the cells, which is a cryo vial containing 25 million cells in 1 ml of actually the cryopreservative suspension. This has to be thawed in a preheated water bath of 37 degrees centigrade, and this has to be heated gradually over a span of 3 to 4 minutes. This will be completely thawed, and then we mix it with 1 ml of plasma light A, making a suspension of 2 ml, and then this total volume of 2 ml is been injected intraarticularly, followed by 2 ml of HA. This is the vial is been opened, and this will be mixed with plasma light A, and the total volume will be 2 ml, which will be injected. Thank you very much.
Thank you, Dr. Pawan. Are there any questions? I will ask you one question. In the study that you did, there are some 8 patients who were withdrawn from the study. What was the reason?
Actually, they have been withdrawn because of actually various reasons. They were lost to follow-up, and one patient died because of COVID, and because of these reasons, they were withdrawn actually from the study.
Okay, thank you. So there's some question from the audience.
Cost of it, and after 2 years, what do you do?
So we have the data for 2 years now, just now.
Cost first.
Cost, for the cost of the drug to the patient is 1.25 lakhs.
One more question from Dr. Sabnis.
And then after 2 years, what do you do?
Do you repeat the injection after 2 years?
As of now, we have the data for 2 years, and we are also following a subset of the patients after 2 years also. But by seeing the data, which was statistically significant compared to placebo arm even after 2 years, so I don't think that immediately after 2 years they may require a second injection. So it may be that after 3 or 4 years or 5 years they may require a second injection.
My question is, you stress about injection should be given under ultrasound guided. Why it is so? Because we'll be giving very regular intra-articular injections.
Yeah.
Why you talked about ultrasound?
Yeah, agreed. Yeah. So actually we have discussed that, and plus recently there has been publication also where they compared by giving an intra-articular injection by experts, which has been blinded injections, and compared to under ultrasound guidance. If the injections are being given intra-articularly blinded, then it is seen that the success rate is 95%, whereas if it is being given under that ultrasound guidance, then the success rate increases to 98 to 99%.
I think 3% doesn't matter. To go to a ultrasonic clinic is difficult.
This is
Yeah.
Yeah.
Okay, thank you.
Yeah, Dr. Sabnis? Question,
Hello.
yeah.
Hello.
Dr. Dilip, give him that mic.
Yeah, so for a total of out of 146 patients, 89% of the patient had been benefited, and 10 to 11% of the patient did not get benefited.
Yeah, there's a question from the back. Yeah.
Hello, hello, hello.
Yeah, please go ahead.
Sir, I have to tell you that I have read the trials of Synovis intra-articular injections, depending on the molecular weight. The higher the molecular weight, the better is the result. Now, when you are trying to do a trial of stem cells, and you also know that Synovis also gives relief, why combine? Is there any protocol? Why combine? Because we want a clear result of stem cells. Nowhere else something is combined for stem cell results.
No, but he showed
Here
that
you are
it
trying.
acts like a scaffold.
So,
who says?
He said it acts like a scaffold.
Take it from them. You have to take it from them.
So,
you have to have a scientific proof that you
yeah.
have to use it.
So actually to answer your question, there has been a study published where they have used the stem cell alone and stem cells along with HA, and the data which has been published, which has shown that if we use the stem cell along with HA, the efficacy is much better, which is significant as compared to that using only cells alone. And plus the similar data we got from our preclinical studies also, where we had a separate arm for the cells alone and compared with cells with HA. And we have shown that cells with HA had a better efficacy as compared to that of cells alone.
May I ask, with placebo also did you give HA or not? And
Yes,
which
yes.
HA did you give?
Yes,
which
yes.
HA?
Yeah, absolutely correct.
Hyaluronic acid, which one? Which variety? Which
So
molecular weight?
for the HA which was used was a mid-molecular weight with a molecular weight between 500,000 to 730,000 Daltons.
Why not Hyalgan GF20, which is supposed to be the best?
We have used that because we have used actually different types of hyaluron also, and we saw that using a mid-molecular weight, which has been used, shows a better efficacy. For that reason, we have chosen a HA of a mid-molecular weight.
Okay, thank you.
Yeah. So
Your own injection,
can
we
I
had our own
request the
yeah.
faculty to please come here? Thank you, Dr. Pawan.
Yeah, thank you very
Please stand here. Dr. Faculty to be...
Yeah, I would request Dr. Rajesh Malhotra to come on stage. And I would request Dr. Ram Prabhu to felicitate Dr. Rajesh Malhotra.
Dr. Ram Prabhu. Dr. Ram Prabhu, can I put one more question to Dr. Pawan Gupta?
Sorry, someone is asking some question. Dr. Rajesh Malhotra, sir. I would request Dr. Dunbar to felicitate Dr. Ram Prabhu. Thank you. With this, we come to end of day one. It was very good day in terms of discussions, academics. Now, after academics at 8 p.m., we are having gala dinner along with entertainment in this hall only. So I would request all of you to come by 8 p.m. in this hall. And tomorrow morning, our session starts at 9. So again, I request everyone to be present by 9 a.m. tomorrow morning.
I request all faculty to come on the dais for a group photograph.